Use the speakers and go to the topics, please. Thank you.
It's a great pleasure to be here with all of the dignitaries and experienced faculty. First, I would like to invite Dr. B.S. Ramakrishna, Director, Senior Consultant, Medical Gastroenterology, Institute of Gastroenterology, Hepatobiliary Science and Transplantation, from Sri Ramchandra Institute of Medical Sciences. Dr. Ramakrishna is an alumnus of Christian Medical College, Vellore. He joined the faculty of CMC and retired as head of Department of Gastrointestinal Sciences. He has also worked for several years abroad in Australia, Bahrain, and USA. So in 2013, he joined the SIMS hospital. So his basic expertise is in inflammatory bowel disease, small bowel disease, pancreatitis, and therapeutic biliary and pancreatic endoscopy. And his membership as an illustrious membership and honors and awards. So welcome, and it's a pleasure to listen to you, sir.
Thank you very much, chairpersons, and thank you to Dr. Kiran Peddi for inviting me to this excellent hospital and to be here today. So over the course of the next 20 minutes, I think, I'll talk about the pathogenesis and pathophysiology of IBD. And the talk that was given is actually pathophysiology, but I thought I'll focus more on the pathogenesis instead, because that's something that all of us are troubled with. So what is the basis of inflammatory bowel disease? Essentially, there are 4 things that you have to keep in mind. One is that there is an overly aggressive T-cell mediated immune response, which is to specific components of the intestinal microbiota in genetically susceptible hosts, and the disease is initiated by environmental triggers. Now, I will deal with each of these very briefly. I cannot go into too much detail given the shortage of time, but just to give you a flavor of what causes IBD. So let's first look at immunity. I think to people who are really not very immunologically oriented, so here there's innate and adaptive immunity. Innate immunity is there in all organisms. It's constitutive. The receptors are cell-bound. They recognize molecular patterns which may be alien or self, and the cells are macrophages, natural killer cells, and non-professional antigen-presenting cells. Adaptive immunity is acquired, and it can be immediate or delayed, and the receptors are both within the cell and may be soluble. Recognition is through antigens, and the mediate and the constituent cells are the T cells and the B cells that you're all familiar with. So let me also introduce the concept of oral tolerance, because this is central to IBD. So Wells and Osborne showed this first, with that if you feed protein orally and then challenge the animal parenterally with the same antigen, you'll have a dampened systemic immune response to the antigen. And how does this occur? We need to look briefly at the intestine and the bacteria and immune cells there. This cartoon shows the epithelial cells of the intestine with villi. On top of that, these orange things which you see there are bacteria. They represent the common cell flora. And below the epithelium, in the lamina propria, there are dendritic cells, there are antigen-presenting cells, and naive T cells. And these dendritic cells sample molecules from the bacteria, and then they interact, and this basically via innate immune interactions. The naive T cells are then guided to become Th1, Th2, Th17, T regulatory cells, and so on. So again, just to look at the basis of oral tolerance, if you give an antigen orally, and via the gut-associated lymphoid tissue, if you give a low dose, it induces T regulatory cells which dampen inflammation. If you give a high dose of the antigen, it deletes the appropriate T helper 1 cells, and so there's a clonal anergy or a clonal deletion, and both of these lead to oral tolerance. And IBD is essentially a loss of oral tolerance. So if you lose this, this is when you get IBD. Of the innate immune receptors, basically there are two families which determine the balance between tolerance and inflammation. And you will all have heard these names, the NODs and the TLR family. I'm not going to elaborate on this, just to give you an idea of what's going on here. So this essentially is, tells us, is a cartoon, which is again from a little while ago, which shows how the commensal flora of the intestine interact with the innate immune cells and thereby influence adaptive immunity and thereby dampen inflammation. They expand the numbers of T regulatory cells, essentially. There are a number of immune models which tell us that T cells are important in the genesis of colitis. And so I'm not going to go through these. And this is how our understanding of the pathogenesis of colonic inflammation began. That is with IL-2 knockout mice, with IL-10 knockout mice, and so on. And then they could find that they could transfer to an animal the propensity to develop colitis by transferring the appropriate T cell subsets. And this again is a cartoon just to show you a current understanding of how these cells here, okay, so I'm not sure if I show it here, but sorry. So in any case, here you have on the left-hand side the intestine, and then the epithelium, and then the lamina propria on the right, and the cells which are there within that, essentially to show you that there are a number of mediators there which are shown on the right-hand side panel, and an understanding of how these mediators lead to the secretion of various cytokines which then lead to disease. So in a nutshell, disease initiation in IBD is a function of the innate immune response. Disease perpetuation is a function of the adaptive immune response. And augmentation of flares of disease involves both innate and adaptive immunity. What about genetics in IBD? Twin studies have shown, and we've known this for a long time, that there's a genetic basis for IBD. And if you look at monozygotic versus dizygotic twins, you'll find that in monozygotic twins, the propensity for both of the twins to develop colitis or Crohn's disease is higher than in dizygotic twins. So these large genome-wide association studies were done quite some time in the past, and there are quite a number of susceptibility loci for IBD. But in essence, the disease variance explained by all these loci accounts only for about 15% of Crohn's and about 7.5% of ulcerative colitis. But what we understand from this is about the pathogenesis of IBD. A number of the genetic defects are related to the autophagy pathway in innate immunity, like ATG, 16L1, the IRGM, NOD2, etc. And essentially, they are associated with impaired destruction of intracellular pathogens or xenophagy and increased expression of inflammatory cytokines. So in the Indian scene, and again, all this data that I'm showing here is from our group in CMC. Essentially, what we found that there are virtually no defects in NOD2 genes in Indians. HSP70 was not implicated. IL-23 receptor was not implicated. The toll-like receptors were not implicated in Indian IBD. what we found was that the TNF-SF15, IRGM, and ATG16L1 were associated with disease, with IBD in Indians. So the third player that I talked about, or the third factor, is the gut microbiota. We know that you need bacteria to develop IBD. So there are a number of immunodeficient animals which do not get IBD. Like IL-2 deficient mice, if you keep them bacteria free, they don't get IBD. And there are some models where you can reduce IBD by giving antibiotics. So looking at the literature worldwide, it's actually fairly confusing. There's a whole lot that's available, but if you kind of condense it, there are some aggressive bacteria and there are protective bacteria, and I put the top three at the top there, which are the ones which are shaded, and the ones which are expanded in IBD are proteobacteria, which includes most of the common pathogens and things like E. coli and so on, and then Ruminococcus nevus. And the ones which are reduced in IBD are Bacteroides fragilis, the Clostridial groups 4 and 14A, which are very important in carbohydrate fermentation and short-chain fatty acid generation, and this bacterium called Faecalibacterium prosnitzi, which a lot of you would have heard about. So the Indian data on microbiome changes in IBD comes largely from our group and from Dr. Vinita Ahuja and AIIMS. And so basically what we found was that there are some which are increased in ulcerative colitis, some which are increased in Crohn's, some that are reduced in ulcerative colitis, and some that are reduced in Crohn's. It doesn't necessarily gel with what is available in the literature internationally. The third factor that we talked about, I'm sorry, here actually the fourth factor is environment, which is the regulatory factor here. So one of my contemporaries, Dr. Jayanti, worked in the UK, in Leicester and so on in the 1980s, and she showed that incidence of Crohn's disease in Indian immigrants to Leicester was slightly higher in first-generation immigrants and markedly increased in second-generation immigrants. And particularly in the second-generation immigrants, it was higher than you would have expected in the Caucasians. And this was another study there. They took all people born on a particular day in the UK and looked at them in terms of whether they were originally from Britain, originally they're from South Asia, and they found that second-generation Asian, Indians and South Asians had a significantly higher risk of developing IBD than Caucasians. So how do we explain this? There's something called the hygiene hypothesis. And this was, it's just kind of talked about way back, but this is from an article in 2002, where they showed, for instance, just graphically, it's just a hypothesis, mind you, that in 50 years preceding this, in the second half of the last century, all the infective diseases, infectious diseases had declined in incidence. At the same time, a number of auto-inflammatory diseases, I'm not calling them autoimmune, they're auto-inflammatory diseases like Crohn's disease, multiple sclerosis, type 1 diabetes, and asthma, they increased. So what are the factors that are responsible for this? And as I said, this is a hypothesis, and nobody, it's difficult to prove or disprove these hypotheses. So some of the factors which have been implicated are frequent infections, intestinal infections, and the mechanism would be altered immune responsiveness. For instance, helminth infections steer the immunity towards the T helper 2 kind of response. A high prevalence of helminth infection is therefore one of the things which was blamed. Traditional diet and lifestyle, which led to increase in beneficial commensal bacteria. A high sugar and refined flour intake, which increased the incidence of abundance of aggressive bacteria. And refrigeration, with the growth of cell wall deficient organisms and refrigerated food. These are some of the factors which have been blamed for this. In fact, one of my colleagues, it was somebody, some of you might know him, Dr. Mohandas, who's a cancer gastroenterologist. And he suggested perhaps it is the lack of iron, that we were iron deficient and now we've become iron abundant, and therefore that's why inflammation is increasing here. Okay, so another factor to look at is the epithelium. And there are a number of epithelial abnormalities which have been reported in inflammatory bowel disease. So we have scaffold proteins, transporters, tight junction proteins, all being reported as being involved in subsets of patients with IBD. And of particular interest, so since I worked with a surgeon called Bill Rodiger, many years ago, looking at a metabolic theory of ulcerative colitis, that ulcerative colitis develops because the epithelium of the colon is unable to metabolize butyrate, which is its major energy source. And so in relation to that, it's been shown that certain mitochondrial genes are defective in some patients with ulcerative colitis. I don't know if any of you would remember one of the State of the Union addresses by Bill Clinton many years ago, when he claimed that we've solved the puzzle of ulcerative colitis. Essentially that there's a small subset of patients that had the mitochondrial gene abnormality. So let's very, very briefly look at some mechanisms leading to IBD so that you'll see how this all gels together. So one of the things that was very nicely described is the connection between ileal Crohn's disease, smoking, NOD2 abnormalities, and adherent invasive E. coli in Europeans with ileal Crohn's disease. The person who described this unfortunately died early, and she was actually a passionate researcher in this. But essentially what they found is that these AIEC replicate extensively within macrophages, leading to TNF-alpha secretion. And if you have a NOD2 genetic abnormality, and if you're a smoker, then you might develop ileal Crohn's disease. And so that's one example. Another example is Ruminococcus nevus and Crohn's disease. It's there in most of our guts, and it produces rhamnose-rich polysaccharides. The abundance of this bacterium increases if you eat a lot of starchy foods and sugars. And this activates TNF-alpha secretion. So there's another mechanism which has been described. A third mechanism which has been described is Klebsiella in the mouth. So poor dental hygiene and Crohn's disease may be linked, and they colonize the ileocecal region and produce pro-inflammatory cytokines. So what is important is to understand that IBD is a whole spectrum of diseases. So there's the human genetics on one hand, and then there's the microbial genetics of bowel on the other hand. And if you can, I mean, here on the left-hand side is a fecal microarray that we developed some time back, which showed that you can identify differences between patients, between normal people, with patients with ulcerative colitis and patients with Crohn's disease. And if you can match that up with the genetic abnormality in that particular individual, then potentially this can lead to personalized medicine. So I will just wind up by saying that IBD comprises a number of different conditions, which is based on the interaction between microbes, innate immunity, and the epithelium. And understanding the specific microbe-human interactions can lead to precision medicine in IBD. And this is just to show you a Venn diagram, which you'll have. I mean, here it's IBD up to IBD4, but there's IBDN. Thank you so much. Bye.
Thank you so much, sir. Any questions you want to?
Sir? For that excellent presentation, you can see a lifetime of work has gone into that. From a pathologist's perspective, it's always been fascinating We tend to club UC and Crohn's together, but histologically the differences are fairly fascinating. Just from, for instance, a biopsy perspective, we know that if the inflammation doesn't cross the muscularis mucosa, it is UC. And of course, typically the pattern of infection. With Crohn's, you have transmural inflammation, and with you have rectal sparing, whereas with UC, it starts on the rectum and goes upwards. So there must be subtle differences maybe in all these three factors which cause these kind of maybe phenotypic or pathological differences, but I've never been able to find a lot of information on what is it that causes these different patterns of inflammation.
So that's actually going to wait for huge amounts of data to be collected and large data analysis that needs to be done. I think AI might help you eventually.
Yes. Thank you, sir.
That was a beautiful talk, a really beautiful overview. A lot of the differences you highlight are those between South Asian populations in terms of genetics, environment, and the microbiome, and what we have in Caucasians. There are a multitude of different pathogenic pathways seemingly leading to these highly heterogeneous phenotypes that we see in the clinic. How do you explain that with such different backgrounds, genetic, environmentally, and microbially, actually the disease we see in the clinic is pretty much the same disease? Yes, there are differences between Asian and Caucasian IBD, but it's pretty much the same. Yet no NOD2, no IL-23 mutations, different microbiota, etc. What are your thoughts on this? You must have thought about this for a long time.
So essentially, the intestine lives in a state of controlled inflammation. This is something that we've known about for decades. The intestine has a huge surface area. It's exposed to this constant microbial fluxes there. And the immune system is constantly trying to interact with that. In tropical environments, the level of contamination is high in the intestine. So you have much more inflammation, but it still is controlled. And for the average Westerner, who lives in a much more hygienic environment, there's very little inflammation. But eventually the end organ, it's in a sense, it's like how you would probably develop chronic kidney disease. I mean, the morphological patterns of response are finally probably fairly limited. And so whatever it is that causes the inflammation eventually leads to a pattern of damage which looks more or less uniform, but the genesis is different.
So you're talking a combination of hygiene and also of lack of tolerance, I guess.
Absolutely,
over time.
yes.
Yeah.
Thank you so much, sir. It's a great, wonderful lecture. It's my great pleasure to introduce Dr. S. Anuradha. She is the Director and Chief of Pathology at Asian Institute of Gastroenterology in Hyderabad. She has a tremendous experience of 17 years of experience in pathology, and she's a best friend of all of us. She's the Joint Secretary of IMA. She published 45 publications in peer-reviewed journals. She's a key reviewer of Indian Journal of Pathology and Microbiology, and she has been trained for a number of countries in UK and as well as Wisconsin University as well as USA. She delivered great lectures in national and international scientific communities. Please go ahead, Dr. S. Anuradha, madam.
Good morning. Good morning to all the chairpersons and all. Thank you, sir. The outset, I would like to thank Dr. Kiran Peddi and the entire Yashoda team for inviting me here. Dr. Kiran had asked me to talk on histopathology of IBD, and as we know that as histology is the main crucial diagnostic workup which you do for diagnosis of IBD, I would like to present what are the morphological features which we tend to see based on which we come to a diagnosis, and how we rule out the non-IBD colitis or how we rule out the mimickers of IBD. So as we all know that the biopsy of IBD is done to confirm the diagnosis, to look for disease flare, to grade the disease activity, to look for superimposed infections, and of course to rule out any dysplasia or neoplasia in long-standing conditions. And also there are many histological features which are important predictors to predict the outcome and further management. So there are some indicators on the histology which will give an idea on whether the patient is going to relapse or require hospitalization, and what are the side effects of the drugs. So as you know, since IBD is a complex disease with a lot of interplay of environmental and host factors, it's not a diagnosis based only on histology, so it requires a teamwork from the endoscopist, from the clinicians, from the radiologists, and how the patient responds. So all this information is very crucial. So before we understand what are the morphological features, I would just like to show a few pictures to say how we say when it is active, when it is chronicity. So when we get a biopsy, the most important step is the orientation of the biopsy, and a well-oriented mucosa is like the racks of a test tube where all the crypts come parallel to each other and rest on the muscularis mucosa, as you see here. And we need to know what is normal, first of all, before we say what is abnormal. So many a times when a biopsy is given, we tend to overdiagnose or underdiagnose the morphology. So first of all, we need to know that what is normal on the right side need not be what is normal on the left side of the colon. And there are important features like the cellularity is more on the right side, and Paneth cells are common on the right side in transverse colon, and beyond that in the left side is the metaplasia. And crypt distortion, when we use the term crypt distortion, we should know that it's a word to be used when more than 10% of the crypts are distorted, and normally you can have some amount of crypt distortion in the rectum in the site of innominate grooves. So avoid overdiagnosis of the word crypt distortion, based on which we are going to say chronicity and label a person as IBD for lifelong. And the normal variations in the colonic histology are, other than the absorptive cells and the goblet cells, which are more common on the right side, we also have to look at the inflammation, and the intraepithelial lymphocytes are more on the right. As I already said, Paneth cells are more on the right, and lymphoid aggregates are more on the right, and eosinophils are more also on the right. And lymphoid aggregates, more than 2 lymphoid aggregates, is also again a feature of chronicity. So now when we say IBD, so we are going to divide whether it's an active disease or whether it's a chronic disease. So when we say activity, we are going to look at the inflammation, and that is neutrophils. So we are going to look at whether there is cryptitis, that is inflammation within the crypts, or crypt abscess, or inflammation within the lamina propria, and then look for the epithelial damage, erosions, ulcerations. So when is the term that we are going to use chronicity? So when you have architectural changes, or when you have metaplasia, or significant inflammation, and this is very important when we say that there is chronicity. And if you see the follow-up of a patient, the chronicity will start only after 7 days. So the first 7 days, you may not have chronicity, so you may miss early IBD. So this history of the patient symptoms is also very important. And when we say architectural changes, we have to look at the distortion, the branching, shortening. So I will show it in the slides below. So when we say activity, so this is what is called the surface erosion or ulceration. You have the cryptitis and the crypt abscess. So these indicate activity, which can be present even in an acute infectious colitis. So it's not that it is the indicator of IBD. And here you have mucin depletion, which is very important, which occurs, that is the goblet cells start depleting. So you'll have the columnar lined epithelium, and sometimes this can be overdiagnosed as atypia. So you have to be very careful that you don't overdiagnose regenerative atypia in a background of marked ulceration. And then metaplastic changes, that is the pylori gland metaplasia or the Paneth cell metaplasia, which is important metaplastic changes. And if you see this picture here, so here if you see that there's no longer the parallel crypts, the crypts are all distorted, they are of varying sizes, varying shapes. There is marked loss of the crypts, so there's marked expansion of the lamina propria. You see the lamina propria is very busy, it is blue. So the next step is to evaluate what is the inflammation in the lamina propria. So here you can see there are a lot of lymphocytes, and also the location of the inflammation is very important. Normally you have top-based inflammation, but once the inflammation starts coming down to the base of the crypts, or there is the basal plasmacytosis, it's very important for a feature of UC. So here you have cryptitis, crypt abscess, crypt budding, branching, loss of crypts, shortening of the crypts, and you have a basal inflammation. So all these are features of chronicity. And then sometimes we use the term focal active, mild active. So what is focal active? When you have only inflammation of an occasional crypt, and that is very, very important when you're trying to evaluate Crohn's, and very important when you're evaluating your duodenal or gastric biopsies, because that might be the only pointer of an involvement of the biopsies when we're talking about IBD. And then when we get the endoscopic findings of an aphthous ulcers, so an aphthous ulcer is when there's erosion of the overlying epithelium and a lymphoid aggregate or ulceration replacing the mucosal lining, as you can see in the second picture. And then you can sometimes see ulcers. So when you see ulcers, it means it's an indicator for Crohn's. And this is very important when you're thinking of Crohn's versus UC in your biopsies. And then we have to grade whether it is chronic mild active or chronic inactive, or it is quiescent colitis, which is very important when you are dealing with the follow-up of the biopsies. So what are the pitfalls we get when we have incomplete history or incomplete colonoscopic findings? So this is a 27-year-old female who presented with intermittent fever, abdominal pain, weight loss, colonoscopy showing multiple nodules from sigmoid colon to transverse colon with a stricture in the hepatic flexure. So what could be the endoscopic diagnosis here? Probably IBD. So then we got multiple biopsies, and this is from the hepatic flexure. You can see that there is variation in one bit to the other bit. One bit is showing marked chronicity, the other bit is showing subtle features. And this is from the transverse colon, which is again showing mild chronicity, cryptitis and cryptapsis. And this is again from the rest of the colon, which is same showing chronicity. This is again from the sigmoid colon. So again we are saying it is chronic active colitis. So then what is the diagnosis? So obviously from the pathology point of view, we might say chronic active colitis, probable it is IBD. But then we don't know what is the status of ileum and rectum. We don't have any history of treatment. There was no evidence of basal plasmacytosis or metaplasia in the previous biopsy. There were no granulomas, necrosis or parasites to point out towards any specific etiology. So as a pathologist, I'm not able to differentiate UC from Crohn's here, nor am I able to exclude infective. And it is wrong on my part to label it as indeterminate. And then there was also the TB PCR, which was positive. So the patient was initiated on tubercular treatment. So this is just to show that sometimes if we don't have the adequate history, we might wrongly label it as chronic active and label him as an IBD case. So the factors which are very crucial to reduce the pitfalls is get adequate history, get the scoring systems, get all the multiple biopsies from different sites according to the protocol in different labeled containers, so that this will help us to evaluate the distribution of inflammation. It will help us to evaluate the granulomas. Please do not look for cost and put all the biopsies in one bottle. Then there's no point of doing multiple biopsies. And it's very important that you give us all these symptoms and duration within the protocol and the proformas. So as I said, the most important feature was to differentiate the acute self-limiting colitis from IBD. And so if you see in a study, normal architecture is present in almost 85% of the acute self-limiting colitis, whereas in IBD, you have distorted gland features, your branched glands, your villiform surface, and mucin depletion can be present in both. Reactive hyperplasia can be present in both. But basal plasmacytosis is said to be very important in early IBD. So when we have features of overlapping, the pathologist should look for in presence of basal plasmacytosis and give a pointer that probably we are dealing with IBD UC. And then for Crohn's versus UC, when we get multiple biopsies, the role of pathologist is to see where all the 5 bits in one area showing uniform or diffuse inflammation, that means we are going towards UC. But if the 5 bits from one area are showing patchy involvement as in the previous bits, I have to think of Crohn's. And then we have to take multiple serial or step sections because the granulomas are sometimes not evident in the initial sections. So we have to take multiple sections, and also it is not necessary that all your biopsies can show granulomas. And granulomas in Crohn's are non-necrotizing, they are microgranulomas, they are sarcoid-like, very poorly formed pericryptal granulomas, and they are present in any layer, including the lymph nodes. So this was a lamina propria granuloma. Whereas a Cox granulomas are more large, multiple, confluent. You can have necrosis, but usually they are associated with giant cells. And another important factor is they are submucosal granulomas, and they are associated with a disproportionate submucosal inflammation. Disproportionate meaning the amount of inflammation in the submucosa is much more than the mucosa. So based on this, when we see a granuloma as a pathologist, we try to differentiate whether it's a Cox granuloma versus a TB granuloma. And then there are also many artifacts which mimic a granuloma, so a pathologist has to be careful that we don't overdiagnose the germinal center of a reactive lymphoid follicle or a cutting of a pericryptal fibroblast or a clustered collection of smooth muscle cells as granulomas. And TIG, we did a study whether we could do a CD73 on the granulomas to differentiate whether they are TB versus Crohn's, and this pilot study showed that CD73 could be helpful. But still, as we know, that there is still a lot of diagnostic dilemmas in Crohn's versus Cox. So the pathologist should avoid using the term indeterminate colitis on the biopsy specimens, and instead use the inflammatory bowel disease unclassified terminology and only use the term indeterminate on surgical specimens. And this indeterminate colitis is not a real diagnosis, and the reason to use this terminology is when there's overlapping features because of fulminant colitis, or you don't have enough data of diagnostic criteria, failure on part of the pathologist to identify the hardcore diagnostic criteria, or to identify the pathological variants, or to recognize the IBD mimics. This is, or based on the IBD diagnosis on the pouch complications. And never try to change diagnosis of IBD when you get a pouch biopsy and mislabel it, because you should be aware of pouch complications as well. And also, you should know that there are unusual variants of UC which can mimic Crohn's, and there are also subtypes of Crohn's that mimic UC. So you have a superficial UC like Crohn's, or you have ileitis in UC, or upper GI involvement in UC, or you have these pseudogranulomas in UC. So avoid mislabeling. Just to show, we had one patient here, a 31-year-old male with ulcers. It was a large, deep, clean ulcer. A diagnosis of infective versus IBD is made. And as you can see here, the architecture was not much deranged. But if you see, there's some large cells in the lamina propria, and we have no history of immunocompromised status. We don't have any history of treatment. So based on these large cells which are showing anisonucleosis, and we went ahead and did the IHC, and this is positive for CMV. So always keep in mind the look for CMV, and it's not necessary that the entire slide should be ulcerated or bizarre to look only for CMV, or the clinician should give you a history. And then there are many other conditions which can mimic IBD. So that is when you are not able to recognize the classic features. This is a 34-year-old male with gastric ulcers and duodenal ulcers. Patient went to umpteen number of places, and all places showed that the endoscopy was very bad with friable mucosas and very deep ulcerations. So biopsies were done from duodenum and stomach. This was the duodenal biopsy, and you can see here there is chronicity. There is villus shortening, there is crypt variation, there is crypt shortening, there is basal inflammation, and also if you see in the submucosa, the arrow points to a granuloma. So in this concept of a young patient, the idea would be to think about Cox, right? So, or is it Crohn's? So what is this? What could be the clinical diagnosis here? And then the clinician said he's not responding to IBD treatment, he's not responding to Cox treatment. And then when we took serial sections, we found something in the lamina propria. And you can see that on deeper serial section, you can see that there's a worm there, and the crypts are showing many larval forms of strongyloids. So this was strongyloids which was involving the duodenum, and the gastric biopsy was also showing many larval forms. So this was a strongyloids case mimicking as IBD. Sometimes you have clinical and colonoscopic findings suggestive of IBD, but then microscopy is not so. This is a 59-year-old female with male chronic painful diarrhea with large serpiginous longitudinally placed ulcers with skip involvement with a provisional diagnosis of Crohn's. And we have got biopsies from the ileum and ascending colon. They look normal. Transverse colon and descending colon. There's ulceration in the descending colon, but otherwise if you see the rest of the mucosal architecture, it is normal. All uniform crypts, there is no chronicity. And then when you go to those ulcerated areas, you are seeing some large cells with ingested with RBC within them. So these are the trophozoites of amoeba. So look at the edges of the ulcer and always keep this in mind and do a PS, and you will find these amoebic trophozoites which will be missed, and you will miss the diagnosis of amoebic colitis. This is a 70-year-old male. He has a history of pneumonia. He was treated with piptazine, levofloxacin, and he was discharged, and patient went home, then came back with diarrhea, and he had 6 to 8 stools per day. So this is the mucosal endoscopic picture. Now this history is very important that you translate it to the pathologist, because when we have a biopsy like here with a mushroom-like erosion, it's easy for me to say, okay, I'm dealing with pseudomembranous colitis. But when it gets cut and this mushroom gets cut and detached, the pathologist would mistake it and just say active colitis. So we might miss out in giving you the diagnosis of pseudomembranous colitis, so treatment history is very important. This is an interesting case of a 77-year-old male who had pancolitis. He was going all around, and he had multiple sigmoidoscopies which showed severe serpiginous ulcerations. So what do you think based on this? IBD? So yes, it was IBD. He was started on treatment. He was given infliximab. He was given steroids. There was no response. So he was stepped up to infliximab. So every time he went to a new doctor, the endoscopy was being done. The picture was bad. So he was being changed medication to medication. And then these biopsies were also taken. So if you see these biopsies, you have some amount of subtle architectural changes. You have cryptitis. You have cryptapsis. You have some inflammation in lamina propria. Okay, I have some basal inflammation. So even I was confused, and we said, it's looking like IBD, but I'm not having all the criteria to say IBD. I said, probably the medication is changing the morphology, and so I'm having a half-treated case of IBD. But then my clinician said, no, it is not IBD because he's being long treated. There's something which we are missing. Can we again look back? Can you evaluate again? So we again saw, we said, okay, the only striking point is there's a lot of crypt apoptosis. So we said, okay, could there be any other drug that this patient is on? Then a detailed history was taken, and then they thought, okay, could it be a treatment-resistant IBD? Then when they took history, they found out that he's on long-time treatment with levodopa. So this has been causing the drug-induced changes. Patient was stopped on levodopa, and after 28 days of stopping the medication, you can see that there's near complete resolution of the symptoms. So a drug-induced colitis is one great mimicker of IBD, and the pointers on pathology should be, you should look for some eosinophilic infiltrate, which was not present in this patient, but you can have marked apoptosis, or you can have melanosis, or you can have cytoplasmic vacuolation, or increased intraepithelial lymphocytes. And when we get IBD, it's also important that we use some scores. So you can use the GBO score, which is very complex, which is not practical on a day-to-day basis because there's so much of scoring, or you can use the Nancy score, or you can use a simple score like the HARPAS, which takes only 3 parameters, whether it is inactive or mildly active, where based on the intraepithelial inflammation by neutrophils, or if there is erosion. So it reduces inter and intra-observer variation, but a pathologist can use this scoring only if they get the proper details from the endoscopist that yes, it is a case of IBD, otherwise we would be wrongly labeling it, and this can be used for all the follow-up of the patients. And as you know, there are many studies which are going with an intent for treat to target in UC as well as in Crohn's, and earlier the histological healing was not given any relevance, but now we know that they are histological parameters, and the concept of histological healing is very much in all your studies. And so what do the histological outcomes look like? So the indicators of relapse on histology are, if you have the basal plasmacytosis, mucin depletion, cryptapsis, and neutrophils. So the pathologist should make a point to mark all this, and also persistent active inflammation and loss of crypts. And in Crohn's, the most stringent definition is normalization of the mucosal histology. So you should not have any erosion, ulceration, epithelial damage. So I would like to conclude my talk by saying that a diagnosis of IBD by a pathologist is based only when we have the complete endoscopic, colonoscopic, previous treatment history, radiology findings, and what are the clinical parameters which you are taking, considering to rule out other IBD mimics. A pathologist should keep in mind the variance of UC and know that treatment can alter the morphology, and never call indeterminate colitis, and if required, take the opinion of an expert GI pathologist. Thank you.
Thank you, Dr. Anuradha.
Thank you, sir.
And I want to ask one question regarding the patient those are on IBD and regular treatment. What are the parameters you take into consideration of that histological healing? So to say that this patient has a histological healing, which are the parameters you take into consideration?
So the most important step, sir, is to look for the neutrophils within the epithelium and the lamina propria. and look for any erosions, ulcerations, and any basal plasmacytosis. So when you take the course of the patient, the neutrophils are the first to appear, and the plasma cells are the last to disappear. So an activity is based on these factors.
Nice, Dr. Anuradha. So basically, if you find a neutrophil for the postgraduates, a neutrophil has 3 lobes, right? So if you see more than 3 neutrophils, it's abnormal. In the basic fundamental, you have to remember. And I just want to have a question is, what are you able to predict on the resection specimens? Means, have you studied anything on resection specimens,
Yeah,
whether you have
so
any recurrence about the disease, or like some articles mention about plexitis and all those
So
things?
we did one study. I didn't go into the resected specimens. So when we get a resected specimen in Crohn's, for example, we try to look at the neural hypertrophy. We look for inflammation of the ganglion cells and plexitis. And we found that these are important features which might predict the chances, particularly when they are in the resected margin. So these are important parameters in the resected specimen which you have to look for.
Thank you. I'm CJ from Singapore. Can I ask a very simple question
Yes.
from a clinician point of view? So when you're suspecting IBD versus, say, CMV infection, Clostridium difficile pathologies, how do you advise us how to take biopsies? Do we take it from the ulcer edge? Do we take it base ulcer? Do we take also from normal tissue? So, I mean, does it help in some way to target your diagnosis?
So when you're thinking of a CMV, it's always advised that you take from the edge of the ulcer, because the viral inclusions are more common at the edge. And when you are thinking of some other diagnosis, I would want biopsies to be sampled from edge of the ulcer as well as normal mucosa, to look for whether what is normal on endoscopy is normal on the microscopy. And sometimes in the ulcer edge, we might get amoebic trophozoites. And if I don't have amoebic trophozoites in my ulcer edge and I have changes in what you thought normal as showing chronicity, I would go on side of IBD.
Madam, Dr. Ganesh from Coimbatore. Many times we find an endoscopic appearance that it's a significant ulcerative colitis, and surprisingly when the biopsy comes it says non-specific colitis with all the other plasma cells, neutrophils, lymphocytes are expanded, but we still treat them as IBD and they recover. So how do you correlate this, whether we don't get this classical appearance of cryptitis, all those changes, but only when the pathologist gives us non-specific colitis? Is it something, a new entity, or the pathologists have not diagnosed it properly, or how it is translated?
So, sir, when a pathologist gives such a diagnosis, that means they are not able to find signs of activity, and signs of activity are cryptitis, cryptapsis, which is present both in acute self-limiting colitis and IBD. So when we have cryptitis and cryptapsis, it can indicate both. So as I said, an early IBD versus an acute self-limiting. But if both are not there, and they're scattered neutrophils and all, then we need to know the treatment history. So sometimes treatment will partially alter the changes. And so we are not able to see evidence of chronicity to label it off definitely as IBD. So the term non-specific is given. And sometimes pathologists should also be bold enough to say edematous mucosa, no significant pathology found, instead of just writing non-specific. And then if you as a clinician are telling us that you are having multiple ulcers and you are strongly suspecting IBD, then it is recommended that you give a segmental biopsies from different sites and correlate with the different segments. So if all my segments are showing ulceration and erosion, then, and if the duration of the patient's symptoms is also more than what should have responded to an antibiotic, then probably it will go more in favor of IBD.
Okay, thank you, madam.
Thanks.
A really good presentation. I just have one point to make, and I'm sure actually one of the cases that you projected underscored that TB versus Crohn's is really not a histological diagnosis. The case you projected as well did not have granulomas, and you picked up the fact that it is TB on the PCR. So this is something that we regularly advise all our clinicians. If you're thinking of granulomatous colitis, a TB versus Crohn's, we regularly advise that they send a separate sample for microbiology. We do gene expert or TB PCR at the outset, and we've discovered many such cases. There are no granulomas, but it's still TB. And also equally, you do see maybe features of chronicity. You see architectural disorganization, you see basal plasmacytosis, but it is still TB. So in our experience, TB versus Crohn's, regardless of whatever the textbooks say, it's really not a histologic diagnosis. So that's the point I wanted to make.
So at our institute, we have a protocol to take for microbiology at the outset.
Yes. So that is what we advise as well. Yeah. Thank you.
One last question, ma'am. So how do you approach the chronicity in a non-IBD setting? So it's not always that the chronicity is equal to the IBD.
Yes.
So it's not the synonyms. So once we say chronicity, it should not be misunderstood that this is IBD. So there are list of causes are there which can show the chronicity in the biopsy. So how do you approach in that case when you see the chronicity in the biopsy?
If you have seen my case where the duodenal biopsy, there was chronicity, there was shortening, there was villus blunting, there was cryptitis, cryptapsis, and in addition, there was a granuloma in the submucosa. That means I'm having a submucosal granuloma, I'll think of Cox. Chronicity, I'll think of IBD. Both together, I'll think of Crohn's. That is where we also have to make an effort in pathology to take multiple serial sections and look for the hidden parasites, as was in our case, where there were parasites in the... Of course, this was hyperinfestation. Sometimes you can have only 1 or 2 crypts showing the parasites. So chronicity does not equal to IBD. Granulomas does not equal to only IBD or Cox, is the basic understanding, which should be kept in mind.
Yeah, thank you, Dr. Anuradha, for an excellent talk and good discussion on this histopathology, which is always a confusing topic. Made certain things very clear. Now we go to the next topic. We're short of time. I request Dr. Nanduri Ishwarchandra, who is a senior consultant radiologist at Yashoda Hospital, High-Tech City, to deliver his lecture on radiology in IBD. Dr. Ishwarchandra is one of the leading radiologists in Hyderabad and has numerous publications, and he has special interest and expertise in general radiology, chest and abdominal imaging, fetal MRI, and correlative imaging. He has got a lot of memberships in the various societies, and without wasting much time, I request Dr. Ishwarchandra to deliver the lecture.
Thank you, sir. Thank you, sir. Good morning, everyone. In the next 15 to 20 minutes, I'll be talking about the contemporary imaging of inflammatory bowel disease, a little bit about ulcerative colitis, and more about Crohn's disease, which is more frequently sent for imaging than for ulcerative colitis. So the outline of presentation would be the role of imaging modalities, the role of imaging and per se, what are the various imaging modalities we regularly use, typical imaging appearances, and if time permits, I'll have a small post-test as well. Now, inflammatory bowel disease, ulcerative colitis, and Crohn's disease are the dominant varieties what you have seen. One thing what I found interesting is that they share a common lack of understanding as to their underlying etiologies. Still, you don't have a pinpointed mechanism, and they varied, the manifestations and radiological appearances are pretty different. Now, the role of radiology would be in terms of diagnosing in a patient who first time presents with clinical symptoms of an inflammatory disease. More importantly, we'll be interested in depicting the activity and the extent of the disease, what segments of the bowel are involved. Are there any complications, especially for patients who have been on a long-standing course of treatment as well as the disease per se? And obviously, with the increased amount of biologicals that are being used, the treatment responses, how the patient has responded to the treatment regimens. The 3 most commonly used modalities would be ultrasound, CT enterography. CT enteroclysis was performed much earlier, but because of its being cumbersome, CT enterography is as good as an enteroclysis study. And as these patients need to be repeatedly imaged, MR enterography has come to play a dominant position, a dominant imaging modality in terms of avoiding a repeated radiation. Now, ultrasound, very eminent modality. It's quick, well tolerated, relatively inexpensive, can do it at the bedside and readily available. And studies have shown that it's as good as MR angiography, not better, but it's reaching up to the level of diagnostic capabilities of MR angiography, especially if done in a appropriate setting. The findings would be thickening of the bowel wall. Here you see a small bowel ileal loop in the right iliac fossa showing increased thickening. And if you see it in a cross section, this is what appearance called as a pseudokidney appearance of a thickened bowel with adjacent increased fatty echogenicity suggestive of inflammation. Now, CT angiography would be the dominant modality, especially for evaluation of a small bowel disease. Done with oral mannitol, you distend the small bowel with oral mannitol, that being a neutral contrast agent. Typically, the scans are done in the late arterial phase or the portal venous phase, where the bowel enhancement is maximal. The only disadvantage is the extent of radiation, and of course, MR would play a better role in that scenario, especially in pediatric and young Crohn's. So we have these fluid-filled small bowel loops, the neutral contrast, and the wall which tends to get enhanced in the abnormal phase. You do multiplanar imaging reconstructions in the coronal, sagittal, and oblique phases. Now, MR angiography would be slightly much more cumbersome in performing as well as interpretation as compared to CT angiography. However, the soft tissue contrast resolution is much better than a CT angiography. The advantages being there's no radiation, there's high soft tissue contrast, and it's also a dynamic imaging modality. You can see the peristalsis as well, especially if you want to know whether it's a artifactual thickening or whether it's a stricture which has got obstruction. We could all do that on a MR much better as compared to a CT angiography. Now, the basic sequences are T1 and T2 weighted axial and coronal. So in the T1 weighted axial images, you find that the lumen would be dark, whereas on a T2 weighted image, you find the lumen to be hyperintense or bright, and you find the normal thin wall of the bowel at angiography. Now, coming to the appearances at imaging, this is a very typical appearance of inflammatory bowel disease at CT. You find that in this particular patient in an ulcerative colitis. As you all know, it starts with the rectum. Rectum is almost always involved. You have increased wall thickness of the rectum and the sigmoid, showing layering or mural stratification at contrast enhanced CT. There is pericolonic fat stranding, suggesting that there is active inflammation. Another patient showing the typical, the layered or the laminar appearance at the cross-sectional of the rectum here. You find that it's extending into the rectum as well as the rectosigmoid as well. Now, you could also say about the chronicity of the illness where the wall thickness tends to get reduced, and you can have this deposition of fat in the lumen of the bowel called as the fat halo sign, which was at one point of time thought to be very typical of chronic colitis secondary to inflammatory causes, but it could be seen in normal patients as well. The complications also use imaging to detect in ulcerative colitis. One acute complication would be a toxic megacolon like this, where you have significant dilatation of the colon, especially the transverse colon. When it increases to more than 6 centimeters, there's a chance of perforation. And a chronic complication, especially in long-standing chronic colitis, you have incidents of malignancy where you find that there is asymmetric nodular mural thickening with pericolonic fat stranding suspicious for malignancy. Now, in Crohn's disease, when you come, the CT angiography and MR angiography play a major role, where you find that the two dominant findings are increased wall thickening and segmental mural hyperenhancement. So these are the two dominant findings. So here in this particular example, this is the T2 weighted axial showing T2 hypointense mural thickening, showing concentric mural enhancement with a laminar appearance, very classical for an inflammatory condition. In the correct context, it is classical for an inflammatory bowel disease. The same thing in a different patient in a CT angiogram, showing the terminal ileum, showing again the mural thickening, hyperenhancement, and the layered appearance, very classical for an inflammatory pathology. Now, this segmental mural hyperenhancement can be asymmetric. If it is asymmetric, it's very specific for Crohn's disease, especially along the mesenteric border. Or it could be a laminar type of appearance. It could be bilaminar, or it could be trilaminar. Or sometimes it could be homogeneous as well, as in this particular patient. So this bowel wall enhancement should be ideally imaged in the enteric phase around 40 to 50 seconds after contrast administration. Inflammation, increased density, which is not well defined with no fluid collection. So there is inflamed loop here with adjacent fat stranding, no evidence of any fluid density or gas pockets in that. It's an inflammatory lesion. Now, an abscess is a fluid collection with rim enhancement, with or without presence of air pockets. So this is one example. An inflamed bowel loop in the right iliac fossa, a fluid collection with thick walls, and CT shows that in addition to the collection here, there's presence of air pockets as well adjacent to a bowel loop here. So this was a abscess secondary to a localized perforation in the terminal ileal loop. Now, mesentery findings are important as well because they could be a clue to the diagnosis or differential diagnosis. They could be perienteric edema, as in this case, adjacent to the colon here. They could be engorged vasa recta, called as the Coombs sign. They could be lymph nodes, which are typically non-necrotic. They'll be small in size, 4 to 8 millimeters. They show homogeneous enhancement, no evidence of necrosis. And they could be inflammatory lesions as well in the pelvis. The fibrofatty proliferation can occur as well, also called as the creeping fat. This is one example of a pediatric Crohn's, showing a long segment disease, skip lesions in the jejunum here. And 4 months later after treatment, shows presence of prominent mesenteric fat in the left upper quadrant, secondary to fibrofatty proliferation. Now, perianal fistula are a common occurrence. At least a third of the population develops perianal fistulae, and MR would play a major role as compared to CT, obviously. So whenever a patient comes with MR angiography, it's also prudent to image the perianal region as well, and when you find a fistula there, it's important to do a dedicated perianal fistula study as well. So this shows that there is inflammatory changes in the rectum, T2 hyperintensity, increased wall thickness. There's an intersphincteric fistula on the left side with no evidence of any abscess formation. These fistula could be simple or complex in nature. So you need to identify the entire tracts, look for the extensions, look for abscess collections, so that the complete surgical treatment can be offered. So when trying to formulate a radiology report, the impressions that should be given would be, especially for a new onset of inflammatory bowel disease, you need to say whether there is active inflammation present or not. If you're not able to say that, if it's specific or non-specific, and if you're trying to say it's Crohn's, you'll have to say about luminal narrowing, whether there's any obstruction. You'll also need to say about the complications, whether there are any complications like sinuses, fistulae, inflammatory masses, abscesses or perforation. And stricture, obviously, if possible, whether you need to tell about whether it's an active stricture or a fibrotic stricture, though it might not be possible at all times to say, especially at CT angiography. And also look at other complications of Crohn's in the abdomen, like you could have osteonecrosis of the femoral heads, especially patients on steroids. You could have sacroiliitis, especially in Crohn's, PSC in ulcerative colitis, mesenteric vascular occlusions, neoplasms, stones, etc. One last slide about tuberculosis was Crohn's disease. In Indian setting, it would be difficult to diagnose, especially when patient coming for the first time, whether it's Crohn's or tuberculosis, especially involving the ileocecal junction. So some findings would be presence of a necrotic lymph node would be definitely a favor of tuberculosis. A patulous ileocecal valve, the strictures tend to be short, the mural thickening could be asymmetric, and if you got peritoneal disease, like ascites, you have omental thickening, or you have got lung disease, X-ray findings in the chest, that would help. But more of the times, it tends to be difficult, especially in patients coming for the first time. Whereas fibrophotic proliferation, mural stratification, comb sign, skip lesions, they all would tend to be more in favor of Crohn's disease. Now, future directions, there would be increasing role of ultrasound in both diagnosis and in surveillance, especially contrast ultrasound could be one direction, and ultrasound elastography could be performed. There's also studies for quantitative imaging of fibrosis, especially using DWI, magnetization transfer, and PET with novel tracers to look for signs of inflammation. And obviously, artificial intelligence would tend to help in terms of collating this vast amount of data, especially MR images. There tend to be numerous images, numerous sequences. It tends to take a while to look at so much data. So these are my references for the presentation. I would thank Dr. Kiran and their team for having given me this opportunity, and the management for providing the facilities, and my team at Yashoda. We have an excellent interaction on a daily basis with our gastro and surgical teams. I would thank them for their continuous learning in our journey. Thank you so much.
Yeah. Thank you, Dr. Ishwar Chandra, for an excellent talk on the radiology of IBD. I think we are running short of time, and we will not invite any questions. I think.
Okay. If there are no questions, we'll go to the next session. But before that, I would request Dr. Shravan Kumar to please give away the mementos to the speakers. Dr. B.S. Ramakrishna, sir. I invite Dr. S. Anuradha gar, please come on to. Sir, Dr. G.R. Srinivas, sir, please give a. I invite Dr. Bhulakshmi garu to give away the memento to Dr. Ishwar Chandra, sir. Thank you, sir. Sir, one more request from you. I invite Dr. Ranjini garu on the stage. Please take a memento from Dr. Ishwar Chandra, sir. Yeah.
Good morning. I request all the panelists to kindly come onto the dais to receive the mementos. Dr. Somshekhar will be handing over the mementos, please. Come. Come closer. Dr. Shravan Kumar. Dr. Somshekar, kindly hand over to Dr. Shravan Kumar. Dr. G.R. Srinivas Rao. Dr. Shashidhar. Dr. Satish. Dr. Ranjani. Dr. Bhulakshmi. With this, we come to the end of the first session. Then we'll be having the panel discussion now. Come. I'd like to invite for the panel discussion on ulcerative colitis, Dr. B. Ravishankar, moderator for the panel discussion. Invite the panelists also.
Yeah. We'll call panelists.
We'll call. The panelists for this ulcerative colitis panel discussion are Dr. Subrabhat Giri, Dr. Srinivas Murthy, Dr. Yoon Kyo An, Dr. Shiran Shetty, Dr. Raghuram K, and Dr. Abdul Khalik. Hand over the session to Dr. Ravishankar.
Thank you, Vishnu. Thank you so much. Thank you, Kiran. And thank all of you for accepting me here as a moderator for this session. And very happy that I have a very distinguished panel here to help me in solving the problem of this clinical case, and have a very distinguished persons in front of me. Dr. Ramakrishna has been our teacher, and my teacher, Dr. S.R. Naik, was always talking about Dr. Ramakrishna many times. And we met him several times as students and subsequently as in other positions. And I invite the international faculty, and I'm very thankful that Dr. G.S. Rao, our director, is here in front of us. Thank you, sir, for being with us. And Dr. Peddi gave me actually 40 minutes from 10 o'clock to 10:40, and he has robbed away all my minutes. So I'm requesting Peddi, how many minutes do we have along with our panel? About half an hour or so. We'll try to be interactive. And what I request is, I'll try to involve the audience, senior faculty, and my panel also should help me in involving the audience. And all of you, please feel free. From the lab medicine and the imaging, we have come to the clinical case, which is not a very difficult case. At the same, in this case, we are not dealing with the biologicals or anything. It's not a severe case of IBD, but it's a simple case, and we are starting from the lab to the clinical medicine. And this case has been dealt by one of my colleagues, and the case has been given to me for discussion. So this is a 40-year-old male IT professional, not having any comorbidities. He had a diarrhea of 2 weeks, more than 6 bowel movements per day. It was watery stool. There was no blood or mucus. There were no constitutional symptoms, and some symptomatic treatments were tried as usual. There's nothing wrong in trying all these treatments because there's no blood, nothing. And the lab parameters showed CRP was 8, hemoglobin was 10.9, ESR 17, and there was some weakness and no restriction of daily activities, and there was some weight loss, questionable. So now I request the panel, start from the side on my left side. What would you do in this patient? Either a sigmoidoscopy or a colonoscopy, or would you observe this patient? And what's on your mind?
This patient who has presented with let's say persistent diarrhea, which is not responding to antibiotics, as the patient has along with that diarrhea, hypoalbuminemia, and also there is a weight loss. So there is no point in waiting because we might be dealing with colitis. So I would definitely like to investigate in the form of either a sigmoidoscopy or a colonoscopy.
But what's your preference? Your preference means.
But I would go for a colonoscopy because if the disease is high up, I may miss it.
Yeah, I think we need not be very conservative and say sigmoidoscopy. It could be a colonoscopy. I recall one thing. What is the rule in medicine? I always recall the rule in medicine is that there are no rules. So we have come back. The Mayo endoscopic score was moderate. Extent of the disease was proctosigmoiditis. Biopsy has shown that it is chronic colitis. There was some activity. So with this, the diagnosis seems to be, Dr. Murthy, what's your diagnosis?
Yeah,
You want to differ from what the clinician has said? Is there any difference in your thinking?
no difference, yeah. So proctosigmoiditis, inflammatory bowel disease, limited colitis. If the colonoscopy has been done, the extent is proctosigmoiditis. So definitely IBD, inflammatory bowel disease, proctosigmoiditis.
I think the pathologist has been very helpful in this case. Usually they confuse us a little bit.
Yeah.
So what is the treatment option would you like to say among the 4 suggested options? What would be your treatment option?
So the B, that is oral 5-ASA.
Oral 5-ASA. Would you also add on a combined therapy like topical 5-ASA?
No,
Again,
no.
it's a choice. It's our choice. It's the way you practice and the way anybody practices.
Oral 5-ASA only.
Only oral 5-ASA. Is there any difference of opinion in the panel? Would you go for a combined treatment of? Yes, sir. Sir. Sir, kindly tell me. Oh, okay. There is an answer from the distinguished faculty that there could be give a combined treatment. But anyway, it's an option. It's an option. It's based on the experiences. Thank you so much for the answer. So let's go ahead slightly. Would anybody give steroids from the audience? Anybody would give steroids in this case as an initial therapy? Maybe and may not be. Nobody has raised a hand, that's why. So what's the disease activity? I think we recall from the slide, the patient had 6 bowel movements per day. So if you see the Mayo score, 6 bowel movements, that is, the stool frequency is getting 3 points in the first one. Rectal bleeding was not there, so 0 over there. Then endoscopic score, the clinician who had seen has suggested that it could be a moderate activity. And physician's global assessment, let's take it as a moderate. So he had about the score a 7. So the activity in this patient is a moderate activity, is not a severe activity. So what do the echo guidelines say? Let me read out the first recommendation. We recommend 5 aminosalicylates at a dose of more than 2 grams per day to induce remission in patients with mild to moderate active ulcerative colitis. I think Dr. Murthy was perfect. But there are certain other recommendations also. The third recommendation says that we suggest the use of oral 5-ASA combined with topical 5-ASA over 5-ASA monotherapy. I think there are several ways we can handle a patient. So let's agree on that because there are 2 types of treatment in this patient. Now there are certain 5-ASA preparations. I think we have mesalamine in India, the topical, the suppository, the enema, and the oral preparations, which includes tablet forms and the granules. So the dose, what is the dose of, there can be some discussion on this. In this patient, what would be the dose? Khalik, would you say what exactly, how much you want to give in this patient? He is having a moderate disease. And would you change your dosage of mesalamine in a mild to moderate disease patient?
No, so generally we start with once daily releasing tablets which are available with us for 1.2 grams. I start these patients with 2.4, that is 1.2 twice a day, along with folic acid, and see further response in the coming 2 weeks, both clinical and lab parameters, and then take accordingly.
Thank you. Any difference of opinion, or anybody wants to give a higher dose? Yes, there are hands, please. Shetty, Dr. Shetty, please tell.
Sir,
Yeah.
actually, if you see the evidence, so a lot of trials have happened. This dose is very important for postgraduates. So when you have mild to moderate disease, so are you using sulfapyridine or the newer version of mesalamine? So the studies have been done. Anything above 4 grams per day for inducing remission is equally good. Anything less than 2 grams per day is not effective. So if you keep in mind that anything more than 2 grams or nearly 4 grams per day is equally effective for inducing remission in mild to moderate disease. But on the other hand, the studies have showed if you are using sulfapyridine molecule, which earlier we used to use, the study was done on the higher dose of up to 6 grams per day. But because of the side effects, so we don't use those molecule much. We are preferring the newer molecule with the lower dose.
Thank you. I almost did not use much of sulfasalazine, especially, I mean, several years back maybe, but right now mesalamine is used. Anybody is using generally sulfasalazine in their patients, except for the extraintestinal joint manifestation? Yeah. In those situations, our rheumatologists tend to use that, and we tend to continue. Otherwise, as such, our own prescriptions, sulfasalazine, anybody uses, sir? Sir, you do use sulfasalazine in your practice without arthritis? I think not many of us use, but if there is arthritis and the rheumatologist's favorite is sulfasalazine, and what about Khalik? What is your take on that?
Where I use sulfasalazine. One is affordability in the poor patients for the long term. That's a very wonderful drug. And second thing is, particularly in proctosigmoiditis, whenever classical mesalamine doesn't work, there are many studies that shows that sulfasalazine acts better. And in my experience also, some patients have really responded well who doesn't work with mesalamine.
Yeah, thank you. Again, the rules stand.
Most of the time.
Most of the times we use?
We don't use that much high dose. These are all abroad studies.
4.8 grams.
Yeah.
I think the recommendations, I mean, not necessarily Indian recommendation, they say that mild disease, I think 2.4 grams per day is okay, but in a moderate disease, 4.8 grams is fair enough. But generally in the country, we tend to use 2.4 grams. Dr. Ramakrishna, what is your take on that, sir?
I would agree. 2.4 grams is generally for the milder disease. 4.8, yes, with moderate disease. There is an older echo consensus that sulfasalazine has a marginal advantage over mesalamine in colitis.
Yes, sir. Thank you so much. Dr. Sharda, you have been very kind. I'm seeing the time. Already we have run through some slides. So back to our case, oral 5-ASA, what type of formulation? These are questions again to my panel. What type of formulation would you give? And I mean, you're reading on that, advantages of switching from different 5-ASA and the optimal dose. Dose we have discussed, we'll not go to the dose. And would you switch between 5-ASA formulations? We have mesalamine Raghuram. What do you say on that? Do you switch from one type of formulation to the other, or you don't really intend to do that in a case of ulcerative colitis? But anyway, if there is a confusion between like UC and CD, definitely you depend on what you are supposed to do.
I wouldn't think about switching, but in this case where we are seeing predominantly left-sided involvement, we may think about using Rovasa, because Rovasa has been shown to be quite effective in left-sided disease. So that's one option that we can consider, but I'm okay with mesalamine, Mesaco.
Okay. Madam, if there is a severe disease, would you go for the mesalamine preparations? If this is a moderate disease, mild to moderate disease, if there is a severe inflammation, would you want to use mesalamine preparations?
In addition to just
Yeah, in addition to the steroids, in addition.
Yep. Yeah, I think so. I will just layer of the different therapy And in patient, even on biologic therapy in the future, we do continue 5-ASA as a background. I think there's a role of continuing 5-ASA at some stage, but until certain goals reach, which talk about STRIDE 2 guidelines all the time.
Okay, there is some suggestion in the literature and sometimes in the experience that mesalamine would, in severe disease, would slightly aggravate the symptoms. Would you agree on that, or I mean, not really?
I don't see
Not
that
really.
in my
Not really. Madam says not really. But anyway, we'll see. Is there anybody who says that mesalamine might aggravate the symptoms in a severe mucosal inflammation?
Yeah, we need to differentiate between severe disease and acute severe ulcerative colitis. In acute severe ulcerative colitis, most of these patients are inpatients. There's no rule. But if a patient has moderate to severe disease, there's no harm one can try. Because paradoxical diarrhea, which is reported with 5 years, is very, very rare.
Yes, sir. Thank you so much. Thank you, sir.
So one thing I would want to add is if the subject doesn't show good response to the oral preparation, since we are dealing with a left-sided disease, we can think about adding a 5-ASA enema, mesalamine enema.
Yeah, that's a combined type of treatment.
But what we see is most people are not comfortable taking the enema preparation. So yeah, if we tend to discuss that with the patient, and if they are comfortable with that, we should definitely think about adding a 5-ASA enema to the oral preparation.
Yes, thank you so much. Let's go going again. Patient was started on 4.8 grams by the clinician, and again assessed at 2 weeks. The stool frequency improved, but still 3 per day. There was some amount of weakness, and CRP still not lowered. So what is the next thing we need to do? Should we wait for wait for some more time for the response and reassess? Add topical 5-ASA, topical steroids, both, or oral steroids? And again, the 3 questions to the panel, anybody can take.
Yeah, I think after you have assessed for 2 weeks, I think still there is some inflammatory process going on. So there's no harm adding topical 5-ASA with the optimum dose of at least 1 gram per day. So there is some interesting studies showing that both topical 5-ASA or topical steroid has been quite effective if you have the proctor or the distal colitis, where you can use oral 5-ASA plus topical ASA in such group of patients.
Yeah, Raghuram is my friend, but I have not revealed any question to him. He has answered before the slide was put. Raghuram, now I want to little trouble you. In this patient with proctosigmoiditis, would you want to use a suppository or give an enema if it is topical?
So suppository, the site of action will be only rectum. So since there is sigmoid involvement as well, I would want to use a liquid enema rather than a suppository alone.
Okay, I already focus the slide so that it will be read. Only I will read one recommendation, that is 4th. We recommend using topical steroids for the induction of remission in patients with active distal colitis. How much agreement is there among the panelists on this recommendation? Applicable to this case. Apply this recommendation to this case. Would you use steroids in this patient? Topical steroids.
As a add-on therapy, maybe, but not as a isolated agent. I don't think so.
Okay. Srinivas, what is your take on that?
Sir, I would prefer adding a topical 5-ASA rather than adding a topical steroid.
Yeah, thank you. So whether this has been added or not, we have oral steroids and we have topical steroids. What is I mean, I'm not asking you the oral standard dose because nobody has agreed upon the oral steroids in this patient. For oral steroids, let's leave it, and topical steroids for induction of remission in distal colitis. In this patient, the panel has said that you'll use mesalamine rather than steroids. But if the response is not adequate, would you use topical steroids in this patient? Again, anybody in the panel, Srinivas Murthy, you can tell. You would, okay. There's some problem with your mic.
Patient is not well, inflammation is going on. I think we should start quickly oral steroids, I think.
Okay. I think that that's what the clinician has done. So suppose you want to combine topical steroid with say topical 5-ASA with steroid. What is the steroid would you use in this patient? Now you can use even your prednisolone or budesonide or topical steroid. What is available in the country which you use?
Basically, see, left-sided colitis MMX is preferable. That's budesonide MMX. But prednisolone, if the patient is not financially this one, prednisolone, oral prednisolone is equally efficacious. So we can use one of them, either budesonide MMX or oral prednisolone.
I think most of the drugs available in the country are not expensive, at least this level. Biologics are expensive in this country, but the other drugs, mesalamine.
Prednisolone is the cheapest.
Yeah, okay. And even between sulfasalazine and 5-ASA, I think the cost factors are not so much.
Sir, can I have one question? So I would like to ask the senior faculties regarding topical 5-ASA. So what is your advice regarding the position in which the patient should lie down, and what is the change of position? Like I have seen some faculties, they advise that you remain in the left lateral for 15 minutes, then in prone for 15 minutes, and then in right lateral for 15 minutes, that help in evenly spreading the enema. Is there any data or any experience regarding that? Because I don't find our residents advising these things, and the patient again comes back with that it is not working.
I think this is really great panel discussion, because the important thing here is that a significant number of UC patients will do well with mesalazine therapy. Optimizing that's really important. At the start, we give pretty much everyone top and tail, unless they have proctitis, when we just give them a suppository. If they have left-sided proctosigmoiditis, extensive colitis, we'll give them top and tail. What enema you give them, how they take it, I don't care. Whatever they'll take, whatever they'll tolerate for however long is probably better than nothing. There are millions of different preparations, and our IBD nurses then will do a fantastic job with the patients, talking them through the different therapies, the different preparations, how they can use them. But to be honest, I would never say to a patient, you know, hang yourself upside down by your legs, do a special dance when you've got the enema in, because most people don't particularly like doing them. So we would say for a month of both, then just carry on with your tablets.
I think it has been answered to a certain extent. Yes, please go ahead.
I guess I want to echo what Charlie said. I think using the right therapy and waiting the right time before assessing is important. You're using 5-ASA, the first assessment was 2 weeks. You know, more often than not, for moderate severe ulcerative colitis, you're not going to get complete response. You just have to wait it out. So if you're committed to oral, if some of you are persuaded, that's fine. But I agree on combination, meaning oral and topical. There are many formulations now. In India, I know there are tablets, there are granules. Even how you use them will determine whether how the patient responds. The whole idea is to improve adherence is once a day dosing. Granules for left-sided disease, like Celofort, they've done their own studies. Oral Celofort tablets versus oral Celofort granules. Granules are superior for distal left-sided disease. So you have to pick and choose. You really have to customize it for the individual. Then if the patient cannot tolerate enemas, there are foams. So foams are better tolerated, especially when they are really moderately severe at initial stages. They could have a lot of urgency, tenesmus, etc., etc. Then finally, I do agree, although Charles says you don't have to hang your legs up, but I think I put it one side, left side for 10 minutes, prone or whatever, or sometimes just lying up. So the idea is mechanical. You want the drug to go as high up as possible. That's all. There's nothing rock science about it.
I think the drug that's easily available for as a foam preparation and enema is the one is that is available. The available drug is there. Earlier, some 25 years back, when this foam was not available, what we used to do, that's why the question has come, is to break the tablets of prednisolone, mix in some amount of water, give it as enema, and make the patient roll around. That was some time back, the therapy, which, when some of our seniors were, insisting on that. And now that thing has changed. Now, patient was started on 40 milligrams per day. There's a clinician who has done, and she was very interested in this patient, so she has given prednisolone at some activity. The clinical response was there at 2 weeks. Stool frequency came down to 1 per day, and there was CRP also reduced. And in this patient, having administered 40 milligrams of steroids, when do you taper steroids? Again, to my panel, madam, you would want to take the question?
Happy to. If we started on 40 milligram, I try to shorten the duration of steroid the patient is in, and depending on the severity of disease. So going back to this case when it's more moderate type and on 5-ASA therapy, I probably aim quick weaning of the steroids within 6 weeks. So as soon as once the clinical response reached, I think usually I go through quickly by the regimen of at least 10 milligrams initially, coming down to 20 milligrams. Maybe you can extend in 20 milligrams and come down again to lower doses.
Yeah, one quick question to you is, how many days would you continue 40 milligrams?
So 1 week in this setting.
1 week. Could we go on for 2 weeks? In this patient, your suggestion is 1 week. It's well taken. Yeah. Yeah. Anybody in the panel? Anybody wants to say? Want to say something quickly?
We use 40 mg for at least 1 month, 4 weeks. And then the taper is more of a gradual rather than rapid taper. We taper over 5 mg per week until 20, and then 2.5 until 10.
Maybe, but I think 2 weeks or 4 weeks? I mean, who would say 2 weeks?
2 weeks. 2 weeks.
2 weeks. 1 week.
One
Okay. I think there should be some difference of opinion, especially when such a panel discussion is there. 1 week is what madam has said, and I think there are good supports for 1 week, and there is also support for 2 weeks. 4 weeks, any support for 40 milligrams? At least you should raise your hand. Okay.
So otherwise, wait for the clinical response. If you have a difference of opinion, is like clinical response.
Yeah, exactly.
Patient improves, then you start tapering.
Yeah,
at least 2 to 4 weeks.
Exactly. My question is going to be to the panel. Suppose at 2 weeks, there isn't much response. Then how do you go about? You want to continue the steroid therapy for some time, or you want to make up your mind, okay, this patient is not responsive. When you make up your mind that steroid is, not responsive in this patient.
Yeah, if it's a moderate to severe disease and it's not responding within 2 to 3 weeks, and obviously we would need to think about escalating the treatment to the next level of thing, probably biologicals or something like that. Otherwise, continuing with steroids for a very long period, if it doesn't show response, doesn't make much sense.
Yeah, definitely. Clinical medicine looks easy, but definitely it's complicated. So what is the response that has been used in some of these studies? Just see the True Love WITS. Just let's read up that criteria used to define remission in the True Love WITS study. Less than 2 non-bloody stools per day, no fever, no tachycardia, then improving hemoglobin, reducing ESRs and some weight gain. So that's used as remission. So let's now go back to the present study. 40 milligrams, is it more effective than 20 milligrams? What is the definition of a low dose steroid and what is the definition of a high dose steroid in this IBD setup? Can we think that 40 milligrams is a high dose and 20 milligrams is a low dose?
No, some people tend to use 1 milligram per kg dose of prednisolone and equating to 60 milligram in most of the scenarios. But what, at least in my clinical experience, I have seen that a dose more than 40 milligram, irrespective of the body weight, doesn't add to the advantage.
Yeah, frankly speaking, I want to give 40 milligrams only to the patient, but when patient is little chubby, I always want him to be little skinny. So what is the dose, sir, Dr. Ramakrishna, sir, what is the dose of steroid in a patient? Would you give for 1 milligram per kg, 0.75 milligram per kg, or you're fine with 40 milligram per day?
No, I'm personally fine with 40 milligrams, but traditionally, and since we talked about it, steroid non-response is defined as non-response at the end of 2 weeks to 1 milligram per kilogram.
So definitely, there are so many complexities in the clinical practice. So any other, yeah, please, we'll have 2 answers on that question.
No, I completely agree, 40. In fact, actually, there is one randomized control trial between 40 and 60. There was no superiority of 60 over 40. My comment was about the earlier question that the duration of steroid treatment is now should be subject to trials, and India is well placed to do those sort of study. Otherwise, we will have the same discussion next year talking about different people giving different durations.
Thank you. I think just briefly, we really want to avoid overuse of steroids. And I think the best way to do that is to keep really simple rules. And so certainly across the UK and most of Europe now, the rules are very simple. If you're going to use prednisolone, use 40 milligrams once a day for a week. You then drop it down 5 milligrams per week. It's a total of 8 weeks. If anything, you go quicker with your steroid taper. If you haven't responded after 2 weeks, you need to think about another therapy. The real key is to avoid people getting stuck on 20, 30, 40 mg of steroid with the complications therein.
Yeah, thank you, sir. Nowadays, our patients themselves, they don't accept the steroid. They say, oh, steroid, you're going to give me. I know the COVID lessons, things like that. So our patients themselves are not taking steroids nowadays. They put 100 questions. I'm an asthmatic. I was given by my pulmonologist 20 years ago, 60 mg per kg based on my weight or something. So then I told in my home, my wife, then she fainted. Thanks, she did not leave me when I was taking 60 milligrams steroid. So higher doses doesn't seem to be beneficial, and response assessed at completion of 2 weeks. No use in increasing the dose or continuing steroids after 2 weeks if there is inadequate clinical response. Then if there is inadequate clinical response, I think we can switch over to other therapies. So again, maintenance was given, prednisolone was given for 40 milligrams was 2 weeks and tapered over the next 4 weeks. Quick question is, tapering over 4 weeks or 8 weeks? Raghuram, would you take that?
Now, one thing that the rheumatology colleagues tend to tell us is if you have used a dosage of 40 milligram and if the duration of usage is less than 4 weeks, you can go for a quick taper. So, yeah, I would
4 weeks or 8 weeks? Quick question, quick answer on that.
Yeah, so a quick taper over 3 to 4 weeks should be good enough if you are using 40 milligrams.
4 weeks or 8 weeks? Or doesn't matter?
4 weeks.
Okay, now the next question is, should a colonoscopy be done at the end of treatment to assess disease activity? Would we do a colonoscopy to assess the disease activity at the end of treatment, whatever has been given to this patient? No? Okay. Now, let's quickly go back to some slides. Here, in these studies, what has been assessed was clinical and endoscopic remission. This sometimes makes us feel that, okay, why don't we do an endoscopy at the end of the treatment? Well, anyway, these are studies and not the routine, usual cases. So the patient was started on 5-ASA, 4 enemas, along with the oral 5-ASA. Patient was fine. There was a disease flare at 2 years. So the disease activity again was moderate and the extent was rectosigmoid only. CRP was slightly on the higher side, and second course of oral steroids was given in this patient and tapered over 6 weeks. And the question is now, there is a remission now after the second course of steroids, maintain with 5-ASA or go for immunomodulators, go for biologics or tofacitinib. I think the quick answer seems to be maintain with 5-ASA in this patient. Anybody would want to differ and go for any other option apart from 5-ASA in this patient? I think there are no hands that are raised. So this patient developed a mild CAD and was initiated on medical management. Some chest pain and angio was done. So he was continued on 5-ASA. The question from the patient was, is my ulcerative colitis caused this CAD? Anybody would say yes to that or think about it? The CAD could have been caused by the inflammation of the colon. No, there's nobody saying that. So screening sigmoidoscopy showed a small patch of inflammation. There was some iron deficiency. There was a flare at 4 years. And there's budesonide was added, given for 8 weeks and tapered. Now, quick question here is again to the panel. How many weeks of 9 milligrams would you use when you are using budesonide?
At least 8 weeks.
8 weeks.
8 weeks.
And then would you go for a taper or would you want to stop suddenly?
You taper and then stop.
Taper over 2 weeks?
Yes.
Would you use a lower dose or how do you taper the usually 9 milligrams available in our country, in India?
Yeah, usually we don't have.
There is a 3 milligrams available.
You can actually taper 3 and then go. But in India we don't have this digital release MMX 9. Only we have 9 milligram tablet. So it's difficult to taper. So maybe we can go for a longer gap.
We do have 3 milligrams.
But that's sustained release.
MMX, yes, MMX is there. 3 milligrams. It's one brand. Then this patient was started on azathioprine. So I think we don't have to discuss on this because we have agreed on this. If there is a pancolitis, would this budesonide be useful or is more useful in left-sided colitis? Let's clear on this aspect.
The study shows it's more beneficial if it is left side or distal colitis. If span colitis is not much of effective, then you preferably go for either for the induction you go for steroid, then obviously immunomodulators are the better drugs.
Sir, is there any difference of opinion on this aspect? Yes, sir, please, Dr. Sood sir.
Regarding budesonide MMX, I think 8 weeks is fair enough. Now we are talking of taper. There are two kinds of budesonide. One is controlled release, second is MMX. Controlled release doesn't work in the left side colon, so we should not really go for 3 milligram at all. So we can stop after 8 weeks comfortably.
Sir, would you go for a sudden stop or?
Yes, yeah, we can withdraw after 8 weeks. Okay. If somebody really wants to taper, then we can make it alternate rather than going to the controlled release.
Yeah. So only my thing was there is a preparation in the country which is 3 milligrams MMX preparation tablet form.
That's my knowledge is that's a controlled release. It's not a MMX 3 milligram.
Okay. Okay. So there are some statements like courses of steroids to be restricted to a maximum of 3 months. Then requirement of steroid sparing agent is needed when a patient requires more than a single course of systemic corticosteroid in a year. And the second point is when the patient experiences a disease flare upon steroid tapering. I think everybody agrees on that. Okay. The common dilemmas are approach to achieve endoscopic remission in a quiescent disease, steroids with azathioprine additions. When should immunomodulators be considered during a second course of steroid? Would you agree on that? Second course steroid immunomodulators? What are the advantages and disadvantages of delaying immunomodulators? Anyway, these are some questions. Maybe we'll answer or not answer. Should the extent of disease determine the therapeutic choice? I think there are certain things that can be discussed in this case. So summarizing this case, moderate disease, clinical parameters were never normal, CRP, anemia, low MCV and some inflammation, but it did normalize after steroid therapy. The patient required 3 steroid courses in 5 years. The quick questions could be importance of achieving endoscopic remission to prevent flares. Is it really important to achieve a endoscopic remission? Developed CAD, the question from the patient has been, is it related to UC? Clear, usual answer was no. Importance of setting higher goals like histological remission. Should we set such goals? Taking this patient as an example. Importance of adding a steroid sparing agent early in the disease course. All these are the questions from the patient side actually. These are put forth to me by the clinician who has treated this patient. So aminosalicylates, the mechanism is it blocks IL-1, it blocks the TNF receptor, it activates the PPAR in colonic epithelium and inhibits prostaglandins, and it also a free radical scavenger. The dose is sulfasalazine is 1 to 4 grams per day, mesalamine suppository is 1 gram per day, mesalamine enema is 4 grams, and we have discussed the dose of oral mesalamine. 5-ASA not very effective, not effective in acute severe ulcerative colitis, as Dr. Sood Saab has mentioned. 5-ASA use is interrupted in patients with severe disease. This can be debated. With severe local disease in rectum, steroids may be better than 5-ASA. What does the panel say about it? If there is a severe disease in the rectum, would you use steroid rather than 5-ASA? Yes, agreed? Yes, there is some agreement. Interstitial nephritis may be an adverse event of 5-ASA. And has anybody experienced this, or have we been doing this interstitial nephritis checking in patients who are on long-term 5-ASA? How many do? Well, I should agree that I will try to do. And we are, I mean, we do PBIs, we give these drugs left and right, but most of the times we have not been doing this interstitial nephritis checking. What do we do for interstitial nephritis checking? My nephrology colleague has said do creatinine and maybe proteinuria. And rare adverse effects are pericarditis, myocarditis, pneumonitis, pancreatitis, hepatitis. How many of us have seen this type of severe complications? The last line says severe complications. Anybody? Yes. Many experienced. Anybody from the younger crowd? All are budding gastroenterologists. All lovely guys. So steroids, it has the GC-GR complex. We are running out of time. So the glucocorticoid and the glucocorticoid receptor complex has its actions, and then it reduces the inflammation. So thank you all. I think we had some discussion on this topic. I kept 1 or 2 minutes for a quick discussion if feasible. So the panel can take over now. Any postgraduates, you want to ask some question?
Sir, can I ask a question? Excuse me, sir.
Yeah, madam, please.
Sir, when do you use stem cells in UC? We know stem cells in Crohn's. Do you use stem cells, and if at all, what's your experience?
Yeah, madam, I think my more learned colleagues can answer this question, but I think it's more useful in fistulating disease where this can be given as a therapy. Apart from this, according to my knowledge, stem cells have not been very useful in other areas in inflammatory bowel disease. Dr. Sood, would you want to answer that question?
It's mainly for the perianal fistulizing disease, not so far in UC.
Any experience in your center you could tell us?
No, sir, we also do not have anything. So I was just wondering that when we are using stem cells for fissuring diseases in Crohn's, would you want to use, because after hearing the discussion on severe ulcers and how to apply the topical steroids and all, I just had a thought that do you use it for any cases?
Because stem cells again are difficult to procure, need all the things, gadgets and other things. It seems to be useful in some cases of fistulating disease where these can be used topically. So any quick question, or you want to stimulate our juniors? Yeah, I think there are many hands. I think all the hands should go that side only now, not to me. Khalik, you can organize now.
Yeah, I have a question here. So yeah, thank you for the panel discussion. So I'm wondering, I've seen a lot of discussion on the diet and the drugs and everything. So what is your take on diet intervention while you're also considering the clinical treatment in such cases?
Yeah, exactly. I think there is going to be a discussion on diet, but any takers?
It's like evidence says, sir, only in acute exacerbation we have to have some modification. Otherwise, you don't have to restrict. There is always a notion. Patients keep asking that I'm intolerant to this drug. In IBD, should I avoid these proteins or milk? But it is only when you have an acute flare, you ask them to modify the diet. Otherwise, you can take, because depends on which geographic area he comes. If it's the southern India, obviously predominantly they are rice eaters. You're North Indian, you can't ask him to change his cereals, wheat-based diet to cereals. So it's difficult question. Like you said, we have a talk on that. So ideally, when he is in remission, you can ask him whatever his natural diet of balanced recommended daily allowance should be continued. Only when he has a flare, that time you can avoid some trigger foods where it precipitates the symptoms, worsens the symptoms. That's the thing we need to tell our patients.
Already Somo is threatening me.
So
He
one
wants
question,
to pull
sir.
me down. So
Sir,
one last quick and last question.
Yes, sir. Sir, if you have a patient who is showing anaphylactic reaction to 5-ASAs with oral 5-ASAs, so if he's having a protosigmoides, can we use a topical 5-ASA? Or if it's not, what is the next option for them?
I think it's a difficult question. Somebody had a definite 5-ASA reaction. I would be scared to use topical, but anybody wants to say yes, they could get up and say yes, they would want to use. But if it's me, I will say I'll chicken out from that. I would not use it on myself if I have the reaction to that. And I would be a little scared. Anybody would want to use, if there is a reaction, excellent question. If there is a reaction to 5-ASA, anybody would want to go for topical steroids? General answer seems to be no. Thank you. So I think we have finished, Vishnu. Are you stunned or you're not able to get up? I think if I don't move, Vishnu will push me.
Thank you very much, Ravi. I think it was a very stimulating panel discussion. Now I will request the panelists to kindly come on to the dais to receive their mementos. And Dr. Ravi Shankar, can you please do the honors of handing over the mementos to our panelists?
Our panel is a young panel. They want to move fast.
Yeah. Great. Ravi, can you do the honors, please? Dr. Suprabhat, Dr. G. Srinivas Murthy, Dr. Yoon Kyo, and Dr. Shiran Shetty, Dr. Raghuram, and Dr. Abdul Khalik. Yeah, I think we need to give a round of applause, please. A wonderful discussion happened. I request Dr. Somshekhar to kindly come on to the dais, hand over a memento to Dr. Ravi Shankar. And yeah, yes. And Ravi Shankar, kindly hand over the memento to the theme director of this session, Dr. Somshekhar. Thank you. Thank you very much. I think the first session was concluded successfully. We will briefly go on to the inaugural session. As is norm for all conferences, we need to have a formal inauguration. So good morning, ladies and gentlemen. I am Dr. Vishnu Reddy, and I'll be hosting this inaugural session for all of you. It is indeed a great honor and a pleasure to invite all of you on behalf of Yashoda family for this IBD conference. IBD Conclave 1.0. This conclave we are planning to do every year, so this is the first conclave we are doing, and our department will be conducting this, making this an annual event. I want to especially thank, on behalf of the Yashoda family, the international faculty who traveled from all over across the world to be here to take part in this conference, and the national faculty who took time out to be here with us, and of course the local faculty who have been here supporting this conference throughout. And of course, no conference is successful without the delegates, and that is, I think, a great, a lot of delegates are here with us on a Saturday morning, and that's because Saturday is a working day for us. So, taking time out of the work and coming to attend a conference, I think that shows the interest this particular conference has actually generated amongst the gastroenterologists. The budding gastroenterologists, a lot of postgraduates are there, so I think this is a real good academic feast for them, and I'm sure there'll be a lot of interaction between the postgraduates and the younger practicing colleagues and the senior faculty who are here from across the world. Yashoda Hospitals, briefly, has started as a small 50-bed hospital about more than 3 decades back, more than 35 years back, and today we are recognized as one of the largest group of hospitals in the twin states of Telugu states, that is Telangana and Andhra Pradesh. Now today, from 50 beds, we have gone up to 4,000 beds, and we are going, expanding further. So this has been possible primarily because Yashoda has always believed in bringing the best and the cutting-edge technology from across the world to Hyderabad, to our hospitals, to give it to so that it is available for the patients, and most importantly, this is available at a very affordable cost, which makes it all the more important to recognize that, you know, this is one of the key success stories behind how the hospital has grown. Now, the confluence of the best technology, the best infrastructure, and of course, the most committed consultants is the reason for the success of our hospital, and we really appreciate that the management has been focusing on this, the top management, and that is one of the reasons why Yashoda has been so successful. The Department of Gastroenterology, the department which is in focus today, an overview of which Dr. Ravi Kiran will briefly tell next after my talk, will give an idea as to how we have developed from what we started initially to where we are today. And similar is the success story of each and every department in our hospital. I would not take more time. I would invite Dr. Ravi Kiran to briefly give an overview of the Department of Gastroenterology.
Good morning. Once again, welcome to everyone on behalf of Yashoda family. Gastroenterology is a very important aspect in the healthcare system. It has now become a problem of every household. Earlier, infectious diseases was one of the major burden compromising of the patients coming into the gastroenterology department. Over time, from infectious diseases, it has now become a non-communicable diseases like IBD, ulcerative colitis, Crohn's, etc., which are becoming a major burden of the patients who are coming into the gastroenterology department. Another complexity that is also happening is we are doing very high-end procedures on OPD basis. So we are doing complex resections and corrections in the GI tract and discharging these patients on daycare basis. Keeping this in mind, Yashoda Group has invested on the latest equipment so that we can do these high-end procedures safely and give the best results to the patient. The infrastructure like the endosono suits and all are the state of art so that the experience, they can come in and get discharged by the end of the day. Also, most importantly, we have one of the most distinguished faculty who are here taking care of these patients. This is a list of the various equipment that we have in our armamentarium, starting from basic endoscopes, colonoscopes, etc., the latest endoscopic ultrasound, the capsule endoscopy, fibroscan, manometry, APC system, the spyglass, double channel enteroscopy. We also have pediatric gastroscopes, and we have also ensured, because almost every patient is asking for sedation during the procedures, we have not compromised on the anesthesia infrastructure also. The various procedures that we have been doing in our setups are under EUS guided system, gastrojejunostomy, cystic drainage, pancreatic drainage of the necrosis, celiac plexus block. We have been doing various procedures under ERCP also, including spyglass cholangioscopy, and third space endoscopies have also been happening, like endoscopic mucosal resections, submucosal dissections. POEM procedures have been happening. We have been doing endoscopic polypectomy, banding, and balloon placements too. Overall, at the Yashoda Group of Hospital, we have been annually doing more than 60,000 procedures, of which close to 2,500 ERCPs, under Endo US, more than 1,200 procedures, 400 endoscopies, and more than 300 POEMs have been done so far in the last 1 year. So what we hope is that we should be able to serve all the patients coming into our system. We have 4 hospitals which might have different overall infrastructure, but the departmental infrastructure, we have ensured that it is the state of the art so that we can serve all the patients equally. We have also ensured that the pricing is equal in all 4 units, let it be here or any other 3 units of the Yashoda group. With this, I conclude my talk. Thank you.
Thank you very much, Dr. Ravi. I think this broadly gave us an overview of what we are doing in the Department of Gastroenterology. We are extremely proud of our gastroenterology department for doing such cutting-edge work. Now, I would we'll start the formal inaugural session. I would invite our senior consultant, Dr. Kiran Peddi, and the organizing secretary of this conference to kindly come onto the dais. Dr. Ajit Sood, who is the consultant gastroenterologist and secretary of CCFI, to kindly come onto the dais. I request Dr. C.J. Ui, consultant gastroenterologist and president of APAGI, that is Asia Pacific Association of Gastroenterologists, to kindly come onto the dais, sir. Dr. Shaji Sebastian, the lead clinician IBD unit from UK, kindly come onto the dais, sir. And last but not the least, our chief guest for today, Dr. G. Surendra Rao, sir, our managing director of Yashoda Hospitals, who's been one of the most guiding lights for us in this journey. Thank you very much, sir. I would request Dr. G.S. Rao, sir, to kindly honor the dignitaries on the dais with by handing over the bouquets to them. Kiran. Thank you very much, sir. As is the tradition in our country, normally we start all these programs with lighting of the lamp. So I would request the dignitaries on the dais to proceed for lighting of the lamp. And I would like to invite the international faculty, Dr. Jacob Bigan, kindly come onto the dais, Dr. Charlie Lees, Dr. Yoon Kyu An, Dr. Deepak Parakal, request you to kindly come and join us for the lamp lighting, sir. And I would like to invite Dr. B.S. Ramakrishna, Dr. Peddavir Raju, Mr. Anuj Gupta, unit head of Somajura Yashoda Hospitals, kindly come onto the dais. Dr. Ravi Kiran, request you to be there. And I would request the gastroenterology consultants from Yashoda Hospital also to kindly come onto the dais and participate in the lamp lighting, please. The consultants from our units, all the units, gastroenterologists, please come onto the dais. Thank you very much. Please be seated. I request Dr. Kiran Peddi. Request Dr. Kiran Peddi to go briefly address the delegates and give us an overview of this conference. Thank you.
Thank you, Dr. Vishnu. Once again, good morning and welcome to all of you. On behalf of Yashoda Group of Hospitals, I warmly welcome you all to attend this conference, and especially the international and national faculty, all the delegates, postgraduates, welcome once again. So my interest is in IBD stemmed from my experience in UK when I was working in UK and Australia. And when I was actually relocating to India, I was under the impression that I would hardly see any IBD at all, if at all. So that made me worried initially. But as in the last 14 years of my stay in India, I can certainly say that both the numbers of inflammatory bowel disease cases and also the complexity has enormously gone. And I'm sure all of you agree with that. So in the next 5 to 10 years, India is going to witness one of the steepest rises in inflammatory bowel diseases. And all of us should be geared up to face that challenge. So we thought that's exactly the reason we wanted to conduct this conference on a regular basis. And with the help of both national and international faculty, we would expect that this will, all of us would increase our knowledge and understanding of inflammatory bowel disease, ultimately to the benefit of our patients. So as briefly mentioned before, for those who are not attended in the morning, so we have these 2 days of conference interspersed with lectures, series of lectures and panel discussions, and followed by a quiz program tomorrow morning, and we'll be concluding tomorrow here by 3:30 or so. Then after that, or during lunchtime, we'll be breaking, a small proportion of people will break and 20 people will go into have a hands-on IUS experience at Somajiguda branch of Yashoda Hospital. And so with that, I would hand over back to Dr. Vishnu. Thank you and welcome once again.
Thank you very much, Kiran. I would now request our Managing Director, Dr. G.S. Rao sir, to kindly address the gathering.
Welcome all the delegates of the IBD conference. Welcome the faculty, national and international faculty. Welcome all the junior faculty who are under probably gastroenterology students and DNB students, whatever. Dignitaries on the dais. Especially welcome Shaji Sebastian, lead clinician IBD head University of UK. Dr. C.J. Oy, President of APAGC, Consultant Gastroenterologist, Clinical Hospital, Singapore. Ajit Sood, Professor and HOD of Gastroenterology, Dayanand Medical College Hospital, Ludhiana. Kiran Peddi, our Senior Consultant and IBD Specialist. We also recognize Dr. Ramakrishna, who is a Senior Gastroenterologist of our country. We welcome you, sir. Peddiraj garu, Veerraj garu, Consultant of Gastroenterologist in Vizag. I think more than 3 districts depend upon you, sir. We wish you a good, long, healthy, all the districts, members of the Telangana ISG, esteemed consultants of Yashoda Hospital. When we started in 1990, we had a small hospital. That's what I think Vishnu has told. Fortunately, we have started with a gastroenterologist only, which really developed over a period of time. And we have put up another hospital and another hospital, like that. We had 4 hospitals. Developing into a multi-specialty unit because of the gastroenterology only, because gastroenterology could give lot of cases to the surgical gastroenterology, then could give a lot of cases to the oncology also. That's how I think we went on adding different departments. We added physicians, we added other departments. We are very successful. My only request to all the junior gastroenterologists, this department should not become like cardiology. Cardiology nowadays, if I say how many PTCs, how many angiograms, it has become more of a number of procedures rather than a number of patients. So unfortunately, we should not go into that sector. of how many colonoscopies we are doing, how many angios, I mean, whatever it is, ERCPs or third space endoscopy. Why I'm saying this is, the juniors tend to become into a glamorous system of procedures. No. I'll tell you one example, long back, of course, 15, 20 back. A junior neurophysician joined us. A senior gastroenterologist was with us. The junior neurophysician came to me and said, "Sir, what does this gastroenterologist thinks of himself? He sent me a pain abdomen case. It is his department he sent me." I said, "Bhai, wo senior aadmi hai, usko to malum hoga. He knows what he sent. You study it again." "No, sir, I studied everything. I could not find anything neurology in this." I said, "Please ask him only, because I also don't know why he sent." So he really asked. He said, "Ek kaam karo, Doctor Sahab, you do EEG. Pain abdomen EEG." That fellow was furious because he's young. He doesn't have much experience. I said, "Please do it, because he's a senior guy, please do it." It turned out to be an abdominal epilepsy. EEG was positive, whatever. He gave some, I think, some drug, and he became. The patient was suffering for more than probably 4 or 5 years. It's a child for 10 years or 12 years. And the pain was there for the last 4 years. Diagnosed by a gastroenterologist that there is an epilepsy. Why I am stressing on this is, there is a lot of other issues, not only procedures and treatment, but there are a lot of, like IBD, of course, I am sure. Nowadays we are seeing doctors in cardiology who doesn't use their stet. They don't, the auscultation has been forgotten. We don't want gastroenterologists to become like that. Patients also needs not only your diagnosis and treatment, your touch of humanity. You please treat them with a lot of compassion. That's what I request all of you for the juniors. I'm sure seniors are doing the whole thing. And one more thing is, juniors are in a very hurry to reach peaks. No, there is no shortcut for any fame. There is only hard work which goes into the fame factor. Thank you very much. All the best.
Thank you very much, sir, for your kind words. Now I would take this opportunity to invite Dr. Ajit Sood to kindly address the gathering and say a few words.
First of all, thank you, Dr. Kiran, for the invite. This is the first time I am visiting this hospital, and it's very impressive. I really didn't know that the Yashoda Hospital has as big an institution as 4,000 beds. Thank you, Dr. Kiran, for the invite. And as Kiran mentioned, that the IBD is on the rise. And I think to tackle rising number of patients, we need to have a very strong group of people who are committed to IBD. And that way, Dr. Kiran has very core interest in IBD. And I'm very happy that he started this IBD Conclave and international meeting. And I can see very interesting kind of discussion already going on. And I'm sure further on we'll have more academic sessions. And what I wish that what is well begun, it's half done, and it's a good beginning. And I'm sure Dr. Kiran will keep it up. All the best, Dr. Kiran. Thank you.
Thank you very much, sir. Now I request Dr. Uy to kindly say a few words.
Thank you very much to Yashoda Hospitals and also Dr. Kiran for the kind invitation. This has been a tremendous journey. I think I represent APAG, which is the Asian Pacific Association of Gastroenterology. We have 23 member countries, of which ISG is a very important member country as well. In APAG, we have a IBD committee. At the moment it's helmed by me, but I'm sure I'm going to pass it on to many people who are now very interested in IBD and are very good proponents for IBD medicine in Asia Pacific. And we're extremely happy that Yashoda is doing this whole curriculum on IBD, because it's really an emerging and important disease. As you can see from just a simple discussion this morning about 5 ASAs, the science is there, but gosh, the art is incredible, meaning that there's so much diversity in the way we approach our patients. I think that we take solace in our managing director, Yashoda, who says, whatever you do, science apart, the patient is very important. Thank you.
Thank you very much, Dr. V. Now I'd request Dr. Shaji to say a few words.
Thank you. Thank you, Kiran and Yashoda Hospitals for inviting us all here, and it's absolutely an honor for all of us. I want to start by saying that I'm amazed, I'm in awe here. The facilities here, the volumes here, but most importantly, the talent here, particularly among the residents, is something which has really inspired me over the last few days since I've been here. Why I think that is important is that IBD is a truly global problem. I predict that in 10, 15 years, IBD in India, China, and Brazil will definitely overtake the West. So that means the problems of IBD will not be solved by we sitting in the West. It will only be solved by the emerging incident countries in India, China, Brazil, etc. So it's time for us to collaborate together, and these sort of meetings gives that opportunity to sow the seeds of collaboration. And in my role in the governing board of ECHO, we have a global strategy called the REACH, which is exactly singing to the same tune as to develop these collaborations and networks across the world. So thank you again, and hope these collaborations last till we find a solution for this epidemic of IBD. Thank you.
Thank you very much. With this, we come to the end of the inaugural. I request all the delegates, we have a tea break. It's just a small 10-minute or 15-minute tea break at the most, because we need to continue with our scientific session later on. Thank you so much.
I will say hello to her later.
Good morning and welcome back after the tea break. I'm sure all of you are awake, more wide awake after the lovely tea and cookies that they have served. So we go to the next session on prediction, and I invite the theme director for the next session, Dr. Anil Kumar Mannava, to kindly take over. Good morning, everyone. We had an excellent postgraduate session. Now moving ahead, the next theme is prediction of IBD. So for this, we are having a chairpersons. I invite the chairpersons, Dr. Devendra Desai, Dr. Rohan Reddy, Dr. Saad, Dr. Balamurali, Dr. Aditya, Dr. Srinivas. We are going to have 3 talks in this session. So no 2 IBD patients behave the same with respect to their disease behavior or treatment responsiveness. 2 identical patients diagnosed to have IBD, newly diagnosed patients, might behave differently later. One person might behave aggressively, the other's disease might be indolent. So we have few markers to predict the disease behavior, and research is going on in this aspect. So regarding this, we have Dr. Jacob Began with us to discuss on can we predict IBD. I invite Dr. Jacob.
Super. Sounds good. Thank you. All right. Thank you, everyone. It gives me great pleasure to be here. Thank you for the kind invitation of the conference organizers. It's lovely to be here, and it's been very impressive so far to see the breadth and depth of people who are speaking on this important topic today. The topic that I have to speak on today, or that I will be speaking on, is can we predict IBD? So I will just touch briefly on a few of the contributors to pathogenesis. I know that there were some people here in the postgraduate course who got a bit more of this, but it's germane because this forms the basis, I think, of prediction in the future. So inflammatory bowel disease is a group of chronic multi-causal immune-related diseases of the GI tract that we break down into CD and UC, although there are many overlapping features of these 2 diseases. The exact causes remain unknown, but as I'll show, and we build our model of the pathogenesis, there are several contributors that we have been able to delineate over time. And we generally study them together, but they really are distinct diseases. We know that the worldwide burden of inflammatory bowel disease is unequally distributed, where we see very high incidences and prevalences in the developed world, in North America, Europe, Australia, where I come from, but we see also these increasing incidences around the world as well. And this is just showing a little old now, but a heat map of the world, if you will, for Crohn's disease incidence and ulcerative colitis incidence. On the left-hand side are some old studies, but I like them because they put together multiple countries showing this steady increasing incidence of inflammatory bowel disease in many places around the world where we can measure it accurately and measure it over time. And I think this graphic on the right-hand side has been shown in countless talks showing the increasing incidence in the Western world. And although inflammatory bowel disease was really recently or more recently described in the developing world, we see this rising incidence and compounding prevalence. Genetics has been an area of inflammatory bowel disease research that has been really fruitful, and I think that this was driven by a couple of things. One was the early characterization of very large family groups and looking for causes of Crohn's disease among Ashkenazi Jews in large pedigrees, which was really quite a powerful way of coming up with our first IBD gene, IBD1, or also known as NOD2. But since then, there's been the advent of next-generation sequencing, the widespread use of GWAS studies, and the construction of really impressive collaborations around the world where tens of thousands of patients have been recruited into things like the IBD Genetics Consortium to allow these large studies to be done. And that's allowed us to find a multitude of genes that contribute to this disease, over 250 by latest count when you look at the meta-analyses. And these have shown that there are some genes that are specific to Crohn's disease, some genes that are specific to ulcerative colitis, and a lot of genes that are common to both that are interestingly in that they overlap with other inflammatory conditions and infectious conditions. And the next slide, here we go. And then the other factor of pathogenesis that I want to touch on is the microbiome, which we'll hear more about in other sessions, but just in one quick little slide. This is one study that was done looking at new onset Crohn's disease in a pediatric population, a very clean cohort, if you will, of newly diagnosed patients, showing that we can see an increased abundance of some bacteria, a decreased abundance of other bacteria, and what's coming and emerging more these days with the multi-omics capabilities that we have is that we can start to find microbial pathways that are actually driving some of these processes, and that's a very interesting area of research to better understand. It's not necessarily which bug is there, but what they're doing in that space that's important. The other key important part about inflammatory bowel disease is the environment. We've seen this increasing incidence around the world. It can't be explained by genetics, which remain relatively fixed over the time spans that we're talking about, but rather environmental exposures must be driving this increasing incidence that we see in disease. On the left-hand side is a sort of a Venn diagram of some of the protective factors that we know about and risk factors for Crohn's disease and ulcerative colitis. There are some things that are common. For example, breastfeeding is protective for both Crohn's disease and UC. Smoking is one of those variables that has opposite effects in Western cohorts, at least, where it seems to be a risk factor for Crohn's disease, but perhaps protective for the incidence of ulcerative colitis, and a variety of other factors to boot that have been studied in areas all around the world. On the right-hand side is the emerging idea about where these risk factors fall in terms of the developing person, if you will, from prenatal exposures to perinatal to exposures during infanthood, early childhood, and then adulthood. And we can see where some of these various factors fall on that chart. So this then is the model we have of IBD pathogenesis, if you will, that there is a genetic susceptibility in the host, that then through the exposuresome or the exposome in the environment and diet, we see microbial changes that emerge, and then the ultimate phenotype, if you will, is this state of immune dysregulation, a loss of tolerance, activation of the immune system, which then has this feed-forward loop of activity. All right, so, but now to the topic at hand, which is, can we predict the risk of developing inflammatory bowel disease? And it's been exciting times in recent years because there's been a lot of new data that's come on the scene that might be getting us closer to this goal, which is a very important one. I thought I'd start off with just a couple of my own cases that I've had in just the last few years. One was a young woman I took care of last year, an 18-year-old female who was admitted to hospital, bloody diarrhea, and was diagnosed with acute severe UC. Interestingly, her older sister was diagnosed with ulcerative colitis at age 19, 2 years prior to this. Was this a patient who we could try and predict the risk of developing IBD? Another one was a 20-year-old man who I had in my clinic who had abdominal pain and intermittent diarrhea. He had a calprotectin that was maybe a little bit above normal, but not alarmingly so. He had a normal colonoscopy, but his father has ileal Crohn's disease. How can we risk stratify this patient and manage them over time? So I'd just like to talk about genetics as a predictor of Crohn's disease. I think that some things that we have to recognize in genetics that make this a little complicated are that mutations, or if you will, polymorphisms, which is what we generally talk about, the effect of those depend on the penetrance of that gene and the expressivity of that gene. Let me see if this pointer works. Oh yeah. So over here, if you had a gene that had complete penetrance and narrow expressivity, then everyone who had that genetic mutation would have the phenotype and it would look the same in everybody. That is very rarely found in nature. More often or not, we have incomplete penetrance where some people express the phenotype who have the gene but others don't. We have complex and broad expressivity where some people have a very severe form of the disease, others have more mild disease, and then when you put it together, it can be very hard to predict, given just the presence of a genetic loci, what's going to happen. One exception to that rule might be very early onset IBD. VOIBD is defined as an IBD diagnosis less than age 6 years of age, and in those patients, up to a third of those cases are due to monogenic gene disorders, and perhaps actually it's even higher than that, but it's just that we don't know about the causes, the structural implications of genetic mutations in other genes. If you look at extremely early onset IBD, which is less than 2 years of age, then up to 40% of those cases are monogenic that can be identified. And nowadays, in young patients like this, whole genome or whole exome sequencing has become the standard of care. And then shown on the right there are just some of the genes which broadly fall into categories of adaptive immunity, as we heard about earlier, epithelial barrier dysfunction, autoinflammatory disorders. I think we'll probably remember from medical school the XIIP and NLRC4 mutations, and then also bacterial recognitions and innate immunity. What about more common IBD that we generally see? Well, if you look at the GWAS studies, this is from the original Jostens paper on the left-hand side, and I just wanted to highlight a couple of things, which is, as I mentioned, a lot of the genes contribute both to Crohn's disease and ulcerative colitis, with rare exceptions, that the effect size on the y-axis over here is actually quite modest for any individual mutation. So how do we approach this milieu when we have 250, 300 genes that might be contributing to the risk? Well, we often will go to construct a polygenic risk score, which basically means that we take each one of the individual risks of a polymorphism and sum them together to get an overall risk. And then after we've done that on one cohort, we go and validate it on another cohort to see how these polygenic risk scores work, how well they work. But there is a little bit of a problem with this. A lot of the genetic studies that have been done in past decades have relied on European populations and North American populations, and we've learned that Crohn's disease and ulcerative colitis in Europeans, the genetic architecture is not the same. If we look at the biggest gene effect in European cohorts, it would be NOD2, which has no effect in East Asian or Southeast Asian or South Asian cohorts. Similarly, IL-23 receptor polymorphisms, which are protective in Europeans, have no effect in East Asian cohorts. And instead, we see a dominant role played by the TNF superfamily 15 members, as well as HLA loci in the case of ulcerative colitis. So polygenic risk scores that we derive in European cohorts might not apply so well to India or other parts of Asia and the developing world. And in fact, this was a nice study that was done a couple of years ago looking at that exact question, and their polygenic risk score performed quite well in European populations, which is in the blue line in the middle here, where we see that it can predict in terms of what the polygenic risk score is, what the actual IBD frequency is. It also performs fairly well in Ashkenazi Jewish populations, but when applied to African American or Hispanic cohorts in the United States, it performed quite poorly. So we do have to develop a polygenic risk score if we're going to use it, using data from that region that we're applying it to. This was a study from the UK Biobank, which I thought is an excellent study. First of all, UK might have gotten some things wrong, Brexit, et cetera, but this study, the UK Biobank, it got really right. It was an excellent use of resources, collecting data and biospecimens on 500,000 patients recruited between 2006 and 2010. During that time of follow-up, there were 707 cases of CD and over 1,500 cases of UC in the follow-up period. And that's a huge ability then to look at these new cases that have developed, tracking their environmental exposures, looking at their genetics, and as well as a lot of other biomarkers. And in this study, they found that in their population, if we look at the genetic risk, that people in the high genetic risk category for Crohn's disease had a hazard ratio of 2.2, and for UC 2.15, so that's performing fairly well. But interestingly, when they looked at the lifestyle factors, they found almost similarly hazard ratios, high hazard ratios approaching 2, and these actually modified genetic risk significantly. And perhaps some of the problems we have with applying polygenic risk scores and trying to risk stratify patients is we're not taking account of the environment. And just to delve into this a little bit more, these is what it looks like when you distribute patients with respect to genetics in terms of the high risk, moderate risk, and low risk for both ulcerative colitis and Crohn's disease. So Crohn's disease is on the top, ulcerative colitis on the bottom. These are the genetic risks, and these are the environmental risks. And I'll just draw your attention over here to the incidence of Crohn's disease. If you look at the high genetic risk group here, and they have unfavorable lifestyles, the hazard ratios are almost 4, whereas if they have favorable lifestyle factors, smoking, diet, et cetera, that halves the hazard ratio. So it shows this strong interaction between the environment and genetics and how we might be able to actually modify genetic risk if we find it. Microbiome. So the GEM cohort is another inspirational cohort study that's been performed in Canada. This cohort recruited first-degree relatives of IBD patients who didn't have IBD, recruited between 2008 and 2017. And they have 5,000 first-degree relatives that are in that, but from the microbiome cohort, there were almost 3,500 first-degree relatives, of which 73 developed Crohn's disease. And from this, they could derive a microbiome risk score, just like we would derive a polygenic risk score, and then they can apply it to their cohort. So they did 2/3 for discovery and 1/3 for validation, and you can see here on the right that patients who had the high risk of the microbiome risk score have a higher likelihood of developing IBD in this Kaplan-Meier survival curve. But I will just point out that, of course, on the y-axis here, this is still a very low percentage because overall not many people develop Crohn's disease, even in this high-risk population. The same cohort, the GEM cohort, also looked at potentially biomarkers that allow us to predict. And so again, in this higher risk cohort of first-degree relatives, they looked at intestinal permeability using a lactose mannitol drink, and then looking at urinary secretion at ratios. And what they found is that patients who had an impaired barrier function, increased intestinal permeability, were more likely over time to develop Crohn's disease, showing this might be an early biomarker for patients to say you're at higher risk of developing Crohn's disease. Again, pay attention to the probabilities on the right, because the overall probability of getting Crohn's disease is still low. Another approach is serum biomarkers, and this is another cohort that's really quite impressive, which is the PREDICT-S cohort. This is a cohort of US military workers who are required to give serum samples periodically that are stored in a big biobank of the US military, and Jean-Fred Colombel and colleagues went back and looked at patients who got diagnosed with Crohn's disease. What did their serum markers look like previously? And so they had 200 patients with Crohn's, 200 with UC, and 200 controls, and they assessed those serum samples and ran them through an antibody panel, the Prometheus panel, as well as the SomaLogic, which is a marker of over 1,000 serum proteins. And what they found is that there are, I'm sorry, went back too far. That they could come up with a scoring algorithm based on these antibodies or with these serum proteins that actually performed not terribly badly when you look at the ROC curves for predicting disease. The best performing one is the one just 1 year before diagnosis, but even up to 5 years before diagnosis, there are signals there. There are additional biomarkers that have been done through their studies as well as others. So in addition to ASCA, it looks like anti-GM-CSF antibodies appear quite early in Crohn's disease, and in ulcerative colitis, anti-alpha-4 beta-6 antibodies seem to come very early and increase. That should be 20%, not 200%. Whoops. There's a variety of other biomarkers as well listed here that have come out of some studies looking at prediction. And so we end up with something like this. The name of the goal is, I think, to define and detect preclinical IBD. So before someone has a diagnosis, they're in a preclinical phase where they have altered intestinal permeability, altered microbiome, in a genetic risk, and that we might be able to find these people before they get their actual IBD diagnosis and hopefully be able to intervene. So, for my conclusion then, a model for predicting IBD, are we there yet? Not quite, but this is what I think a predictive algorithm might look like. We can identify people at increased risk of developing IBD. That includes first-degree relatives, genotyping on a population scale and applying a polygenic risk score that's applicable to that population, microbiome profiling, maybe using a microbiome risk score to define risk, and then exposome profiling. There are standardized questionnaires that have been developed to look at risks from the exposome point of view. Then monitor for preclinical IBD. Look for seroconversion of serum antibodies like ASCA, anti-GM-CSF for CD, and anti-alpha-V beta-6 for UC have been identified in multiple studies, but I'm sure there's more to come. And then maybe, or not, there might be a role for endoscopy or cross-sectional imaging in these patients. And I think, as an ultrasound, intestinal ultrasound advocate, that might be a really good role, actually, for intestinal ultrasound to look for emergence of disease, as well as more traditional biomarkers. So, the last thing I would say, that predicting IBD is only useful if we can intervene and prevent it. And I guess I take a little bit of hope from the UK Biobank study that showed that those modifiable environmental factors can really modify the risk. But also we have to think that any intervention that we propose really has to be a safe intervention. Diet is great, but if we're thinking about giving medicines to these patients, I think we have to be very careful about what we do so that we don't induce any harm in trying to prevent IBD. So thank you very much for all of your attention. And I managed to finish before the dreaded beep. Great.
So, very nice talk, Jacob. And any questions, please?
I think I see one in this row here, yes.
Sir, wonderful talk. I just wanted to ask, the recent study from Dr. James Lee group, which had showed that the ETS2 transcriptor factor in the macrophages, that is predicting some sort of a phenomenon which is associated with IBD. Sir, how the study changes the practice scenario?
Oh, well, I don't know if it changes the practice yet, but it's really quite exciting data, actually. And it's this area of the genome that was quite often ignored because it's sort of in this gene desert area, and it seems to have a big effect on the immune system, macrophages, et cetera. And how widespread that's going to be when we start looking at large populations around the world will be interesting to see. So it's still in the developmental phases, but I will be watching it very carefully because it really does seem to have quite discrepancies between impaired and normal function of this gene, and whether or not that would be functional assays that we're going to be using and how you can apply that to sort of broad-scale clinical testing. We'll see how it emerges, but it's a very exciting space and a great publication if you haven't read it yet.
Dr. Santosh from here. So, as you mentioned, most of them will have genetic background, but they may not be phenotypic expression. So, from your Australian cohort, how many of your IBS patients are going to have IBD if they have wrong lifestyles?
Yeah. So within my own practice sphere in Australia, we're expected to hit a prevalence of 1% by the end of 2030, which is going to be a truly large number of patients for our small island country. And it's just going to be by happenstance that a lot of IBS patients will also have IBD, I guess. IBS prevalence is about 30% of the Australian population. So it's still the case that most patients who present with abdominal pain and irregular bowel habits are going to have IBS. And so discriminating these two. Fecal calprotectin has been such a great test for us in Australia in discriminating between IBS and IBD. So if the fecal calprotectin is less than 50 and they present to their general practitioner, then that's it. They go down an IBS pathway and never make it to a gastroenterologist. It's really only the ones that have a mildly elevated fecal calprotectin that make us to us.
So, one more question. Do you do genetic sequencing in all of your IBD patients coming to your practice to assess for the severity? If they have not to GOT15 gene mutations, you know that they are going to go through a rough time.
Yeah.
So early use of biologics in these patients, when even if they come with a mild disease, can change the profile of the patient over a long period of time.
So
it's still recommended.
Yeah, the question is, should we do genetic testing in order to predict the course of disease? That is actually a topic that's coming up in this session, so stay tuned. My own take on NOD2 is that NOD2 is a great marker of ileal disease. Ileal disease is a good marker of badness, and so if you have someone with ileal disease, treat aggressively up front because they're likely to have a bad course of disease. We do, though, I would say, as I said in my talk, for patients under the age of 6 who are diagnosed, we do genetic screening just to see if there's a monogenic disorder.
But not as a routine screening
No.
for all IBD patients, no.
So with that, we will stop as we don't have time. And you will see Dr. Jacob in action tomorrow for bowel ultrasound also.
Yes, that too.
And I must say he's a great teacher.
Okay, next we have Dr. Kiran Peddi, who is going to talk about the best bang for your buck and how to be cost effective for your patients in the Indian scenario.
Good morning, good afternoon. So my talk is more of practical aspects of management of IBD rather than clinical. And some of the concepts are kind of my own and derived from some of the data which is floating around in the industry and among the patients and among the clinicians. So is IBD setting in India different from Western countries? With the experience of working in both UK and Australia, I would say it is definitely different and completely different in fact. So how is it different? So quite often we run into a scenario where patients go to their primary care physicians and then other doctors, and the quite significant delay in diagnosis, especially the confusion which prevails among patients with infectious disease such as tuberculosis and with relation to Crohn's. And quite understandably, patients do suffer a lot and then they keep changing the doctors. That will just add on to the delay in diagnosis further. And as we discussed before, India is seeing a steep growth in the incidence of inflammatory bowel diseases, and still lack of awareness among physicians and histopathologists is just kind of getting better, but there's still a lot of scope for improvement. And even among the gastroenterologists, there's a lot of interest in IBD and other advanced procedures, but not so much so when it comes to inflammatory bowel disease. So there are only few people with interest in IBD and few dedicated IBD centers. And from patient's perspective, there is significant cultural differences and the stigma of having a bowel disease, which often puts the patient off and they will be hesitant to report to their family or even to the doctors. And somebody mentioned before that the treatment of IBD is quite expensive. So we'll dwell on it a little more in detail in few minutes. So this is a nice article written by one of our patient advocate, Madhura, and few of our faculty or co-authors in that, like Shaji Sebastian, Deepak Parakal, and also Vishal Sharma. So they quite nicely laid out what are the different challenges which a IBD patient faces across in their journey. For example, lack of IBD specialists, diagnostic delays, and cost and lack of insurance coverage, and so on and so forth. And at the same time, this will provide a lot of insights or opportunities for doing research among clinicians. So why is it expensive? So we keep on saying that IBD treatment is expensive, but why is it expensive? So if you look at it's just an interesting analysis, and the share of people waiting for 1 month or more for seeing a specialist appointment is quite significant when it comes to other countries like Canada, Norway, and other Western countries. As you can see, India is not featured in there at all. So the waiting time to see or getting common surgery done vary from less than a month over a year. And then again, India is interesting, not featured in at all. Why is that? Because there is no waiting time in India, and it's about -1 week. And last week we had a patient in our clinic who walked into my clinic, and he put in a large complaint because he had to wait for 2 hours to see me. So he put in a large complaint. So that's what the patient expect. And when it comes to IBD patients, it's even more prominent because the patients will be having a lot of symptoms. They have to go in and out of toilets, and lots of complaints can be faced. So the waiting list doesn't exist in India. But still it's expensive. So why is that? Because the public insurance covers limited number of conditions, and it's restricted to few centers, government centers. Private insurance is not widely taken up. And we had a chat with Dr. Ajit Sood and among CCFI members before. IBD is excluded by majority of the insurance companies, and then logistically lots of work going on to address this issue. So India is treated as one of the most kind of rapidly developing economy and one of the powerful countries across the globe. But if you look at the GDP per capita among G20 countries, it's still very low. You can see it's about $2,000. So $2,000 compared to other countries is still very, very low. So for an intervention, for a drug to be effective or cost effective, as per WHO criteria, if you are talking about something which is costing less than 1 GDP per capita, it is cost effective. But anything once it crosses more than 3 GDP per capita, it becomes expensive. So in absolute terms, this translates to something like 2,000 to 6,000 rupees. Whatever intervention you're talking about, that has to fall in this narrow range. So as soon as it crosses 6,000 rupees, that becomes expensive as per the norms. So where does this cost go? So we say that the cost is enormous, but if you look at where does this cost go in management of IBD patients, the majority of the cost is, you can see, goes in usage of biologics and hospitalizations and surgery. So if you can do something to minimize the cost or improve the cost of biologics and then minimize hospitalizations, minimize surgical interventions, the cost of care can be better. So how do we do that? So there are lots of options we can explore. So this again, a cost analysis in the same article which I just quoted. You can see different prices which is given for different interventions we're talking about in treatment of IBD patients. We'll look into that. So we all agree that we need to intervene early in the management of IBD patients, so we get a narrow window of opportunity, and not only in Crohn's disease and also in ulcerative colitis. Even in ulcerative colitis, it's supposed to be a progressive disease, and we need to intervene at the right window of opportunity. We need to take that. Otherwise, we are dealing with a lot of complications, more and more complex journey of the patients, and they end up spending more of economic resources, financial resources, and a lot of psychological trauma these patients undergo. So once you want to intervene, then you decide on your approach. I know there's a lot of debate on when to go for step-up or top-down therapy, and now we are talking about, Shaji will be talking on profile trial and other things. But grossly speaking, we need to be very clear in our mind what kind of strategy we are going for, whether going for step-up or top-down, because that will determine what are going to do next for our patients, which is vaccinations. I'll come on topic of the importance of vaccination in a minute, but you need to decide on what kind of vaccinations you need to give to patients, whether it's yearly influenza or one of pneumococcal, HPV, meningococcal, HPV and Tdap, Haemophilus influenza, zoster, and also now we have shingles recombinant vaccine available in the country. So you need to decide on that. Then you decide on the timing of these vaccines. Ideally, all these patients should get vaccinated at the time of diagnosis, because we never know when these patients are going to require immunomodulators or biologics in the journey. So we need to be ready for the patients and who are immunized with all the vaccines. If the patients are already on immunomodulators, at least we vaccinate before biologics, because the efficacy of vaccine, the immune response will be lower in patients taking biologics compared to immunomodulators. And pneumococcal vaccine, 8 weeks gap between 13 and 23, but if the patient comes to you, as I said, the patient might have seen many physicians or gastros before they came to you. You need to give a gap of 1 year between 23 and 13. Most of the vaccines can be given on one sitting, but again, patient will complain a lot of pain, logistics will be a problem. Children born to mothers on immunosuppression should be avoided live vaccine for 6 months after the birth. So as I said, we're talking about immune response in patients with on monotherapy, and there's slightly higher compared to monotherapy with TNF, and patients on combo therapy have an even lower immune responses when it comes to vaccinations. So decide what is your patient on, know what is your patient taking. If he is not on any immunosuppression, that means not on any immunomodulators or biologics, you're talking about no immunosuppression. But the patient is on Vislone less than 20 milligrams or azathioprine or methotrexate, you're talking about low immunosuppression. High immunosuppression, if the patient is on anti-TNF already, that comes under high immunosuppression. And we have special group of patients who are pregnant, children, and travelers. So these are different kinds of vaccination I was mentioning about, the mode of the vaccine administration, how frequently you need to give. And you can get this data anywhere on internet or anywhere else. So if the patient is not on immunosuppressants, this is the data for patient is on immunosuppressants. So we can't give live vaccines on patient is on immunosuppressants. So the patient is not on immunosuppressant, you have free hand to give even vaccines like MMR, varicella, and zoster, and above 450 is the recommended zoster vaccine now. The Shingrix, which is by GSK, has got into place into Indian market now. So on top of this, all the other vaccines which are seen in category 1, which is early category, can be given. So you need to defer, sorry for the spelling mistake there, so you need to defer immunosuppression for at least 4 to 6 weeks after live vaccines. And varicella and zoster vaccine can be considered if low level of immunosuppression, if the patient is desperate. And patient need to be staying away from vaccinated person with a rash. So coming to cost analysis of these vaccines, you can see I just selected randomly, no preference to any companies here, but I just put the data which is available in the market. If you think about the different companies available and what is the cost of these vaccines, the MRP if you look at. So even if you nail down all these vaccines, it is going to cost you about 18,000 rupees, which is one-off most of the times. And on top of that, you may be having yearly influenza vaccine, which is not much anyway. And other group of vaccines, which would cost around 33,000. So the total cost of vaccines is, you're talking about 50,000 rupees. And if the patient unfortunately ends up with one hospital admission with opportunistic infection, we are talking about, even if the patient stays for a couple of days, we're talking about a financial burden of at least 1 to 2 lakhs. So once you decide on the vaccination, you do administer vaccine, you make the best use of what are the available drugs which are made in the market, 5-ASA, be it azathioprine, biologics, tofacitinib, or trial drugs. So when the patient is on 5-ASA, especially with ulcerative colitis, we need to optimize the dose, and we need to choose the right. We had a fantastic discussion this morning, moderated by Dr. Ravishankar and other panelists, route of administration, right form. And coming to azathioprine, not widely used in Western market, but in India, it still can be a boon for patients on azathioprine. So these are the picture I copied from ECHO website actually. Azathioprine still can induce remission in Crohn's patients and also in ulcerative colitis. And stopping azathioprine can lead to a relapse. So we're talking about continuing the medication for a few years. And azathioprine can also induce mucosal healing up to a certain extent. So, but before you start the patient on azathioprine, please do TPMT and also NUDT 15 in our patients, which can cost around 15,000 rupees. But if you think about the risk of leukopenia, some of the times we see quite often, I had a patient who spent almost 40-50 lakhs because he's had an hospital admission running up to 6 weeks because of immunosuppression and leukopenia, sepsis, all these features. So this can be prevented by spending about 15,000 rupees, and that will be very, very cost effective. We know that TPMT shows a polymorphic distribution of activity, and most of the time we have normal activity, 90% of them will have normal activity, and very high activity seen towards the end, and zero activity on the other end of the spectrum. So based on this, based on the levels of TPMT, and we can decide the dose as well. We don't need to give full dose for patients who have low activity. We can reduce the dose for better optimization. We don't have TDM available everywhere, except from some centers like Dr. Desai Center and some other centers across the country. But if you don't have access to TDM levels, measurement of therapeutic drug monitoring for azathioprine, this is a poor man's TDM. A change of MCV of 7 femtoliter is associated with therapeutic TGN levels. So if the patient developed or showed a change in MCV of 7 femtoliter, at least we can be reassured reasonably that patient is having a therapeutic window with the drug. Once decide to go on anti-TNF, they should be used very early in the course of the disease. So it's an interesting chart. If you see the postgraduates, especially if you see the initial trials which are done like Accent 1 and CHARM studies, the remission rate shown at 1 year is only something like 20 to 40%. But in the recent studies, it is reaching up to 60%. The main reason for that is the recent studies recruited patients early into the course of the disease rather than late into the course of the disease. That clearly shows that the early you start anti-TNFs, the better the results. Early aggressive therapy versus step-up therapy is we all come across. And once you achieve mucosal healing, is associated with long-term beneficial effects for these patients. And reduce long-term cost, long-term surgical requirement, and other complications. If the patient can't take original drugs, the biosimilars are also available in the market. If they're cheap, you can work on them. You can do your own maths. You can do, you can bring best of the worlds out of the biologics. You can mix and match. Sometimes loading with original molecule followed with biosimilar, which can be taken outside the hospital, can be cost effective. And you need to explore patient support programs which are offered by many pharma companies, explore opportunities like crowdfunding, and you can opt for proactive TDM versus reactive TDM. So if you think patient is kind of losing response, you go and ask for TDM levels so that you can at least modify the drug dosing and then or change the drug if required. Rather than waiting and giving the same drug for 6 months, 1 year and wasting all the resources, you would rather be proactive and then change the drug or change the dose. Not every patient. So you given the drug, you given the biologics, but at some point you need to think about stopping these drugs. And the proportion of these patients would relapse when you stop the drug, but not everyone would relapse. So a significant proportion of these patients may remain in remission. Of course, you're talking about stopping the drug only after achieving remission, and they can still remain in remission for significant amount of time, even after stopping the biologics. You need to know how to use your surgeons effectively and wisely. This is an interesting lyric trial, as all of us know. Patients with limited ileocecal disease, sometimes surgery may be a good option. There's a study comparing about 60 patients in one arm with infliximab and 17 other arm. Primary outcome was negative, and that's a quality of life. But secondary outcome, the cost effectiveness was better with the surgical option. But we need to counsel the patient that this is not a curative option. The patient still might need a post-operative preventive prophylaxis strategy. So what I do personally, somebody coming with newly diagnosed and naive to immunosuppression, I start with 5-SA, of course, in ulcerative colitis, and complete vaccination, both live and inactive, and whatever is deficient with the immunity, and medication-specific screening just before the requirement. For example, if the patient requires azathioprine, I do TPMT, quantiferon gold if the patient requires biologics, and we need to I need to emphasize more on household contact vaccinations as well. If the patient is already on immunosuppression, I do immune testing. What are the kind of serology of these patients? What are they immune to? And if need be, I stop for 3 months and we vaccinate and start 1 month after stopping. You can start the immunosuppression as well. If the patient is immune for varicella zoster and MMR, and just stick to annual flu and pneumococcal and HPV vaccination. If the patient is already on biologics, when he comes to me, it's a difficult call. I can't stop the biologics because the patient can flare up the disease. On the other hand, I just watch carefully for any life-threatening infections and counsel and report early. Low threshold for stopping biologics in the event of any significant fevers. So the message is to watch out. Patient can't afford vaccinations. Well, I mean, in that case, can't afford biologics by default. So it's all the more reason to vaccinate these patients. If they can't afford biologics, I mean, that's more reason to vaccinate these patients to prevent any complications. And you can always talk to pharma companies and then get into some kind of support programs for these patients. So how to get best for the buck? Avoid delay in diagnosis and treatment, comprehensive teamwork, MDT meetings, second opinions. Patient education, very important. You set the scene at the beginning so that the patient have realistic expectations, what they're getting into, and how long the disease is going to be, what are the options and all. Use the drugs in most effective way. Stop expensive drugs whenever appropriate. The patient not requiring, stop whenever it's appropriate. Prevent potential opportunistic infections by robust vaccination. Prevent from complications with medication related or disease related. That requires regular monitoring of these patients. Anticipate loss of response by doing proactive TDM. Use your surgeons effectively. And remember, the most cost effective measure in India is doctor consultation. We all know that, the doctor consultation in India for, the international faculty might get offended, but it might cost about $10 for consultation. But in the $10, you get one more visit free, and you also need to take about 10 calls and 20 WhatsApp messages. So with that, I'll close it. Thank you very much.
That was a very lucid presentation, Dr. Kiran sir. The floor is open for questions if anyone wants to ask.
Kiran, fantastic talk, thank you. I just wanted to know about that cost aspect which you quite rightly highlighted. Do you think the downstream costs and the cost which is to the society, to the the economy in relation to time spent out of work, etc., are factored in? And isn't it time to develop India-specific data from people like you?
Absolutely. There's deliberately avoided the topic because it's a huge topic, because the loss of man hours, because these patients, unfortunately, they will be suffering and they can't go to work. And especially we do come across patients who are drivers who can't drive, and because they are suffering all the time. So they won't be in employment, they'll be losing the job. So it's a big financial burden, and a lot of economics goes into that aspect. So I don't know how to overcome that factor, but we need to, with the hoping that once you initiate the treatment appropriately, once the patient is in remission, if you avoid the delay in diagnosis and treatment, at least they can maintain the jobs or the employment can be taken up.
This has been slashed actually. So when comparing the quality of life, we can start tofacitinib very early. So how much duration can we keep the patient on tofacitinib? So what is your experience regarding that?
Right. Again, with the lack of time, I didn't talk about tofacitinib, though I showed in the initial slide. And most of the guidelines say that tofacitinib should be used only when the patients fail on biologics. But in Indian circumstances, all of us do practice. The patient can't afford biologics. You're really pushed to the corner. Patient doesn't want to go for surgery in ulcerative colitis. And all of us do use tofacitinib in an effective way, and a lot of patients would show response. Once you start them, then again, there is no definite endpoint of treatment, but we follow standard protocol of 3 months loading dose and then going on to maintenance therapy. And then I tend to stop it. It's new drug. I haven't stopped in many of the patients yet, but probably we should think about stopping once the mucosal healing is achieved. And I don't know, Dr. Sood has got anything to add. He's got a fantastic study done on usage of tofacitinib on acute severe UC.
Yes, I agree. I think we should aim for mucosal healing, and that is the time. But we should try to put a patient maintenance dose after 2 to 4 weeks. Not beyond 16 weeks in any way.
Right.
Sometimes all of us may have to educate our patients because we have a trial. We request patients to get into the trial, which is a vedolizumab biosimilar versus the originator, and patients don't come into the trials. So imagine something. I think we all need to educate our patients to get into these sometimes.
Very valid point, sir, because the myths around getting into trial is quite significant in India at least. And in my opinion, I'm sure all of us agree, in my opinion, getting into a trial, if there is an opportunity, it's a fantastic opportunity. Because not only the drug, the cost effectiveness will be there, and also you need to think about a lot of investigation which can be cost effective, and a lot of team members will be looking into your case study and all. So a lot of inputs can be brought into patients who are into trial medication. The vedolizumab trial is a fantastic one, but again, because of apprehension, that's always a difficult task to recruit patients.
All right. Thank you, Dr. Kiran sir. We'll move on to the next talk.
So we invite Dr. Charlie Lees from UK for the next talk. His topic is precision medicine and IBD. What is practical?
Thank you very much indeed. I'm really very deeply humbled and inspired to be here with you all today over this weekend. My first visit to India, I just wish I could stay a bit longer. So I'm going to talk about precision medicine for inflammatory bowel disease. If I could have my slides on the screen, please. Thank you very much. I want to start by presenting a case to you, a 20-year-old man. I look after his father, who has the worst Crohn's disease I've seen in my 20-year career. I look after his two sisters, and he presents to me. I diagnose panenteric Crohn's disease. I go straight for a top-down approach with infliximab and azathioprine already back in 2017. But despite this, and despite then multiple other therapies, he still ends up with a spontaneous perforation requiring an urgent colectomy and ileostomy. And even after that, 6 months post-operatively, despite being on 4 weekly Stelara, he has a rampant recurrence. And it's taken another couple of courses of medicine to finally get him on the right drug therapy. To me, this really illustrates the urgent unmet need we have in IBD, even with the best therapies we have available to us today, using what we believe to be gold standard treatment strategies. And it's everything from the awareness to the equity of care to breaking this therapeutic ceiling to the stratification of patients, which I'm going to talk about today. But I want to start with this overriding message, and I've seen this already in abundance, my visit here so far, that every person with IBD deserves the same high-quality, compassionate care. IBD does not discriminate by geography, by biological sex, by race or wealth, or anything else, indeed. And it has a profound impact on the individual's life, from the physical symptoms to the psychological aspects, to the fear of the long-term complications of the disease. Remember, these are highly heterogeneous, truly dynamic, and unpredictable conditions. But for the person, it's the impact on everyday life that can be so very profound. And so, yes, we want to aim for healing of our patients. What does that mean? It means treating symptoms, controlling the inflammation, minimizing steroids, keeping our patients out of hospital, preventing the disease from progressing, decreasing surgery and stoma formation, and minimizing complications of drugs and disease. And we now have a wide range of therapies to treat our patients with. Conventional therapies, yes, but also now biologics, 25 years of anti-TNF, with biosimilars, newer biologics, and small molecules too. Before we had all these, we had ineffective therapies, we had too much steroid prescribing, our patients had a poor quality of life, and treatment targets were non-existent. Look at this data from Corey Siegel from the USA from about a decade ago, where already you could see patients with UC sequencing in between 5-ASA and steroids, going back and forth without going on to proper therapy. And even when we introduced infliximab and adalimumab 20 years ago, we didn't know how to use the drugs properly, and they were too expensive. But this has all changed. We now have this wide depth of data showing us that these drugs can work well, how we use them best, and how we keep them working over time. So biologics, new therapies, all helping us to get our patients better. But with that background, we have a really big problem, because we have very unpredictable diseases that are highly heterogeneous and dynamic. They change over time. So we want to be able to predict. We'd like to stratify our patients by aggressive versus quiescent disease, by drug response. Are you going to respond, yes or no? Are you going to respond to drug A, yes, or drug B, no? Or what about the complications of the disease and of the drugs? When I counsel my patients about the complications of a drug, the first thing I do is I tell them about the complications of their disease and how the inflammation over time, if untreated, leads to the biggest danger for the patient. So this is what we want: precision medicine. Right drug, right patient, right time. And unfortunately, right drug to right patient is mostly, at the moment, guesswork. But we can do right time. And the right time in Crohn's disease is early. And in fact, early is very early. Crohn's disease is progressive, much more so than ulcerative colitis. Inflammation at the start progresses to strictures and to fibrosis and to abscesses over time. These are the data we published from the International Genetics Consortium 10 years ago. You can see 10, 20, 30, 40 years after follow-up. This is what we have seen. Here's that static image on the left. Disease location, relatively constant. But disease location also then determining risks of progression with surgery. Look at the risk of progression to surgery if you have ileal disease in the red or ileocolonic in the dark blue versus pure colonic disease in the light blue. This is mostly in the pre-biologic era, so it teaches us about the natural history of the disease. So we should treat early. This is another version of the chart Kiran showed you. Early trials, early treatment trials show better effect. And profile is now the key piece of data that shows that. If you treat patients with Crohn's disease 2 weeks after diagnosis, 14 days after diagnosis, with infliximab plus with azathioprine here, with a top-down approach, they do so very much better, 80% corticosteroid-free remission versus 15% in a step-up algorithm. Fantastic. And this is what we've been doing in Edinburgh for the last 10 years. I started working in IBD in Edinburgh 20 years ago. At that point, a new patient with Crohn's disease was only getting onto a biologic about 10 years after diagnosis, if at all. In 2005 to 2008, if you were newly diagnosed then, your therapy got a bit quicker. 2009 to 2013, it gets a bit quicker again. But in 2014, we got biosimilars. That changed the game completely. That allowed us to practice what we had wanted to do already for 5 years and change the treatment paradigm, to give therapy earlier. And this is how I've practiced for 10 years. I know that Seb's done the same. And with this, we're starting to see surgical rates drop. Look at the surgical rates, the time to first operation in that most recent cohort compared to the earlier cohort. It's falling by a half. Not just surgery, but hospitalizations too. In our IBD patients in Edinburgh, hospitalizations for IBD flares falling. Hospitalizations in IBD patients for non-IBD things like falls or sepsis or whatever is pretty static. So things are getting better. So early therapy in Crohn's disease works best. Does everybody need it? No. So what do we do in practice? Well, what I do, if someone has mild to moderate disease, is I might give them induction therapy and then just monitor. I want to see that the calprotectin has come down to less than 250 at the end of a year. If at the end of a year, this time point here, the calprotectin is less than 250, my patient is having much less disease progression out to 10 years. If at the end of a year, the calprotectin is greater than 250, my patient is falling off a cliff. So monitor early. If the calprotectin is normal, you're doing fine, carry on, you don't need a therapy. If it's high, get on and treat the patient. We start our moderate patients, most of them straight on to adalimumab monotherapy. We'll be using the ustekinumab biosimilar for these patients next month. But for more moderate to high risks, it's combination therapy. And after TNF, we're now going to ustekinumab and increasingly also now to the P19s. We are not using thiopurine or methotrexate monotherapy. They still do have a role, I think, in this part of the world. We're definitely not using mesalazines in Crohn's. That has no role anywhere in the world. And we've managed to get our patients' smoking rates with Crohn's disease in 20 years down from 33% down to 6 to 7%. Does the same apply in ulcerative colitis? No. In ulcerative colitis, you don't see this effect here. In ulcerative colitis, we've seen that the biologics have changed the game much more recently. This is our first biologic prescribing, 2015 onwards. You can see how it's going up, second line prescribing. And look here, look what's happening in our population now. This is first, second, third, fourth, and even fifth line of biologics with this choice that we have. But you can see it's a mess. This is in large part availability, it's cost, it's guesswork, it's not precision medicine. We'll think a little bit about persistence. This is persistence of our drugs. Vedolizumab, very, very good. In fact, in our population in UC, adalimumab, tofacitinib's not so good. Filgotinib looks good. Infliximab looks pretty good as well. And one final data point for UC, importantly, is that with these new therapies, colectomy rates are really starting to fall year on year. So in ulcerative colitis, the approach is top-and-tail mesalazine, and for the more moderate patients, well, it's a bit of guesswork, to be honest. It's availability and cost. But we use typically Vedo, Filgo, Usti, or etrasimod first line. The sick patients get infliximab or upadacitinib. But our decisions are driven here, and this is the key slide. They're delivered by cost, guidelines, availability, experience, familiarity, limited head-to-head data, network meta-analyses, real-world evidence, some conference and marketing hype, probably. This is personalizing medicine to much as we can, but it's not precision medicine. So how do we get there? How do we break the therapeutic ceiling? How do we get beyond this to get more of our patients into a deep remission? And at least some of this comes from trying to think about addressing this really important prediction problem, not just who will get IBD like Jake showed us, but how they will do after diagnosis, when they will flare, and what about the evolution of disease after. So we really would like to be able to stratify by risk and treat by biology, not by cost and availability. We have some risk factors for disease progression in Crohn's disease. Monsieur Bergerie gave us his criteria 20 years ago: age, smoking, extensive small bowel disease, perianal disease, steroids, etc. But these have not changed in 20 years, and we need to deploy the new tech, AI, multi-omics, so that we can hyper-personalize care. So we need patients from around the world to do that. The big hope was Profile. This was the first biomarker stratified study. Stunning results in the top-down versus step-up, and stunningly negative results when it was biomarker stratified. This fails to give us the answer. Maybe the answer lies elsewhere. Because in Profile, you might say, well, just treat everyone with top-down therapy. But that's no good here. It's no good anywhere, in fact, because a third of patients don't need anything. A third of patients will go into remission and stay in remission. So we mustn't overtreat everybody. But we really should learn from the last 2 decades, and the real problem is undertreating the majority, and so we're now urging, or veering at least, on the side of overtreatment. So where do we get the answers? Where do we get closer to precision medicine? Is it genetics? Well, gene hunting has moved on since Jake last updated us. We now have the latest, greatest meta-analysis from across the world with 110,000 Europeans, 1,200 South Asians. Please contribute to that from here in Hyderabad. I'm sure you can contribute strongly. 15,000 East Asians. We now have over 600 IBD genes that have taught us a huge amount of disease biology. They've taught us, from the paper we published in The Lancet 10 years ago, about disease location. We start to see a difference with the genetics in terms of UC versus colonic IBD-U versus colonic Crohn's disease versus ileoclonic Crohn's disease, and then ileal Crohn's disease, all on this spectrum delivered by genetics. But beyond that, genetics has not given us an answer to precision medicine. Will the environment give us clues? I bet you it will. What about the microbiome? We have big studies looking at this just now. In the UK, we have the IBD response study, an IBD open coming soon, to see if we can find precision medicine markers in the microbiome for drug response and non-response. But as of yet, we do not have these markers. So that's trying to predict disease severity from the start. It's also trying to predict drug response and non-response. Another question that I've been interested in is, can we predict disease flares in IBD patients? So we designed the PREDICT study a decade ago, taking patients in clinical remission, doing a deep dive into their blood, their stool for microbiome and calprotectin, lifestyle questionnaires, diet questionnaires, with prospective longitudinal follow-up over 4 years to then compare the flarers versus the non-flarers over time, particularly trying to look into diet, the environment, genetics, and the microbiota, which factors are associated with and predict disease flare. This is our cohort we recruited, finished 4 years ago, 2,500 patients, 50-50 Crohn's and UC, 40 years of age, with mostly in deep remission, but with 18% having a high calprotectin at recruitment. This is what happens to patients over time. This red line shows clinical flares, symptom-only flares. They occur quite rapidly, but hard flares, where people have symptoms and inflammation and a change in therapy, accruing about 5% per year here over the total of 4 years of follow-up. And we see the importance, the really impressive impact of calprotectin. If your calprotectin is high, greater than 250, your chance of having a hard flare is actually pretty high. So you don't want your patients going around with a calprotectin of more than 250. If it's less than 50, in the blue line, patients are doing very well. And that in-between line, that yellow line, shows 50 to 250. So you have calprotectin here, use it, test it, and then adjust based on the results of the monitoring. This is a fabulous way from getting around the treatment. I've got 2 more minutes, Chairman. We can then look at other factors that we've studied and predict. I'm just going to show you 2 highlights. One is when we look at dietary data, we find that patients that consume more meat with ulcerative colitis, this is red meat, have an increased risk of hard flare over time. We then looked at a variety of really important to our patients' questionnaires, including anxiety. We see a significant number of our patients, about 40% with moderate or severe anxiety. We see about 16% with moderate or severe depression, and you can see sleep, somatization, and exercise here. Importantly, when we look at the baseline variable, so this is, are you anxious or depressed when you enter in remission? Do you then flare? Well, we see factors like anxiety that predicts clinical flare, so not hard flare, but just a soft flare. You see depression, I'll show you that in a minute. And we see really interesting things for sleep, somatization, and exercise. So here you are. If you are anxious with ulcerative colitis or Crohn's disease, you have a very much higher risk of having a symptomatic flare, but not a hard flare. But if you're depressed, and this is controlled for inflammation and everything else, you are at increased risk of having a hard flare with your ulcerative colitis. So we need to screen and treat our patients for depression, because this is an independent factor for hard flare, as interestingly is lack of exercise in that patient population. So stress is a really important thing that we need to factor in to hyperpersonalization. So we're thinking about Drug response and non-response. We've been talking about disease severity and progression from the start. We've been thinking about the disease flaring over time. We need to think about comorbidity as well. Inflammation over time is damaging. So we need to think in totality about how we can control inflammation to prevent cardiometabolic, neurodegenerative, cancer, bowel and blood, etc., and psychiatric comorbidity. We can do metabolomic tests now that can provide very robust readouts of these on a finger prick sample, and I'll talk a bit more about that tomorrow. So to summarize, to get closer to precision medicine for IBD, we need biomarker discovery studies with deep longitudinal phenotyping of prospective cohorts with dynamic biomarker tools built in. You can do that here in India too. We need to then validate these biomarkers and clinically test them, but we need to shorten the time lag, like in Profile, where it was 15 years from biomarker discovery to testing. And we really need to tap in to this extraordinary revolution now in deep tech and artificial intelligence. But meantime, let's do what we know works really well. Treat early, monitor, and optimize. Thank you very much. Sorry for going over a little bit, Chairman.
That's a very interesting presentation, Dr. Lee. So the floor is open for discussion.
Yes, I think very nice lecture. You emphasize the role of fecal calprotectin in predicting relapse. I mean, that's a standard practice. We get fecal calprotectin for all patients at 3 months. But to a surprise, I mean, we get surprised by the disease. Even in patients who have a normal calprotectin, I mean, they get unexpected, unexplained relapses. I mean, we look into their diet, we look into other stressors, but all research fails. I mean, it's no doubt, I mean, it's a very, very good predictor, good test to assess a response. But what I point I want to say, that there is still something undiscovered that we really don't know.
Yeah, calprotectin is the best biomarker we have just now. It is not perfect. You need to follow the trends, and we're analyzing these over time. I'll talk about this some more tomorrow. And at the end of the day, we're clinicians, so if you get a very discordant result, go for the ground truth. Get the colonoscopy and the biopsies, or do your IUS. Yeah.
I was just wondering if you would comment on the role of vitamin D sufficiency in preventing relapses. I have this kind of empiric kind of feeling from treating a large number of patients that if they are vitamin D sufficient and not insufficient or deficient, that the relapses are much less.
Yeah, vitamin D is a very interesting one. It's been slightly debunked in the last 5 years, where vitamin D supplementation has even been shown not to prevent osteoporotic fractures. I think the vitamin D story has been slightly overhyped. I think for us, where we have gut malabsorption, we should screen for it and we should supplement it for where people are deficient. Personally, I don't think it has any role in disease flare, but that's partly due to a lack of really good evidence and partly extrapolating from other data sets in other disease areas, where when the gold standard evidence in tens or even hundreds of thousands of patients with longitudinal follow-up has been there, actually the benefit of vitamin D supplementation has been shown to be minimal.
There are mechanistic pathways connecting it to the
Yeah, there are. I mean, there are many, many mechanistic pathways. Indeed, it's a very, very attractive biological phenomenon. It's a very simple thing to supplement as well. So we do it. We supplement people in Scotland because the sun never comes out.
Some of us in the audience are more generic, not necessarily IBD specialists or doing other specialties like hepatology, for example. So for the more general practitioners here, have a couple of basic questions. Which IBD should we not be treating and referring on to a IBD specialist, for example? And which patient population can we continue to treat and monitor? And secondly, one specific difficulty I've experienced here in my practice is differentiating COX from IBD. And a lot of times, we have to put a lot of factors together, and we finally try to get some answers from the biopsy, but more often than not, we are left with
Okay.
a very ambivalent situation at the end of this evaluation.
So the first question I can answer. The question one about TB, I'm not best placed to answer because we have that. It's just not a problem for us locally. So there are other people in this room much better equipped to answer that. What should you monitor? What should you look after? I think if you're a general gastroenterologist, if you've got a moderate case of IBD at presentation and you initiate treatment and the patient goes into remission, and if you follow the bloods and the calprotectin, and if they are normal, then you're probably okay to keep monitoring that patient. But if the calprotectin's going up, then refer them on if that's straightforward to do. We refer all of our IBD into specialist care because the evidence is that specialist care is probably best. But anyone that has more moderate to severe disease, I would be referring on.
I understand where you're coming from in terms of not having much of COX in that part of the world, but do you face a situation where your biopsy is unhelpful when you're trying to make a diagnosis of IBD, and do you then just consider the clinical and colonoscopic findings?
So we have a weekly multidisciplinary meeting where we discuss IBD patients with our pathologists and our radiologists who drive the meeting, with our gastroenterologists, our surgeons, our fellows, our nurses, and other medical professionals, including our pediatricians, and often the rheumatologists, etc., joining in. We, in that meeting, discuss difficult cases, but we also discuss all new patients, all new diagnoses have gone through that meeting, where we will present the clinical features, endoscopic findings, imaging findings, and biopsy results, and we will then determine if we think the patient has IBD or not.
Can we predict before starting the biologicals, whether this biological works better for this patient or not? Because it's a cost of. Can you predict even before starting the biologicals whether this works or not?
So can you predict which biologic will work and whether the biologic will work? The answer is no, you cannot. What can you predict? Well, if a patient has active disease, then the biologic's more likely to work because they treat inflammation, right? All our drugs are anti-inflammation measures. What you can predict very early on is whether or not someone's going to respond by the trends already about 2 weeks in, for example, and at the end of induction. So it's the dynamic changes that I think are most important. Look at baseline, see how people go. We have a multitude of different drugs now approved for the use of IBD. I think it matters much less which you use, more that you use one where it's appropriate, you assess at the right time point, optimize if available and appropriate, and if it's not working, switch to another drug. That's the way we do it because we cannot predict at the start.
We are also doing the same way, but is there anything which can predict? Because in India, it's not cost effective because most of the patient will complain.
Yeah.
If you start on changing from one biological to other biological.
So it's very important to bring the patients along with you. In many parts of the world, I don't know what it's like here, patients will shop around for care. And they'll say, I don't want to go and see this gastroenterologist anymore because the first drug he gave me didn't work. And I went to see someone else across the road. The drug they gave me pancreatitis. So now I want you to give me another drug. So you give a drug and it's third time lucky and it works. I tell my patients at the start, not only about the dangers of active disease, not only about the risks of the drugs, but the biggest risk of this drug I'm going to give you is that it won't work. The risk of drug non-response is much higher than any risk from the side effects. And I just say, please just bear with me. I don't have a crystal ball. It might take 2 or 3 goes till we get this right. Bring your patients along the journey.
So thank you, Professor Liz. It was a very, very nice talk. And thank you so much.
An excellent session on prediction. Thank you all the speakers. Now I invite the chairpersons to hand over mementos to the speaker. Dr. Devendra Desai, please hand over memento to Dr. Jacob. Dr. Saad. Dr. Saad. Dr. Charlie, please. Dr. Rohan. Dr. Kiran Peddi. I invite all the chairpersons on the dais, please. Dr. Charlie. Dr. Charlie, can you hand over mementos to the chairpersons? One second. Yeah. Yes. Kiran sir, क्यों बोले? Yeah, Dr. Charlie, please hand over mementos to the chairperson. Dr. Kiran Peddi. Dr. Kiran Peddi will hand over to Dr. Rohan. Yeah, I think you need to hand over one more to the team director, Dr. Anil. So thank you very much, and with this we come to the end of this session. We'll have lunch, and let us again assemble here at sharp 2 o'clock so that we can continue with our scientific sessions. We can exit from the right, please.
I saw the photos, right?
But my idea is that because we've got lots of quite old people on there, right? Preference to start with
Good afternoon. Welcome to the post-lunch session of this IBD Conclave. The next topic is the panel discussion on diet in IBD. Now I request panelists Dr. Savan Bopanna, Dr. Charlie Lees, Dr. Vandana Mitha, Dr. Anurag Jena, Dr. D.V. Srinivas, and Dr. Nalini Prasad to occupy the chairs. Now I request Dr. Shaji Sebastian to conduct the panel discussion. As we all know that diet in IBD is very important. So the commonest question by the patient is what to avoid and what to take the diet. So with this panel discussion, we can clear. We hope we can clear all our doubts.
Okay, thank you. So it's very aptly timed, isn't it, after that such a nice lunch which we had. We are talking about diet. I got some disclosure. First of all, I know very little about diet in IBD. That's my first disclosure, so I always am here to learn. And hence I've actually made this, this panel discussion about things which I want to know about. So apologies if that doesn't include what you wanted to know about. So I'm going to start with a case. So this is a 25-year-old female patient who presented with classical symptoms of Crohn's disease and was indeed diagnosed as terminal ileal Crohn's disease. Our chairperson already indicated that the first and foremost question for most patients diagnosed with inflammatory bowel disease is, what do I eat, doc? What can I eat and what I should not eat? So remember, this is a terminal ileal Crohn's disease patient who seems to have some features of obstructive symptoms. And when I was training in IBD, we were brought up with this dogma that dietary fiber in small bowel Crohn's disease should be reduced. But at the same time, we hear every day the good things about the dietary fiber. So I want to ask this question to the panelists. When is dietary fiber good in IBD patients and when it is not? So the reason why I'm asking is because of this paper, which was published recently from Manitoba. So it looked at unfermented beta-fructan fibers and found that they actually fuel inflammation in select inflammatory bowel disease patients. So that kind of fits with the dogma which I learned. But this thing happens only in patients who are in either remission or patients without IBD. So does this not happen in our patient who has got active IBD? So we know that these complex carbohydrates work through various pathways, particularly in relation to that short chain fatty acids, what you have seen on the right-hand side, and promote inflammatory pathways. So what I want to ask to Professor Lees is this. What advice are you giving based upon these data to your patients with, let's say, this particular patient in relation to fiber intake?
So I would be looking to reduce. Is that working? Yeah, there we go. I would be looking, Seb, to first of all make sure that she doesn't have fiber aggravating her symptoms. Most patients with an ileal phenotype, when the disease is active, will benefit from going on to a low fiber diet, and our dietitians would be excellent there. In fact, this kind of patient is where a polymeric diet might be very good, and in part that's because you're removing all the fiber from the diet, but I would allow her to take what she can tolerate. And I would encourage not to eliminate it completely unless she was getting quite marked symptoms.
So it is essentially personalized based upon patient how tolerates a particular diet.
It's
But
worth
that doesn't
bearing in
marry
mind-
with the data.
It's worth bearing in mind that most people who have active ileal disease at presentation like this, once they're on therapy for their inflammatory bowel disease, most of it will melt away and they'll be left without too much in the way of stricturing symptoms.
So if I take that further and say that the mechanistic data which I showed you earlier does seem to contradict that in those who have active inflammation, fiber in fact may not be having additional inflammatory process driven, but does that mean that there are other ways dietary fiber impact on patient symptoms? That comes to that second question, what are the mechanistic insights you have from dietary components in ileal disease?
Yeah, so let's separate this out briefly then. So if you have a lot of fiber in your diet and you have stricturing small bowel disease or you have active colitis, then that fiber will drive either obstructive or diarrheal symptoms. So we want to cut back. That's a separate question from what about things like fiber and improving inflammation. I don't give my patients any particular advice on fiber in terms of inflammation in the situation where they don't have active disease. I would just tell them to eat something akin to a Mediterranean-style diet. To take this back, though, to mechanistic insights, we have a lot of information now from epidemiological studies that shows that a lack of dietary fiber increases the risk of Crohn's disease. We then have mouse studies that can help us look at a variety of different dietary components, including fiber, and can give us some clues as to what's going on there. It's been difficult to piece together epidemiology, mechanism, and humans, and human IBD, and active versus inactive disease. So I would keep it very simple in terms of what's driving symptoms, and then once people are well, what's a healthy diet to keep them well, and we can talk about that later.
So you just touched on, what patients, when they get better and they are in remission, and you alluded to your PREDICT study earlier. And was there any signals in relation to dietary fiber content in those who are in remission in relation to their disease course?
Yeah, so interestingly not. I mean, the key dietary finding from PREDICT is the association with red meat and flares in ulcerative colitis. We don't see a particularly signal with fiber or with PUFAs or indeed actually with ultra-processed foods. And this is when we've looked across this large cohort. But these are people with established disease. There are probably going to be specific examples when you look at subphenotypes in specific situations.
So the message in relation to dietary fiber in terminal ileal Crohn's disease, which is our patient, is listen to the patient, see whether the symptoms are aggravated, moderate the amounts, but not necessarily eliminate. The advice after getting into remission is not fully clear. We need to know more mechanistic data. Any questions from the rest of the panel? Yes.
Does it depend on whether it is a fistulizing Crohn's or stricturing Crohn's? About the fiber and diet?
Yeah, I don't think so. I would be driven by symptoms in that sense. Patients with a fistulizing phenotype. I mean, one of the really important things is that we don't end up with malnourished patients as well, right? So that's our, I think we have two primary objectives in Crohn's disease. One is avoid foods that are driving symptoms, and the second is to make sure our patients are not malnourished, or that the advice that we doesn't drive them to be malnourished. So if patients have active fistulizing disease, it's just perianal fistulizing disease, I wouldn't change the advice. If they have more extensive enteroenteric or intracutaneous fistula, then it's going to be highly personalized advice, and many of these will need specific dietary support.
Vandana?
Yeah, in general, if the person is having stricturing disease, we decrease the fiber intake. And the other point is that it should be soluble fiber, and we should suggest that the patient chews properly. The fruits they are peeled, they are mashed, and they are chewed properly. that would be better in patient who has a stricturing disease.
Yeah, great practical advice. Any questions from the audience in relation to the fiber? No.
I think that the fiber intake and the relationship to inflammatory bowel disease is more of like it's a normal population. That is it's exported to IBD. Like for example, if you take a more fruit fiber, the risk of Crohn's is decreased actually. But it doesn't mean that fiber should be given more in a patient of Crohn's disease.
There's just one final point, Seb, and it's you really do need to ask your patients. I quite often will see a patient, maybe my fellow has seen a patient with small bowel Crohn's disease, and they come and tell me about the patient. They're really well, they're symptom-free, everything is fine. I don't know what they were talking about on the scan or at the meeting about this patient needing an operation. And then I go and speak to the patient and say, what are you eating? And then you find out that they're not eating any fiber at all. Yes. They're liquidizing all of their meals, and they're a million miles away from a normal diet. And patients often won't tell you that. So you really have to inquire about this. It can be a very sensitive way. And for patients that have to limit their diet, it's often an indication for surgery.
Dr. Sebastian, one more question, sorry.
Yes.
This is regarding this fibers, because fibers are considered as products which produces lots of short-chain fatty acids by bacterial fermentation. So you get more of butyrate, which is very essential for the cells in the GI tract. So it increases the healing. That's the concept. But why do we get exacerbation when there is excess of short-chain fatty acid produced by fibers?
I think it is what I understand, and particularly from that paper which I showed you, it's about fermented products basically, and that again is a dual sort of action. What is your microbiome composition? We think the diet influences the microbiome, but actually dietary components are influenced by microbiome as well. So what that study particularly showed was unfermented beta fructans are the main culprit in that. That's my understanding. Okay, so now we talked about the fiber. The next thing is whether we are in a place in 2024 where we use diet as a treatment for IBD. So we know about exclusive enteral nutrition for number of years, be it the almost unpalatable, I should say, I have tasted it myself, the elemental diet, to somewhat manageable and more palatable, and in fact maybe cheaper polymeric diet. So that has been around for a while, and now we know sufficient mechanistic data how exclusive enteral nutrition works, and in fact there is some great work done from India, particularly in acute severe UC about exclusive enteral nutrition. So we know the impact of that on microbiome. So we know the mechanism. We also have got perhaps not so robust data in relation to the utility of exclusive enteral nutrition as a primary or as a sole therapy in induction of remission, because actually this Cochrane systematic review only showed benefit of enteral nutrition above corticosteroids in the pediatric population. So our patient was an adult. So I want to ask Dr. Srinivas, given the challenges in using exclusive enteral nutrition in practice, how often do you use it? In which patients you are going to use it? And do you think that there is a role in adult IBD patients of using that as primary therapy?
Yeah, in my personal experience, I have never used exclusive enteral nutrition in a patient with Crohn's disease. And the data also doesn't support the use of exclusive enteral nutrition. And some of the studies which are randomized, having small numbers, they have nearly 40% dropout rate with exclusive enteral nutrition because of poor palatability. So as an exclusive enteral nutrition in Crohn's, still we cannot use it, in my opinion, because there is not sufficient data to support it. But there are some studies which show that if you use exclusive enteral nutrition in preoperative patients with Crohn's disease, those with stricturing or fistulizing Crohn's, their results are better. And in the perioperative period also, if you use exclusive enteral nutrition, their results, their complication rate and morbidity is much less. This is one group where we can use EEN. And the second group may be patients who are not fit for steroid therapy and who cannot afford biologics. Probably we can try exclusive enteral nutrition. And in children, again, we can use, there is some data in children about use of exclusive enteral nutrition, then results are comparable to steroids, but in adults, there is minimal data.
I'd give a
Charlie.
slightly more positive spin on it than that. I think we've used a lot of exclusive enteral nutrition in adults with small bowel Crohn's disease specifically, usually as a bridge to another therapy, often instead of steroids. It helps reduce the pain, it helps treat the malnutrition, and it probably has some anti-inflammatory effect. So I'll use it in a new diagnosis patients while I do their diagnostic workup. We do it with the acutely flowing small bowel patient that comes into hospital, and we'll do it in the outpatient setting as a bridge, waiting for the biologic to start or whatever.
Yeah, as an adjunct to steroids or biologics, okay, but as an exclusive treatment with enteral nutrition, probably we cannot recommend.
So just ask the audience, how many of you either use EEN as a adjunctive therapy or indeed as primary therapy? I suspect there are not many, as you suggested, as primary therapy. How many in the audience you use? Few. I just want to ask one more question on that front. Do you have the dietitian to support that, or do you actually do it yourselves? Dietitian? On your own? I feel fairly not confident in prescribing that because I don't have experience in monitoring them. What do you exactly look for apart from symptoms? You know, what happens in a rather malnourished patient with Crohn's disease? You know, if you have an anorexia, if you want to feed them, you get all the issues. Does that happen in IBD?
Oh, look, if it's a complicated patient, you need the dietitian, particularly if there's a risk of refeeding.
Yeah.
But if it's a bog standard patient, you want it for 2 to 4 weeks, 6 weeks as an adjunct, then, you know, get whatever polymeric drink you want. It could be Ensure, it could be Fortiship, it doesn't matter. And tell the patient to take 5 to 8 a day, depending on how big they are. That's all you need to do.
Excellent. And what about in UC? I know it's not relevant to our patient. Do you see a role, particularly with the study from AIMS, which, although it was a small study and the primary outcome was not met, but is there a role for EEN in acute severe UC?
Yeah, the study from AIMS, again, it proves that it improves the results of steroids. It is given as an adjunct, not an exclusive enteral nutrition. And they have studied even bacterial colonies in patients who have received exclusive enteral nutrition, and they have shown that there is some improvement in the bacteria. Probably that is the result translated when it is given along with steroids. It increases the efficacy of steroids.
Okay. Thank you. So then we move on to, there has been an explosion of various acronyms of various dietary therapies in the last sort of 5 to 10 years. In fact, it's probably almost Charlie's earlier slide about the number of biologics there are, the number of dietary treatments with various acronyms are actually increasing. And many of them have got some mechanistic data behind it, which we may discuss later. But one of the common things which is developed, I mean, not so far from where Professor Lees is in Glasgow, is the CD treat diet. This essentially attempts to recreate exclusive enteral nutrition by using various macronutrients, vitamins, minerals, and fibers, using rather ordinary food, also reducing the carbohydrates and excluding things which many of our patients, whether they're disclosed to us or not, exclude, such as lactose, gluten, and maltodextrins. And this has been now subject to a randomized control trial. I will ignore the mechanistic part of it on the top, But although it was a small study, this study in those patients who had active Crohn's disease, majority of them small bowel Crohn's disease, ordinary food-based diet replicated exclusive enteral nutrition, including reduction in inflammatory markers, calprotectin, and also remission in up to 60 to 80% patients. Then there is the Crohn's disease exclusion diet, or CDED. This is based upon exclusion of certain components on the Western diet, and we are increasingly considering that perhaps the dietary modification is one approach we can do in relation to prevention of IBD. But what about in treatment? In this case, again, we are excluding things what patients normally may even exclude without telling us, such as the gluten and dairy. There is a high quantity of protein here based on chicken and eggs. Complex carbohydrates are removed, and this diet is given over a 6-year period. And what's the trial data from that? And you can see this, this was led from Israel, and it was in pediatric group. In this, they randomized patients to exclusive enteral nutrition or Crohn's disease exclusion diet with partial enteral nutrition. And you can see that the group with CDED and partial enteral nutrition appeared to achieve both the remission, both not only remission but also sustained remission in a good proportion of patients. And then the buzzword, which is the Mediterranean diet. And this is the Jim Lewis study comparing specific carbohydrate diet and Mediterranean diet. Mediterranean diet is much more palatable, much more available, but I would argue it may be much more expensive as well. But nevertheless, the Mediterranean diet achieved Crohn's disease symptomatic remission similar to specific carbohydrate diet in about 40 to 45% of patients, which are similar to, if you think about our biologic treatments. So I want to ask Anurag, what does he do when he hears all these new names of dietary approaches? Do you actually use any of them in your practice, or do you recommend any of them to the practice? And more importantly, I want to ask you, do you actually ask patients what they avoid without telling you?
So regarding the various dietary approaches, I think one of the diets that has been proven in Indian condition, that is the anti-inflammatory diet in mild to moderate ulcerative colitis. I think that is a good thing to advise. I think it consists of very simple changes. You restrict the milk, you can allow the curd. I think curd is preferable. You restrict the sugars, refined sugars, artificial sugars. You allow them honey. You restrict the omega-6 fatty acids like sunflower, safflower, and you allow them olive oil or mustard oil or the good old canola and rice bran oil. You restrict the red meat. I think, as we all know, it has been shown to induce flares in ulcerative colitis. You supplement with fresh chicken or egg. So these are very simple advices, but it sounds complicated, anti-inflammatory diet, but yet simple things to advise.
But anti-inflammatory diet is only shown in UC setting.
Mild to moderate.
We are talking about Crohn's in our patient. So do you recommend any of the diets which has been studied in Crohn's disease
right
to
now,
your
no,
patient?
sir. In Crohn's, I think Crohn's exclusion diet has shown beneficial, that too in mild to moderate. Exclusive enteral nutrition as such, I think the recent ECHO recommendation, they have a separate section on nutrition now. In the last guideline, they didn't have anything on nutrition. They suggest exclusive enteral nutrition in Crohn's also, but only if the patient has some contraindications to steroids and the patient will has some adherence to the therapy.
So if a patient comes to your clinic tomorrow with terminal ileal Crohn's disease and tells you that I heard a lot on the television about Mediterranean diet, should I follow that? What would be your answer?
No, sir. The Mediterranean might fail in patients with stricturing disease. I think, as discussed earlier, it has to be low in fibrinous, soft in consistency, well chewed, I think well cooked, mashed. I think peeling off those fruits, avoid those seeds. They are going to get stuck and aggravate the symptoms.
So is there anybody who gives advice when patients ask you, what sort of diet should I follow, doc, in my follow-up. What do others do? Charlie.
So if patients ask and want to do something, I do advise the Mediterranean style diet. It's perhaps not so far, quite so far removed in the UK as it is from India to the Mediterranean, although it's still quite a long way from Scotland down to the south of France. I do typically advise that. I try and say to people, the key thing here is many of the things you've already discussed. It's to cook from fresh, to avoid processed foods. It's to limit the amount of meat you take, particularly limit processed meats, and try and increase, where if you can tolerate it, legumes and pulses, etc., good olive oils, not too much sugar. Keep it quite simple, nothing too strict.
We give them a simple advice. One is reduce gluten intake, lactose intake, and red meat. And some of the spicy food, especially in the southern part of India, is definitely found to aggravate the symptoms of IBD. We tell them to reduce the intake of this. And canned food is another thing we tell them to reduce.
Is there any data in relation to spice? Yes, it does increase symptoms. I'm sure many of us have felt that sometimes. But what about actual inflammatory activity?
So we don't have any data to support, but we have to look at the patient's symptoms also. Some patients who says he has increased symptoms with this diet, we need to tell them that he should curb that.
So Anurag, there are some new diet-based treatments which are being trialed in Crohn's disease, like those based on turmeric or curcumin. Do you have any feel about whether they will see the light of the day?
The trials on curcumin, I think there are 2 randomized control trials. Still, the data needs to be validated in larger studies. There is a recent study on coconut water, I think in mild to moderate ulcerative colitis. The sample size was small, yet the data is optimistic. There are studies on polyphenols. I think they are also found to have some beneficial component in these dietary components.
Thank you. Okay, we shall move on. So earlier we alluded to what patients actually do in practice. I have a lot of patients who come and say that I can't eat anything. So essentially they are avoiding food. And this was thought to be more of a Western phenomenon, the so-called ARFID, or Avoidant Restricted Food Intake Disorder. But it's now increasingly found in patients from South Asian origin. This is actually a UK study. You can look at it and say that both in males and females, the food avoidance rate after diagnosis of inflammatory bowel disease is as high for some products, as high as 50 to 60%. Many of them are excluding gluten. Many of them are excluding lactose-free diet. They're using obviously low FODMAP and other things. So this restriction in diet is going to be an increasing problem, particularly with messaging on social media, etc. Now I want to know from Dr. Prasad, is that a common problem you are seeing in India, and what measures are you taking if you are seeing them?
Yeah,
because they impact on nutrition as well.
Yeah, definitely we are facing these problems in our clinical practice. So many of them are avoiding, some set of patients are avoiding the foods and they're becoming malnourished actually. So the most important measure what we had to do is first we had to counsel the patient, talk to the patient, tell about the nature of his or her disease, whether what is the nature of his or her disease, whether it's a stitch-raising Crohn's or probably say a normal, a mild or moderate Crohn's, and and also we also should educate the patient regarding what is flare. So what the symptoms, what he or she will face when she gets the flare, and how to avoid the what types of foods she should avoid when she gets the flare-like symptoms, and give her some positive thing. And also the most important thing is that so it's not uniform. We also have to take everything into the account. For example, sometimes we may see a very obese patient of Crohn's, probably having, probably he's trying to avoid the foods. So we should take everything into account, and the most important thing is that we should counsel the patient and talk to him and tell the nature of the disease. I think that's the most important point.
Thank you. So do you actually have a dietitian dedicated to IBD in the center to look after these patients? Clearly, your time is stretched to go into this in detail. And how many people actually have IBD? I mean, I got a service of just under 5,000 patients. I got one single dietitian. Clearly not all of them can be seen by them. So what's your strategy in relation to this dietary advice?
Yeah, with the regular outpatient type of patients, what we see, I think dietitian is not required, because I think as a gastroenterologist, we are the better decision makers, because we have to see the patient, and we had to guide the diet based on the patient's weight, and also depends upon what minerals and vitamin deficiencies he's having, what is the nature of the disease he's having, whether he's in a flare or whether he's in a stable remission. So if he's in remission and he's having more symptoms, probably due to the ERFID. So we should counsel him, and we should also sometimes we may need to send to a psychiatrist, probably regarding the cognitive behavioral therapy also sometimes. So we should give. So the most thing is that I think we are the better judges to guide them regarding the diet, because we should take all the factors like the body weight, the calorie requirement, the vitamins, minerals, everything, and also we should do some subjective global assessment, and we should see what is his nutrient status and malnutrition, and we can guide like that. I think we are the better guides, and it doesn't take a big amount of time in the outpatient. In the case of very severe Crohn's who is in very severe flare, I think we probably require the help of a dietitian probably.
Okay, thank you. Okay, let's move on. And quite a number of our patients actually think about this and sometimes ask you, was that my fault getting my IBD? Did I cause my Crohn's disease? We know there are some data emerging in relation to predisposing dietary practices, some of which are shown there. But particular importance is ultra-processed foods. And there is a NOVA classification for ultra-processed food. I'm not sure how this really fits in relation to manufacturing processes, but nevertheless, there is emerging data from large epidemiological studies. This one is the Nurses Health Study data. You can see the number of participants and the number of years of follow-up, massive data set. And you can see that at least with Crohn's disease, there seems to be a correlation with increased risk of Crohn's disease with ultra-processed food, and particularly those three dietary components, which is the bread, ultra-processed breads and breakfast food, frozen meals, and then sauces and cheese, etc. So food additives are also a problem because most of our food, what we are purchasing, particularly the ready-made meals, have got number of additives, micro or nanoparticles, sweeteners, coloring agents. But one thing which is of particular interest is emulsifiers, and we really are trying to understand the E numbers. I don't know how many of our dietary products we actually look at what the E numbers are and what they are actually causing to our gut health. So I want to ask to Savan, I know this is partially related to one of my passions in relation to trying to understand the global epidemiology and approach it in a global sense. What do you say to people when they ask you, did I cause my IBD? Was my diet so terrible to cause the IBD? And do you actually believe now that diet is a major contributor to development of IBD?
I think it's one of the most common questions that patients ask when they get diagnosed first with IBD or when they're going through difficult times like a flare. So when people ask me whether diet is the cause, I definitely do tell them that one of the causes, not the only cause, because that would be a difficult thing to tell them, but one of the causes could probably be diet, and we also have this epidemiological shift that we see, that it's the changing dietary patterns probably causing the changing patterns of disease in the world, like shift from the west to the east. So yes, I would probably tell the patient that yes, diet is one of those causes, and not too much emphasize that diet is a huge cause of their problem. Because there's really no robust data as of now to say that there's one particular diet or one particular substance, because the next question is going to be what is that one thing which we can avoid, or what we could have done better to actually not have this disease. So there's no answer for that as of now. So yes, I would tell them that diet is probably one of the reasons, that, but it's not the only thing, and we don't really understand completely as of now that how diet is actually causing their disease. And yes, I do believe that diet is one of the major causes for IBD, mainly because the other patterns of genetics, the other patterns of immune system, they all seem to remained fairly constant over the years, but it's the diets that have been changing, and therefore we've also been seeing the epidemiological changes in the patterns of disease, especially in South Asia. So I think diet is an important environmental trigger for IBD.
And do you think that we, as leaders in society, as medical professionals, do we have a role in influencing policy changes at local or governmental level on this?
If we have very robust data, yes, then I think we could be policy leaders. But theories and assumptions, because to change policy will be difficult in this regard, because the diet, for example, emulsifiers, to actually take off emulsifiers from a normal person's diet is going to be extremely difficult. So before we actually head towards changing policy, I think we should be clear as to what are the things that is actually causing this problem. So there are more than a lot of substances in the diet which we don't know how they actually lead to this. We have epidemiological data, good in vitro studies, in vivo studies, but human clinical studies are still very in the nascent phase.
Thank you. Okay, our 21-year-old, her particular concern was that I got this disease, but my children should not, or I don't want them to do it. What can I do to try and reduce their risk? We know there is rich data now in relation to breastfeeding, reducing the risk, and also some dietary components. So what I want to ask Dr. Vandana is, what are your thoughts on the emerging data in relation to early life, so in utero or early life exposures within the first 6 to 12 months after birth in relation to development of IBD, and what specific advice you will give to our patient who is asking you the question about reducing the risk to her children, not about risk of pregnancy, but specifically about development of IBD?
Yeah, first of all, the early life period, it's a very important period, and if you look into it, it starts right from in utero and goes up to 3 to 5 years of age. So this is the time period where immune maturation is occurring, where our microbiota attains the adult phenotype. And the early risk factors in during this period is said to impact the health and disease later on in life, be it IBD, be it any other chronic illness. And this is a theory which is known as the developmental origins theory of health and disease. So as far as studies are concerned, we have the systematic reviews, we have a lot of cohort studies, we have the geographical data, we have the omics studies which have come up now. Of all the studies, breastfeeding, yes, it has been consistently shown to have a protective effect throughout the studies, except for one recent study, very, very recent study, which says that it has no impact. And it has also been seen that this breastfeeding, the impact of breastfeeding has been seen more in the Asian population as compared to the Western, and also a dose response has been seen. More than 6 months of breastfeeding is said to be protective rather than 3 months or 6 months of breastfeeding. Apart from that, other factors which have contributed are passive smoking, be it maternal smoking, be it smoke exposure to in childhood, infections, enteric infections. Some studies have non-enteric infections like otitis media. They are all shown to increase the risk of IBD. Again, antibiotic exposure. In utero exposure, again, increases the risk. Early childhood, So injudicious use of antibiotics in this early life period is said to increase the risk of ulcerative colitis. There is, as far as the diet is concerned, we have a very recent cohort study from Scandinavia, which says that a high quality diet at the age of 1 year, and high quality, they have referred it to as fish and vegetables. It is said to be protective. And sweetened sugary beverages, they have said to be increasing the risk. The important point in this study is that if you look into this high quality diet at 3 years, it is not making an impact. So it is basically the early life period where, and there are a lot of other factors which have contributed, the biodiversity, the green space, hygiene hypothesis, mebendazole. So there is a plethora of studies which have been implicated as the early life exposures. So if, as far as a pregnant mother is concerned, apart from regular medication and maintenance of compliance, one needs to advise on healthy eating, avoiding the ultra-processed foods, avoiding smoking, avoiding alcohol, avoiding injudicious use of antibiotics. And similarly, for the newborn, it has to be breastfed, and other things would be antibiotic, and the anti-helminthic exposure has to be limited in these patients.
So clearly, lot of public messaging needs to be done. Yeah,
One
Charlie.
thing which I would like to mention again, as far as dietitians are concerned, I feel that all IBD centers should have dedicated dietitians. And under Colitis Crohn's Foundation, we have a dietitian training program which is being carried out for the dietitians of the country, registered dietitians.
Fantastic. That's essential. Charlie.
Yeah, I would agree with almost everything you said there, but I would just add that a lot of our data is incomplete, as you pointed out earlier on. So I think both for the patient that has IBD, we need to be very sympathetic. The vast majority of patients that I see have eaten a really good diet, and they're quite clear that diet's not a cause. And they absolutely don't want someone telling them diet's the cause. And I think a lot of the time we just don't know. But a lot of what we do know that seems to be good for IBD is also good for general health. You want to eat something close to a Mediterranean-style diet. You want to avoid first and second-hand smoke. You want to avoid unnecessary antibiotics. But let's not forget that childhood mortality in under 5s globally has plummeted in the last 20 years, at least in part due to hygiene and to judicious use of antibiotics. So we need to be very careful. And I'm not too judgmental about mothers for breastfeeding. We see these large population studies now that don't show such an effect, but we know that there are other benefits. So general healthy lifestyles. Most parents who have IBD will not have children with IBD. A positive family history is the strongest risk factor for developing IBD. But actually, whilst the prevalence is high, the incidence overall is low. So the vast majority will be fine. So I think we need to just be quite sympathetic to all of this while we get more data as well.
Okay, I'm going to stop there, but I want you to all think about that first line which I have put, because I think our healthcare system, not just in India or Asian countries, even in the West, the healthcare systems will be overwhelmed if the IBD incidence keeps going up. So you need to think about preventative approaches. So I want you to think, you know, when you are back, whether dietary approaches are one of the approaches which we can take both at a personal level, institutional level, country level, policy level, all of that, and what role we can play as healthcare leaders to try and do the prevention. So I just want you to think about that, and thank you for attention today, and thank you to all the panelists for contributions. I've certainly learned and got answers for some of my own questions. I'm sorry you didn't have time for more interaction. Thank you.
So, sir, one point I want to tell that, especially in childhood, amoxicillin, metronidazole, and fluoroquinolones. So these were very rampant use, especially in India. So I think these are the main 3 culprit antibiotics when they use mold in childhood. I think they predispose most to development of IBD.
But as Charlie mentioned, perhaps some of them are quite appropriate use, and it is the inappropriate use which is needs to be curtailed, isn't it? Yes. Okay. Thank you.
I thank Dr. Shaji Sebastian and panelists for their excellent discussion on diet in IBD. Now I request Dr. Charlie Lees to present memento to Dr. Shaji Sebastian. Sir. Now I request all panelists to come onto dais. I request Dr. Shaji Sebastian to hand over moment.
I request Sebastian to present a memento to our theme director, Dr. Chandrasekhar Reddy.
With this, we conclude the session. I request Dr. Vamshidhar to take over.
So good afternoon, everyone. So now we had an extensive discussion on diet in IBD. So I would like to go forward to next session, the treatment part of IBD. So I would like to call our chairpersons, Dr. Ramanjanu sir, Dr. Abhilash, Dr. Ujjwal Gajula, and Dr. Chandrasekhar Puli, and Dr. Nitish Pratap, and Dr. Umakant.
Yeah, while chairpersons are taking their chairs or seats, we have come to the important session in this IBD conclave, that is the treatment aspect of IBD. We have a big landscape now, but even then, the 5 ASAs and thiopurines, they have their role more so in a country like ours, low or middle income group country. The first, I would like to invite Dr. Ajit Sood to talk about this and whether it's a time to extend them or still there is a role. We would like to have your opinion, sir. And Dr. Ajit Sood doesn't require any introduction. He is a famous figure as far as Society of Gastroenterology is concerned or CCFI is concerned. He is a secretary of CCFI and he is from Dayanand Medical College, Ludhiana. Sir, we request you to give your opinion on this.
Thank you very much. Thank you for the invite to be here and participate in this meeting. Been enjoying I've been asked to speak on whether we really need conventional therapies like 5-ASA or azathioprine in today's time when we have a plethora of other drugs which are much more effective. Celsoparin was first used for ulcerative colitis as early as 1948, while first case of Crohn's was treated with azathioprine in 1962. So these drugs have been with us for a lifetime. And 5-ASAs, we know, are locally acting anti-inflammatory drugs. We've been discussing about mild to moderate ulcerative colitis. We had a case discussion and we discussed the role of 5-ASA, and we went through the ECO guidelines. I'm just repeating the same, that even now a recent guideline still suggests that 5-ASA has a role for mild to moderate. Please note down, I'm saying mild to moderate ulcerative colitis, and rectal therapy is useful for distal colitis. And when we combine the two routes of therapy, the efficacy may be better. 5-ASA topical therapy is better than steroid rectal therapy, and this holds true for maintenance of maintenance therapy for ulcerative colitis, that both rectal therapy and oral therapy is effective. So ECO guidelines still endorse that there is a definite role. So then why question their role? I mean, once guidelines say that yes, 5-ASAs are good drugs, and we also know that they have been around for a very, very long time and they're time tested, then what is there which has appeared on the scene that which makes us think that whether we really need these drugs or not? 1998, infliximab came, and biologics have changed the landscape of IBD treatment. And this analysis, when you look at it, this pooled analysis of individual participant data from clinical trials, and the two bars, I mean, in one bar, I mean, there is a biologics infliximab with or without 5-ASA, and when we analyze it according to the clinical response, clinical remission, mucosal healing, or biomarker remission, there is no difference. There is very little difference in the short-term or intermediate time period between the efficacy of combination therapy or infliximab alone. Another, this cluster plot, again showing whether 5-ASA adds to the efficacy of biologics, anti-TNF agents, or JAK inhibitors. It adds to the cost, but when we withdraw these, it does not compromise the efficacy. We touched upon this issue of ASAs in acute severe ulcerative colitis, and I think all of us agreed that we are not using 5-ASAs for acute severe ulcerative colitis. In this study, I mean, this was shown that adding 5-ASA to these patients who have been on steroids for acute severe ulcerative colitis, the response rate was similar. The primary response as well as the need for salvage therapy was similar with or without 5-ASA. There was a very mild or exploratory signal for reduced use of biologics when the data was analyzed at 90 days, but it did not reach at statistical significant value. So it's not practice that we don't use 5-ASA for patients with acute severe ulcerative colitis when we put them on IV steroids. Colorectal cancer is an established complication of IBD, and when we look at the various factors which increase the risk of causing malignancy in these patients, it's the persistent inflammation. It's the inflammatory load which has emerged as one of the major risk factors predisposing to development of colorectal cancer in these patients. Now, patients who have been on 5-ASA and who have shown response, it has been noticed that these patients who achieve response or who achieve mucosal healing, they are the patients who do not develop malignancy. So what is the factor which decides the risk of malignancy? Is it the drug or is it the achievement of mucosal healing, meaning that it's the control of inflammation? If it is a matter of controlling inflammation, then obviously other drugs like biologics or JAK inhibitors, which are going to achieve the same thing, maybe faster, they should also be, these agents should also be chemoprotective. So this is one school of thought. Coming to Crohn's disease, role of 5-ASA, when we say that is there any guidelines which suggest that you use it, there's none. But when we say practically what happens, do we still use it? At least in India, most of us use it, and I also admit that I also have been using 5-ASA. Right? So the question is, do we really have evidence? Now, based on this meta-analysis of 7 studies, it was found that 5-ASA did not achieve or did not do better than placebo as far as Crohn's was concerned. I mean, irrespective of the site of disease, whether it was ileal or ileoclonic or clonic disease, and hence ECO guidelines did not, they said that we do not recommend use of 5-ASA. So, I mean, with biologics, no role of 5-ASA, and acute severe ulcerative colitis doesn't do anything good. In Crohn's, one of the studies have shown that 5-ASA doesn't achieve more remission than placebo. So really, is it time to say goodbye to 5-ASA? The answer is clear, no. We can't say goodbye. I'll share with you why. Now, we've been talking of ulcerative colitis. We've been talking of biologics. And as a matter of fact, when we discussed treatment of IBD in conferences, most of the time we discuss difficult to treat cases. And difficult to treat cases, most of these cases are severe cases. So there's a lot of emphasis on discussion on these agents, and because these are new agents, so we want to learn more about new agents. But when we look at the natural history or disease course of patients of IBD, in ulcerative colitis, this Epstein cohort clearly shows that 55% of the patients of ulcerative colitis, they have a mild course. Initially, they have a moderate disease, but subsequently they have a very indolent course, and the relapses do happen, but most of the relapses are mild. Easily we can say that more than 50% of the cases they have, or they run a mild course. Another data from Europe and Canada, when we look at the number of patients having mild disease, it's more than 50%. And if we include mild to moderate, it comes to nearly 75 to 80%. So what does this show? That vast majority of patients, they have still mild to moderate disease, thankfully, and 5-ASAs are recommended by different guidelines, and we have also seen over the years that 5-ASAs do work in patients with mild and even moderately active ulcerative colitis. Our own data, this is Crohn's Colitis Foundation India data, and our own center, which is a tertiary care center. We have found that 70% of the patients of ulcerative colitis or even Crohn's who come to us have a mild to moderate disease. It's only 1/3 of patients with ulcerative colitis who have a severe disease. And we share our thoughts about ulcerative colitis, and I somehow feel that in North, in our region, particularly in Punjab, I mean, we have a tendency to get more severe patients of ulcerative colitis as compared to the rest of the country. Even then, 75% of the patients, they have a milder disease. Treatment patterns of IBD in the West, both in Europe and USA, still the first drug which is prescribed is 5-ASA, not biologics. This is a study from us. I mean, we did this study in patients with acute severe ulcerative colitis. Patients who did not respond initially to steroids were used infliximab. In India, financial constraints are there. Ulcerative colitis patients, we feel very few of them actually go on maintenance therapy with infliximab or biologics when we use for induction of remission. So what we found that we achieved, we put them on infliximab for induction of remission, and simultaneously we put them on azathioprine, and by week 2 they were on 5-ASA also. So after completion of induction of remission and induction regimen, we continued them on 5-ASA and azathioprine, and we found that by 2 years, nearly half of the patients had a steroid-free remission period. Relapses did happen on longer follow-up, but relapses could be managed with steroids. So 2 things were there, that combination of 5-ASA and azathioprine can sustain remission in a sizable number of patients, and steroid refractoriness, which was seen initially, is not a permanent thing. So steroid refractoriness is not permanent. Initially they did not respond to steroids, but subsequent relapses, most of them could be managed. We've been using 5-ASA, and this has been found to be effective in children also. So I mean, nowadays all of us agree that with single dosing, the compliance becomes better. I mentioned about colorectal cancer in IBD, and I mentioned that it's the mucosal healing which matters. There is this study which have looked into whether 5-ASA initiates an anti-oncogenic or cell-specific mechanism, and which results in genetic alteration of transformed cells. So this is a new concept which has come up. We don't have more data on this, and we are waiting for more data on colorectal prevention effects of other drugs. I think in future we are likely to have an answer to this, whether chemopreventive role is specific for 5-ASA or it's more related to mucosal healing, as we've been discussing. I mentioned one study in which, or I mentioned a meta-analysis in which they found that 5-ASA don't work. Now this is an interesting study from Europe. Patients with Crohn's disease, mild to moderate disease, they put them on 5-ASA. Some of them continued 5-ASA as long as 5 years, while in some it was withdrawn after a year and they were put on different drugs, maybe biologics. And it was analyzed that the patients who initially received 5-ASA, they do better as far as hospitalization is concerned, surgery is concerned, or disease progression is concerned, or composite remission, composite outcome is concerned. So there is a very soft data that it's not outrightly rejectable drugs. It's not totally out. I mean, there is some possibility that 5-ASA may have some role, but I will not advocate it strongly. So to sum up about 5-ASA, I'll say that for mild to moderate ulcerative colitis, 5-ASA remains the mainstay of treatment. We should never get tempted to go to other oral agents for treatment of mild to moderate severe ulcerative colitis. When we combine 5-ASA and azathioprine, it may help in a small, in a subset of patients having even moderate to severe disease. And there's some evidence, I'm saying there's some evidence that chemoprevention may be achieved with 5-ASA and may have some role in Crohn's. So that was about 5-ASA. Now coming to thiopurines, the three drugs, azathioprine, 6-MP and 6-TG. In our country, we have more experience with the azathioprine or 6-MP because 6-TG is not available to us. Regarding thiopurines, we are clear that thiopurines have no role as far as induction of remission is concerned because these drugs are very slow acting. So when we talk of thiopurines monotherapy, we always talk of thiopurines for maintenance of remission. When we talk of thiopurines and induction of remission, it is always with the combination therapy with biologics. ECO guidelines even nowadays say that thiopurines are recommended for patients with mild to moderately severe Crohn's disease who are steroid dependent or those who do not tolerate 5-ASA. We've been using biologics extensively, and the first group of drugs which came available to us was anti-TNF agents. And we realized that with anti-TNF agents, immunogenicity is an issue. The maximum was noticed with chimeric antibody infliximab. With other TNF agents, adalimumab, it was there, but not to the magnitude as it was with infliximab. And with the newer agents, Vido and UST, immunogenicity is less. Sonic trial, landmark trial for Crohn's, where comparison was done between monotherapy of azathioprine, infliximab, or a combination therapy. When we look at the data, the first on the left side is a azathioprine monotherapy. The third is a combination therapy. corticosteroid-free clinical remission as well as mucosal healing was the best seen when we use a combination of infliximab and azathioprine. Point to be noted here is that azathioprine alone was not a total failure. It did achieve remission and mucosal healing, though in a lesser number of patients compared to infliximab. UC success trial, same as SONIC trial for ulcerative colitis, and same results, that combination therapy does better, but infliximab is better than azathioprine, but azathioprine also works. It works to the extent that it works in 24% or 25% patients as far as clinical remission is concerned, and mucosal healing is also achieved in 37% cases. With biologics, there is a problem that there is a loss of efficacy with time, and this study showed that when biologics, anti-TNF agents, they lose their efficacy due to immunogenicity. I'm saying that those situations where anti-TNF agents, they lose their efficacy due to immunogenicity, if we combine them with azathioprine, it restores their efficacy in a good number of patients. As I mentioned earlier, that immunogenicity is less of a problem for VIDO and UST. So combining these two drugs with azo may not be very useful. Now we've been talking of SONIC trial and UC success trial where induction was induced with the combination therapy. So what happens once patients, they go into remission with these two combination therapy, infliximab and azathioprine? This PAIR trial is again very interesting. It included the three groups, the same three groups: monotherapy with azathioprine, monotherapy with infliximab, and a combination therapy. And then the drug was, each arm had a different withdrawal. In one arm, aza was withdrawn, in second, infliximab was withdrawn, and in one arm, both drugs were continued. And the results showed that the arm where infliximab was withdrawn had a highest number of relapses. But when we looked at sorry, I'll just take maybe 1 minute more, yeah. That when we restore these patients on infliximab, this is a very important aspect, that what happens when you withdraw a drug and a relapse happens, the efficacy is restored. So overall, when it was analyzed, that the number of days a patient remained in active disease did not differ between the three arms. That means azathioprine also had sustained remission in a good number of patients. Profile study, we've been discussing about it. I just want to make a point that there also a combination was preferred over monotherapy. So as far as thiopurines are concerned, in maintenance of remission, definitely the role is there. And when we use it for induction of remission, its only role is in addition to biologics, not alone. And when we use in combination therapy, it is advisable that we withdraw one drug after a period of say 6 months to 1 year, because longer period may predispose a person to high risk. Withdrawal is more or less always of azathioprine in West, but in India, withdrawal of azathioprine or continuation of azathioprine can be considered for cost reasons. Thank you. Thank you very much.
Thank you, sir, for that talk, and we'll take up the questions at the end, sir.
Thank you.
Yeah. The next speaker is
Dr. Chan Jin Ho. Just to introduce himself, Dr. Chan is a fellow of Royal College of Physicians, Edinburgh, and the Academy of Medicine, Singapore. From 1998 to 2000, he trained at Center for the Study of Inflammatory Bowel Disease at Harvard Medical School. He's an adjunct associate professor at the Duke Nose Medical School and practices at Glenangels and Ferrer Park Medical Center. He previously served as a chairman of Chapter of Gastroenterology, Academy of Medicine, Singapore, president of Gastroenterology Society of Singapore, and co-president of APDW 2011 in Singapore. He's the president of Asian Pacific Association Gastroenterology and the chair of APAGE and IBD committee. He's the president of Asian Educational Network Inflammatory Bowel Disease and director of Asian Pacific Digestive Week Federation. Many thanks for coming here.
Thank you, Mr. Chairman. I swear I sent Dr. Kiran a very brief CV, and I don't know how this became like that. Anyway, the brief, I would like to thank Dr. Kiran and, of course, Yashoda Hospitals for kindly inviting me to this very exciting meeting. My talk today is anti-TNF versus non-anti-TNF biologics and what is the best opener. These are my disclosures. So my overview, I'm going to really just cone down on anti-TNF and more important, the non-anti-TNF biologics, which are the integrins, vedolizumab and ustekinumab. I won't touch on the P19s because they're just becoming available in Asia, and I don't think it's still within the reach of many of our patients. So the question I'm going to put to myself, and we'll have a nice discussion later, are non-anti-TNF biologics, can they be preferred first line in a significant number of patients, especially patients in our region with special issues? So what are the efficacies and safety issues, and how do we personalize this to our disease phenotypes? I don't want to show this, but the reality is I just want to concentrate on perhaps the panel on the right, which is the current treatment strategies, however nice those initial biologics are. A remission is not always achieved. Clinical response, for example, in infliximab is only 50 to 60%. And you follow them up to a year, you're going to have loss of response, maybe in up to half of our patients. In this particular area in Asia, we worry about opportunistic infections, we worry about TB, we worry about hepatitis B, and of course, like all patients, malignancies. This just to remind ourselves that anti-TNF was a molecule that was a game changer almost 20 years ago and still relevant in many of our patients. Vedolizumab, I think we are all quite familiar that it binds specifically to alpha-4 beta-7, and basically it kind of interrupts the interaction with METCAM and lymphocyte migration, hence reducing inflammation. So whatever it does is very local. And ustekinumab, IL-12/23, really basically by blocking that kind of the P40 subunit, it blocks down a lot of the anti-inflammatory response. So I'm going to take you through a couple of patients. Patient 1, 17-year-old Indian girl I saw almost 7 years ago already. 8-month history of a typical Crohn's disease flare. Fever, loose stools, abdominal pains, recurrent mouth ulcers, weight loss, left elbow pain, painful rash. Thankfully, no perineal disease, iron deficiency, anemia, and significant elevated CRP. Pictures of the hepatic fracture, already ulcers and pseudopolyps and rectal ulcers. Colonoscopy showed all those features. Histology was interesting, of course, microgranulomas, poorly formed granulomas. Have you heard from the pathologist today? It was a fantastic lecture, suggesting that perhaps this is more Crohn's. Now, I mean, of course, at the point in time, when you see granulomas, we all get excited. So, of course, TB quantiferon was done, and just the foxes, indeterminate. We went to TB spot, also indeterminate. Chest X-ray is normal, means nothing because almost a third of our TB gut patients have normal chest X-ray anyway. But what's useful, at least the MR angiography showed jejunal and ileal disease. So started prednisolone very quickly, got better immediately, and when it was tailed down to 20 milligrams, that's when the problem started. Some symptoms again, and then what would you do? So the father asked, she's 18, going to university very soon. Would you retry prednisolone? But this time with azathioprine. You heard the persuasive data about azathioprine from Dr. Ajit Sood. Yes, no? Any hands? Okay, start anti-TNF based biologic therapy, and understanding you want to use azathioprine. Any takers? Quite many. Consider a biologic therapy that does not require co-therapy of azathioprine. Wow, okay, that's nice. So we look at our own guidelines. I try to quote as many references that's more Asian-centric. So we, of course, even in 2019, and Rupa is also in the group, we decided that biologic therapy would be fair to, as something to start for patients who don't want steroids or of course steroid refractory or immunosuppressant refractory intolerant. We've seen these slides in many incarnations, but reality is now we know if we treat our patients within the first 2 years at least, some profile says within 2 weeks, I think the patient does better long term. So it was easy. In Singapore, you don't have to fail immunomodulators before you escalate to biologics. It's a discussion. So the father, of course, is very important. He makes a decision for all. I mean, she's 17 going 18. So basically, they decided they're going to do a biologic. He's paranoid about the use of azathioprine. He's heard horror stories about infliximab and query TB, you know, because there are granulomas and this TB quantiferon, which always Foxes says is indeterminate. So who would anyway choose adalimumab in the audience? Infliximab. Quite many more. Ustekinumab. Wow, more hands. Vedolizumab. A few, a little bit slow, just like perhaps the activity. Okay, I don't say that in a bad way. So anyway, when we showed the patient, the father, basically the father decides everything. We say any of the choices will work. Question of how to choose for our patient. But we iterated that if you're going to use infliximab, certainly from the SONIC study, you're going to have to use at least combo therapy at the outset. So because of the TB indeterminate and granulomas, he was worried about TB. So we know quite a bit about TB reactivation. When we look at the panel on the left, we think that, wow, the data of TB reactivation is so low, but the moment you flip to the right, you see that the numbers are quite different when you look at Asian countries. So we had also data. I mean, Siu and company did really the post-marketing and clinical studies in all the Gemini studies, and we saw that there's really very little TB signals. And also, even at the point in time, 219, our guidelines said that perhaps we were quite comforted that if you're worried about TB, I think anti-integrins and IL-12/23 will be the way to go. So back to the patient. So then these patients, then we did more pre-flight checklists, then TPMT and UDT15, we talked about it, normal. Hep B, as in surface antigen, was negative, but the core was positive. Hep C and HIV were negative. So again, you know, the worry about if you use anti-TNF, are you going to reactivate Hep B? And the reality is infliximab, or at least part, and the other anti-TNF, adalimumab, have high risk of TB reactivation, even in patients who are just exposed previously, but probably not as much as the chemotherapy patients. So thank goodness, Hep B DNA was not detected. And then the patient, basically we narrowed the choices to ustekinumab and vedolizumab. So by then, the diarrhea was 4 times a day, occasionally bloody, tummy pains, not as bad as before, a bit of weight loss and occasional mouth ulcers and fevers. So this is a nice kind of Venn diagram put up by my colleague in Singapore, basically saying that you could choose, at least for her, vedolizumab, ustekinumab, anti-TNF. Of course, anti-TNF, as we know, that's not to debunk the use of anti-TNF in some of our patients. There's certainly a lot of data in pediatric pregnancy patient fistulizing, post-op recurrence, and perioperative safety issues. And of course, extraintestinal manifestations. But I think we left it to the patient. In Singapore at that time, 2017, vedolizumab was more established. Ustekinumab was just coming in for Crohn's. So of course, the patient chose vedolizumab. Also, like in many countries in the region, because of insurance, sometimes the insurance will cover the IVs, but not sub-Q. And the way ustekinumab is given is you get an IV dose and the sub-Qs are all done outpatient and you don't get admission and sometimes you're not covered or reimbursed. So they chose vedolizumab. Of course, then the father asked, well, how effective is the drug and what's the durability? So every drug we use, we should be guided by how long it takes before effect comes in. So we have to advise our patient. So we know that in anti-TNF naive population, the effect's much faster, but of course, you know that vedolizumab takes a while. You're not going to use vedolizumab in a patient with severe Crohn's because you need it to work. You need drugs that work much faster. But I think in this patient with kind of moderate disease and slowly losing response when the steroids tail down, that is a reasonable option. And I think they were thinking of safety. But if you're patient with vedolizumab, like Simon Travis will say, if you wait a while, I think it's okay. By 52 weeks, I think you get very decent clinical remission and response rates. And more importantly, unlike the anti-TNFs, if you're talking about treatment persistence, and I think Dr. Ajit Sood has shown you that because of a lack of immunogenicity, if they get into remission, they stay into remission. So basically, the patient's summary was that we got 0 to 6, then 6 weekly 2 times 2 first. Of course, it was supposed to be 8 weekly, but we were just a little bit more careful, and subsequently 8 weekly. So you can see that the changes, the ulcers, and finally by March 2022, I think everything settled. So you could wait a while, but the patient really became very asymptomatic after 1 to 1.5 years. Next patient, quickly, ulcerative colitis, diagnosed in 2009. The question this morning was who should keep the patient? This patient was kept by the colorectal surgeon for 10 years. Finally, in 2019, when he had 3 flares requiring steroids, he came to the gastroenterologist. This was the appearance, pancolitis, Mayo 3. So he had steroids, he had a lot of problems with mesalazine. When it was 40 milligrams, he responded. Every time it comes down to 20, it was a problem. When you use budesonide, MMX didn't help. So we kind of optimized him because he didn't want any biologics at that point in time. A lot of rectal therapy and in particular budesonide foam, mesalazine enema. Patient just noted also that his father had mild lymphoma, which was H. pylori related. So we finally, after 1.5 years, weaned him off all the prednisolone, requiring extensive, intensive topical therapy. CRP was normal, stool calpro 153. But the patient says, I'm not really back to where I was before the disease. I'm still going 2 to 4 times. So there is sometimes a disconnect, as has been talked about this earlier. So we did a scope anyway. So to our horror, there were Mayo 3 lesions, there were still inflammatory polyps. So there was really sometimes, in some patients, you have to listen to the patient and not just do the numbers. So what now? It was middle of COVID, so he said, no more rectal therapy, please, no more steroids, please. So we did a pre-flight checklist. So everything else was negative except that the TPMT, the NUDT was he showed that it was an intermediate metabolizer. So he said no to azathioprine. Although we said we can start a small dose, we can adjust it accordingly, he said no. Once the COVID's done, I'm going to go back to my work, and my work requires travel every month. So we left with vedolizumab, ustekinumab, and of course at that time JAK1 was coming in, so we had to, in part of due diligence, talk to him about it. He chose ustekinumab. And the reason was because he said, I'm going to travel a lot, just give me 1 IV dose, I'll take the rest. You teach me the next dose, how to give the sub-Q, and I'll give the following dose in front of you, and I'll take the bunch of syringes and go and come back every 3 or 4 months. Low infection risk, because I think there was a position paper by IBD as well as APH that says that if you're going to use the drug, maybe you use the anti-integrins and IL-12/23. He didn't have to use the immunomodulators, and he was at 60 years old, he was not really interested in the JAKs. So this is back to the pictures, and finally, after 28 months, everything went to Mayo, almost Mayo 04 for him. So he was quite happy about that. So ustekinumab, I'm sure you're all familiar with Bruce Sand's paper, basically showing that, primary endpoints are reached at maintenance at 44 weeks. Very decent data, but more importantly, ustekinumab in ulcerative colitis was the first trial that showed there was histologic endoscopic mucosal healing as part of an endpoint in the study, and it was very good data. And of course, this is to remind ourselves that it's not that we don't use infliximab in some patients, but we know that if we use that and they fail, and we use ustekinumab or vedolizumab, the data is going to be less persuasive. But if you use vedolizumab or ustekinumab, and if they fail, you can still technically rescue them with infliximab. I'm not going to talk about sequencing, that's not my brief, but really you have to think about that. So symptomatic remission, because of lack of immunogenicity, I think once they're in remission, they stay in remission. And we are very familiar with the ustekinumab drug safety. Thanks to the rheumatologist, the dermatologist shows us that if you used in their experience with psoriasis, and also we see it in our ustekinumab study that is very, very low TB reactivation compared to anti-TNFs and risk of malignancy. And also a large cohort of 721 papers from China to show us that in patients with TB, latent TB or hepatitis B carrier, whether or not they received prophylaxis or antivirals, it didn't matter when you use a non-anti-TNF drug like ustekinumab. So the last patient, and I have 2 minutes before the bus kills me and many of you. 37-year-old lady presented bilateral red eyes with blurred vision, January 2019. Uveitis was the diagnosis. HLA-B27 was positive. Was treated steroids, didn't respond, and then they hit her with adalimumab. So it took 2 whole years later before she developed intermittent diarrhea. So colonoscopy showed ileal ulcers, patchy mouth colitis, all the infective mimics were all ruled out. So we was diagnosed with Crohn's. And we escalated the steroid initially to 60 from 30. That improved the bowels. And then unfortunately, because she's been on steroids for almost 2.5 years, then she started having blurred vision, intolerance to light, and unfortunately she had cataracts. This is a 37-year-old lady. So don't forget the toxicity of steroids. So there was no choice. We went back and discussed an MDT, and then we realized, oh gosh, I didn't know, at least for in my ignorance, that when ophthalmologists use adalimumab for uveitis, they don't load it the way we load it. As in, we use 60 milligrams, followed by 2 weeks later, 80 milligrams, followed by 40 milligrams every 2 weeks. They just use 80 and 40. So we thought we'll reload her, reinduced her as the same way as we should do for a Crohn's disease patients. As far as we know, at that point in time, there was no role for vedolizumab or ustekinumab. So treatment options for EIM are important. I think in our patients, you have to customize and personalize that treatment. The reality is a lot of NTTM works for a lot of the EIMs. So the reality is JAK are maybe useful for the SPAS and perhaps the arthritis. And a little bit of data is coming out for IL-12/23 for arthritis. So this is a very nice cartoon that gives you all the colors. All green means good. So essentially, look out for the small molecules. I think the small molecules are going to help quite a bit, especially arthritis. It's going to bust soon. Okay, so STRIDE, we know all about it. I won't show. But really, the reality in Asia is that, wow, thank you. In Asia is that we talk about step up, accelerated step up versus top down. I think stratifying the patient, like what Charlie says, is very important. Not all patients need to be top down in Asia for sure, but do bear in mind that you're going to have more drugs and more side effects. And of course, do we aim for histologic or transmural healing? That's a question we talk about. So basically, early to treat for our patients, we've already poor prognostic signs and all this. So that's important to kind of stratify. So I think this is a summary slide that has said everything, except for what I didn't cover is ustekinumab, and there's a little bit more data now to say that if you cannot use the anti-TNF, ustekinumab may be useful for our fistulizing disease patients. And this is a summary slide again to say that I mean for our patients, really a lot of them didn't want to use thiopurines. The older adults, I think they were worried about anti-TNF side effects coupled with other medications like the combo or steroids. And of course, we worry about TB and hepatitis B in this area of the world. So I think we can use non-anti-TNF biologics very well. You just have to pick and choose the patients, and I think they're very safe. So thank you very much. Just Kiran, I'm sure you can see your face here, and these are all our friends who have been helping to navigate the IBD education in the region. Thank you.
Hello, I request Dr. Rupa Banerjee. She is a senior consultant gastroenterologist in Department of Gastroenterology in AIG. Her interest in luminal gastroenterology, especially IBD. She has so many papers and articles peer-reviewed, and she has reviewed so many journals. And she has faculty in international workshops and lectured national and international level. And she has published books on IBD also. Thank you, madam, and dais is yours.
So good afternoon, everybody. And first and foremost, Kiran, thank you so much. I see so many friends here, and on a Saturday afternoon, this is really a peaceful, quiet place. Thank you for inviting me. So we've done the biologics, we've done the basics, and now we are left with some small things. These are the small molecules. So IBD is now a global disease. we've actually come a long way with the treatment. If you see, IBD is recognized. And can you imagine, we searched for a treatment for so many decades. And what did we do? I just want to highlight, we did psychotherapy, psychoanalysis for ulcerative colitis, induction of artificial fevers, just to get some symptomatic relief. Then we thought we had it all, steroids, mesalamines, azathioprine. But in 1997, I suppose, 1993 was the first case, came this new drug, infliximab. The first was just a case report. But within a few years, we got FDA approval. And what happened after that, it came in, was the era of biologics. You name it, we had it. We had so many of these biologics. And they changed the whole paradigm of IBD treatment. We started thinking of mucosal healing, avoiding growth retardation. Forget about even simple things like, no abdominal pain. We were thinking much beyond and to a normal life. After 2 decades came something small, the small molecules. So the first question is, what are these small molecules? So these are actually a heterogeneous group of drugs with low molecular weight, the ability to cross biologic barriers, modulation of different biological targets, and oral bioavailability. Additionally, they follow the famous rule of 5 now. It was actually designed by Pfizer, and it's now accepted in all pharmacotherapy. And that's the Lipinski's rule of 5. The molecular weight should be less than 500 grams per millimole. I'm not getting into it, but now for all oral bioavailability of drugs, this is what is followed. And what is the thing? So the focus today for discussion is the small molecules. And there are 3 groups that we should know about: the JAK inhibitors, the S1P receptor modulators, and the P4 inhibitors. So these are the primary groups of small molecules that are used in IBD. So the first is the Janus kinase, the JAK-STAT signaling pathway. And I put this picture because it's named after Janus, the 2-faced Roman god of beginnings, and faces 2 sides. It's for beginnings, it's for transitions, and it is for endings. So this group has 4, it's a family of 4, the JAK1, JAK2, JAK3, and the tyrosine kinase. And as you can see, the JAK inhibitors block working of the STAT and downstream activation, helping thereby in inflammatory bowel disease, reducing inflammatory cytokines. So this is the ready reckoner for everyone. If you can see, the 3 ones that we need to remember in practice is upadacitinib, filgotinib, and tofacitinib. And tofacitinib is the non-selective one, and upadacitinib is the JAK1 specific one, can be used for both Crohn's and ulcerative colitis. The next is S1P modulation, selectively reduces migration of lymphocytes from the lymph nodes. And we have 3 drugs here, ozanimod, etrasimod, and fingolimod. And you can see the red cross mark right in the middle, because what does it do? These S1 receptor modulator binding results in receptor internalization. What happens as a result? Reduced egress, fewer circulating lymphocytes, decreased inflammation. So that is a different mechanism of action. Again, an oral small molecule. We don't have much of this, but I just wanted to highlight that these are the phosphodiesterase inhibitors. PDE4 is what it's called. They modulate mucosal homeostasis by different mechanism, and apremilast is the name for the fellows to remember. Of course, it's not available in India. So the new kids on the block, one is upadacitinib, first oral drug approved by FDA, improves endoscopic outcomes in moderate to severe active Crohn's disease, irrespective of previous failure, effective for fistulas and fissures, treatment of refractory pediatric IBD, and not associated with anemia in moderate to severe ulcerative colitis. So these are very important. Once we are seeing infliximab failures now coming in, it's more than a few decades with this secondary loss and primary loss of response, we now have a good oral drug available. And then we have ozanimod and etrasimod. All of these are good options, and you can see I have put in a few slides showing long-term safety, real-world efficacy, week 52 outcomes superior with ozanimod, much superior than placebo. But we all know that, compared to placebo, any drug that goes into phase 3 trial always does well. We need to know what about in clinical practice. So this is the overall list of small molecules if you want to know, and I just gave you a highlight of what is what. We should now come to India. What about this large country in the whole world? And we've just won the World Cup. At the same time, there's only one cup, the only small molecule we have here, tofacitinib, approved by FDA, JAK1/2/3 inhibition, a dose of standard dosing of 10 milligram twice daily for 8 weeks, followed by 5 to 10 milligram twice daily, depending on therapeutic response. So the discussion today over here in India is going to be, what are the options for advanced IBD therapy in ulcerative colitis, the fight between the large biologic molecule and the small molecule, if you can see the comparative size. And that is what we will discuss today. And that is what Kiran has asked me to talk, what about the future? Will these small molecules be a game changer? So the small molecules are poised to challenge the use of biologics. You can see the poor tofacitinib in India trying to tell the biologic, I also stand a chance. The question is, which should we use first? And what I thought we should discuss here in an academic environment is, why not tofacitinib first? So choosing the first line therapy is a delicate balance, efficacy and safety. And we have to go with that when we choose what to do first. So what do we need to know in practice? Comparative efficacy, does this drug work? Safety concerns, is it safe? Accessibility, do we have it? Affordability, can we afford it? And what does the real world say? Not the NEJM, not the landmark trial. What do we say for our country, the real life clinical experience? So if we go to comparative efficacy between these two, the pivotal tofacitinib studies, you can see that it does work well. If you compare induction of maintenance and maintenance of response or remission to the various biologics and tofacitinib right at the lower end, actually it does not fare bad. There are no head-to-head trials, of course, but if you see the landmark trials and the comparison with the others, you will see that it does work. So all agents are superior to placebo for both induction and maintenance. Head-to-head trials, of course, are not there. This is a comparable efficacy, but tofacitinib does stand there. Sequence of treatment, why should tofacitinib be used first? Because maximizing effectiveness when used in the right sequence. If you give anti-TNF, then all the other drugs, they don't work as well. And that is what we need to see. We know that anti-TNF naive patients do better with other classes of therapy, and that has been seen with vedolizumab, that has been seen with ustekinumab. Biologic naive patients do respond better to tofacitinib. So logically, if you are going to use it, why not use an oral drug first? If it does not work, if there are adverse events, you can always fall back on the big brother, and that is the big molecules of the biologics. There is evidence from both the Octave and there is real-world evidence which shows that effectiveness is not impacted for anti-TNFs by prior tofacitinib exposure. Then there are specific scenarios in moderate to severe ulcerative colitis where we can show that tofacitinib does work if there is synovitis, arthritis, if there's a low albumin, malnourished patient, ulcerative colitis with psoriasis, pustulosis. These are all situations where tofacitinib does stand. It can be used, and these are papers which are coming in as a first-line therapy for acute severe ulcerative colitis. Look at the convenience of all the IV and admissions versus an oral drug. Low immunogenicity. There's no need for concomitant immunosuppressants. And then lately, we have seen studies of tofacitinib coming in children and young adults also. Which child will want an injection or a tablet? Sometimes we also belong to the same category as far as injections are concerned. And then comes the safety concerns. You see, FDA did not give it a first-line approval because of these. There was a phase 4 rheumatoid arthritis study which said that there could be high incidence of cardiovascular risk factors. And you can see what has happened. FDA has responded. There was a restriction in the use of tofacitinib. But if you go into the depth, the pulmonary embolism cases happened only at 10 milligram twice daily. There was no mechanistic role, not seen in any of the phase 2 or 3 trials. The lipid elevations were in a dose-dependent manner. Increased risk of herpes zoster, yes, but we do have the Shingrix vaccine now. So anti-TNF therapy also has increased risk of herpes zoster. So it's not that the other biologics, there's no risk of herpes zoster. And if you can see anti-TNFs, I'll not get into it. We know of the serious infections, risk of malignancy, side effects galore for biologics as well. Maybe not so much for vedolizumab. So if you see safety issues, biologics versus TOFA, they are equally poised, and we do have to be careful. It should not be discriminate use any day. Vedolizumab comes in between, and I think because of its gut-selective nature, the side effect profile is bound to be better. Accessibility, affordability, and I come to rural India, and we do this program, and what we have seen that many, and we did this survey during the COVID-19 period, that how many have access to all these IV infusions. What we found, out of 1,009 patients, 22% patients missed their scheduled biologic dose due to inability to visit the infusion center or non-availability of local infusion center with expertise. They were just told, we don't know about biologics and we can't give it to you. So in reality, an oral drug is much more accessible. If you see balance between efficacy and safety, the third pillar there is cost. And in India, we know that the balance between efficacy and affordability drives our decisions. Majority of our patients have no insurance and are actually paying out of their pockets. In this situation, you have oral drug with the generics, maybe low cost, and much more convenient. Why not tofacitinib first? We found in a study that we published that out of 10,000 patients, single point ever received biologics in this whole part of the world was just 4%. So there is that gap of people who need biologics who are not getting it, and we now have a small molecule compared to the big molecule who can take that space. So our algorithms in practice still, as far as recommendations are concerned, is corticosteroids, immunosuppressants, biologics, and JAK inhibitor. But look at the cost, and with the cost benefit, sometimes we do need to change there. The cost of IBD in high-income settings is also huge, and we need to know that as well, because we think that for the Western world, cost is not important. It is. And if you see this study, 75% of patients with Crohn's disease are on biologics by 5 years of illness. So if this is true, we all globally need to be concerned about the cost. And this is a study from Japan which has shown that the treatment pattern, including tofacitinib, is a cost-effective alternative to the biologics for patients with moderate to severe ulcerative colitis from a Japanese payer's perspective. So why not India? And then finally, the real-world experience. If you see the real-world experience, and I think I first will quote this paper, Giri is sitting here in the audience, and he suggested in this multicentric study that upfront tofacitinib in patients with the biologic-naive patients does work. And in a series of 47 patients, and this was the first thing, adverse events were there, but not significantly higher. And then we have just presented this data of more than 176, 200 now, more than 200 patients. And what we have found is that it is efficacious in biologic-naive patients. And if you see here, we found tofacitinib was effective in induction of clinical remission in more than half of biologic-naive moderate to severe ulcerative colitis. 3/4 of these patients continued to be in remission at 1 year with very few serious adverse events. Tofacitinib can be considered as upfront oral therapy as far as the data that we have. Interestingly, first-line TOFA responded earlier than those with previous biologic exposure. And this is the latest that we have published. All of you here from India are actually a part of this. I think, Kiran, you are also a part of this. That TOFA can be used as a first-line drug for ulcerative colitis after careful consideration against black box warnings, including increased risk of serious cardiovascular-related events. So we have to be careful, but sometimes it may just be practical. So you can read this paper, and this is the algorithm that we can practically use in India for moderate to severe ulcerative colitis. So the current perspectives of tofacitinib, what we knew, the case for TOFA, oral drug, comparable efficacy, no immunogenicity, small molecule, low albumin, does not impact, works for arthritis, is low cost. And what have we learned today? It can be positioned as a first-line advanced therapy, and maybe the small molecules will come first in future. Are really JAKis superior to biologics? I don't think so, and neither are we in a position to comment on that. We need to consider efficacy, safety, cost, convenience, and there are no head-to-head trials. We have more experience with the biologics. We know that they do work. Both have infection risks. Might there be a reason to use tandem? That is going to be future research. We will continue to wait for the perfect dream therapy. A favorite slide of mine, I keep adding that. We need a drug, no side effects, universally effective, easy to administer, cheap, and readily available. We want to know more about biologics and everything in IBD. Invite you September for the AIG Live, and next year, 25th to 27th April, for the AIG IBD Summit. Thank you so much.
Thank you, speakers and chairpersons. The session is open for.
Next, I would like to invite respected Dr. Devendra Desai, sir, for the topic therapeutic drug monitoring IBD, how and when. So, Dr. Devendra Desai is a senior consultant and head of gastroenterology unit at IBD Hinduja Hospital and Medical Research Center, and he has vast experience of 35 years in the field of gastroenterology and founding member of Colitis Association of India. And he started inflammatory bowel disease clinic at IBD Hinduja Hospital in 2004, and a patient support group called Colitis Association of India in 2005. And in 2002, he attended Birmingham University Liver Unit as a visiting doctor, and he attended Mayo Clinic as an observer in inflammatory bowel disease. And he conducts charity camp in gastroenterology once a year since 1997. And he got selected for the Commonwealth Scholarship and worked in polyposis registry in St. Mark Hospital, London. Over to you, sir.
Very nice. Okay. So my sincere apologies for blocking the coffee. So I wish to thank Dr. Kiran Peddi and the gastroenterology and the Yashoda Hospital. And I will be speaking on therapeutic drug monitoring in IBD. And so basically, the basis of TDM is that generally there is a positive correlation between the drug concentration and favorable therapeutic outcome. So what it involves is measuring drug concentration and or antibody, thereby individualizing the dose of the drug and maintaining drug concentration in therapeutic range. With maintaining the drug in therapeutic range, we get increased rate of response to the treatment, endoscopic healing, reduced relapse rate, hospitalization and surgery, and improved quality of life. So the rationale for TDM in IBD include to improve the efficacy and predict the toxicity when the drug has narrow therapeutic range, as in case of thiopurines, and to achieve the desired drug concentration when there is a variability between the dose and the concentration of the drug, as in case of biologics. So proactive TDM is basically measuring drug and antibody levels regardless of the disease activity, targeting optimum level for achieving better outcomes and preventing failure of therapy. Whereas reactive TDM is measuring the drug and antibody level when the disease is active to guide the treatment. So let us move on to thiopurines. So thiopurines are important in this part of world, and they are mainly indicated as maintenance therapy. About 15 to 40% of the patient discontinue thiopurines due to severe adverse drug reactions, and as we know, Asians are more susceptible. To reduce the toxicity, the pre-treatment testing for TPMT and NUDT15 genotype has been advocated, but the practice is variable. Some don't do it. NUDT15 mutation is more common, that is about 15% as compared to TPMT in Indian, which is about 4.5%. So the thiopurine metabolite testing is done after starting the drugs, and it includes 6-TG, that is 6-thioguanine, and 6-methylmercaptopurine, that is 6-MMP. The therapeutic range for 6-TG is 235 to 400, and that for 6-MMP is less than 5,700. So when do we do the thiopurine metabolite monitoring? So AGA guidelines suggest that thiopurine metabolite testing should be done in patients with active IBD, that is, it should be done as a reactive TDM, and in those where we are suspecting thiopurine toxicity. So let us move on to the case studies. There are two case studies. So the first is a 29-year-old engineer. He had Crohn's disease since 2017. He had repeated abdominal pain, occasional vomiting, and increased bowel frequency. So the baseline stool calprotectin and C-reactive protein were elevated. And in August 2017, he was initiated on Pentasa. However, in October 2017, his pain persisted, and budesonide 9 mg and azathioprine 25 mg added, as he was NUDT15 heterozygous. Now this is the course of his treatment. As you can see that in November 2017, his pain had reduced, calprotectin had mildly reduced, C-reactive protein was still high, and he was on the medicine that I told you just now. In January 2018, he was well, calprotectin reduced, CRP became negative. However, to our surprise, 6-TG and 6-MMP were undetectable, suggesting that he was non-compliant and his wellness was due to budesonide. So he was counseled azathioprine was increased to 50 milligram. In March 2018, he was well, calprotectin decreased, CRP remained negative, and budesonide was reduced to 3 milligram. But as soon as that was done, his abdominal pain recurred. He again started vomiting, C-reactive protein increased, and budesonide was temporarily increased to 6 milligram per day. In May 2018, the abdominal pain, he had abdominal pain, and the metabolite, the thiopurine metabolite again were suboptimal. So it was 96 6 Tg, which is far below the recommended level. So azathioprine was increased to 75 milligram per day. His counts were monitored and they were normal. And from July to December 2019, he remained well. Calprotectin also decreased, CRP remained negative, and over a period of time, budesonide was stopped and 5-ASA was reduced. So here, thiopurine metabolite monitoring helped to get the remission and maintain the remission. So this is the second patient, a 51-year-old male with ulcerative colitis. His disease was active in spite of oral and topical 5-ASA after 2 courses of steroid, and this stool calprotectin was high. TPMT was mild, NUDT 15 heterozygous. He was initiated on azathioprine 50 milligram daily, and weekly CBC was asked for. After 2 weeks, his hemoglobin, WBC, and platelet decreased, all of them, and he had weakness. However, fecal calprotectin became normal from more than 1800 to 53, and we asked for thiopurine metabolite, though early than what normally we ask, and we noticed that 6 Tg was very high. The normal should be 450, but his was 851. So we reduced the dose of azathioprine to 25 milligram per day. His CBC improved and remission was maintained. So this is our data of thiopurine metabolite monitoring. This is our initial study which was published, and this is our revised data. So 721 sample, and you will notice that about 50% of the patient has a subtherapeutic level, which gives us a scope for optimization of the drug. And about 14% of the patients have supratherapeutic levels, and this gives us a scope for reducing the toxicity. So if we use this judiciously, if we compare subtherapeutic levels of 6 Tg with therapeutic level of 6 Tg, then we have more than 40% higher rate of remission. So since azathioprine is used more commonly, we should use these two. One is preemptive monitoring as well as thiopurine metabolite monitoring. Let us move on to the biologic agents. We know that biologics have brought a paradigm shift in the management of IBD. However, significant, about half of the patient have either primary non-response or secondary loss of response. And as we know, in case of biologics, there is no linear relationship between the dose and drug concentration. So there are various guidelines on TDM for biologics. So summarizing these guidelines, TDM is indicated in patients with active disease, that is reactive TDM, and it should be done in patients on maintenance therapy. Proactive TDM should be performed after induction for the patient treated with anti-TNF and at least once during maintenance therapy. And the proactive TDM is most important in more severely active patients and in patients who have higher drug clearance, which now we can measure. So also these guidelines had actually, they were indicated only patients who were on maintenance therapy. Now we know that there is a clinical utility for TDM during induction also, and there is no difference in TDM between biosimilars and originator molecules. So there is a lot of controversy about the evidence for TDM. I will summarize here. Though reactive TDM is recommended by many medical societies, high quality data from the randomized control trials using objective endpoints are missing. So There was a systematic review and meta-analysis by Ricuto et al. And he compared reactive, proactive TDM versus empirical therapy. And the conclusions from this study was that either reactive or proactive TDM, there was no benefit in terms of clinical remission, endoscopic remission, or surgical response. The benefits included reduced cost, reduced antibody formation, and increased durability of anti-TNF agents. There were other studies which followed that, and those also had similar result. That means they did not show the evidence for reactive TDM. So these include Telorix, Serine UC and CD, and Nordrum A. However, the recent studies after that, like Pellet study for children and Precision study, they showed benefit in terms of clinical remission. So TDM, we have come long way, but still we need further evidence for efficacy of TDM. Now, what is available in India? We have infliximab level, we have antibodies to infliximab, and we have adalimumab level. Now, let us look at some real life cases to know whether we really need TDM in every patient or no. So, this is the first patient, 40-year-old patient with luminal ileocolonic Crohn's disease. He was initiated on biologic for severe disease non-responding to conventional therapy. At week 14, he was in remission. HbA was 2, Harvey-Bradshaw index was 2, C-reactive protein was normal, stool calprotectin decreased from 1500 to 150, and serum albumin was normal. So is TDM required in this patient? No, we don't need because he is responding. Though many people would do one level at week 14. This second patient is an 18-year-old girl with ulcerative colitis, E3 disease, needed biologic as she had active disease in spite of 3 courses of steroid, and she was on azathioprine. So at the end of induction, the boil frequency was 5 per day with blood in 3. Serum albumin was low, 2.3, and C-reactive protein and stool calprotectin were high. So infliximab dose was preponed, and however, symptoms persisted. So do we need TDM for this patient? Yes, we need. And because this patient has active disease, we need reactive TDM. So the infliximab levels were found to be low. In her the levels were 1 microgram per ml, whereas the recommended is 3 to 7. So dosing frequency was decreased, and this patient achieved clinical remission after TDM. Now the next patient is 21-year-old patient. He had Crohn's disease. Previous treatment included adalimumab failure, vedolizumab failure, and the last dose of vedolizumab was about a month back. At presentation, he was severely malnourished. He had a low albumin of 1.9. CRP and calprotectin were very high. The first week went into improvement in nutrition. After that, it was decided to initiate on infliximab. So do we need TDM in this patient? Definitely. And we need proactive TDM. And that time ustekinumab was not available. I will not comment about tofacitinib because Rupa is here. So the azathioprine was added to prevent the development of antibody. He achieved clinical remission. He gained weight with infliximab and azathioprine. After a year, he was very well. We were surprised with the response. After a year, he became irregular because he started his college and relapsed. He had a very high titer of antibodies to infliximab, and he had a secondary loss of response. So next patient is a 34-year-old lady with ulcerative colitis. She was initiated on infliximab 200 milligram, but her weight was 60 kg. So she was given suboptimal dose. She was marginally better after 2 doses, after first dose, and after 3 doses she relapsed. She had a very high antibody titer, 1575, and she developed antibody due to suboptimal doses with low drug level, and she was changed to adalimumab. This is our initial experience of reactive TDM. We can see that of 50 patients, 80% of the patient had suboptimal, subtherapeutic level, and 27% had antibodies to infliximab. The management was changed in 35 patients. Clinical response was achieved in 25 and remission in 5 patients. This is our latest data, and we can see that of the infliximab level, 970 patients, these are the samples from all over India. You can see that 41% of the patients have subtherapeutic level of infliximab, and in 123, it is not actually detected. As regards the anti-infliximab antibodies, of these 770 samples, in about 27% of the patients have significant titer of antibodies. So this was about anti-TNF. What about TDM for non-anti-TNF biologics? Sorry for the duplication. So regarding vedolizumab and ustekinumab, there is evidence for exposure-response relationship. However, two trials, Interpret trial for vedolizumab and Stardust trial for ustekinumab, did not support or did not give any evidence for therapeutic drug monitoring. Regarding JAK inhibitor in clinical practice, role of TDM for JAK inhibitors remains unclear. Further development in the field of TDM. So we are giving 5 milligram per kg dose, we are giving 10 milligram per kg dose, but can the patient need 7 milligram per kg or say 5-week dosing interval? This may be answered by Bayesian model based dosing, one of which is dashboard approach. So dashboards are basically software programs, and the dashboard system integrate pre-existing pharmacokinetic model, the patient and disease characteristic and the drug level into single display to predict the drug level and the dose timing. So it can tell us when should we give the dose to individualize the therapy, and at present it is available for infliximab. So there is initial evidence, including ours, for the iDose dashboard approach. So the initial evidence suggests that we can explore it further. So, Mr. Chairman and dear friends, TDM has a role in IBD due to narrow therapeutic window and non-linear dose-response relationship. It can be reactive or proactive. In case of thiopurine, the metabolite measurement can improve thiopurine efficacy and reduce the toxicity, and it can improve the remission by nearly 40%. In case of biologic, we have seen that the low drug level of infliximab are common, and trough level measurement could be useful in approximately 70% of the patient. Newer approaches like dashboard approach will improve the utility of biologic, prevent failure, and save cost. And I would like to acknowledge my colleagues in the Department of Biochemistry and Molecular Biology who do the testings. Thank you so much.
Yeah, thank you, sir, for that wonderful lecture. In this session, actually, we had all the four talks. Dr. Sood was telling that thiopurines and 5-ASA are going to exist in the therapeutic armamentarium of IBD. It's not the time to extend, that's what we understand. And Dr. Uy was telling that non-anti-TNF biologics, particularly the ustekinumab, may have an edge, more so in those patients who are not willing to take the thiopurines. That's what we understood. And here was then a opener that Dr. Rupa was telling, and in fact she was batting for a small molecule in a big way. Definitely they are poised for a big role. I think, but a judicious use of these molecules are required at the moment before we get any further evidence to start as an opener. And the last talk, what Dr. Devendra Desai has given, extremely useful talk for the practitioners and to make the decisions in a day-to-day practice. We thank you, sir. We thank you all the speakers. And if there are any questions, if the time permits, I think we can take it. Otherwise, the organizers took a call.
So thank you, everyone. I would like to invite chairpersons to hand over mementos to the speakers. Dr. Ramanjan, sir.
this, we come to the end of the session. We'll break for coffee. Coffee is to your left and right. And then after that, we'll come back for the next scientific program. In the meanwhile, I request the delegates to go through the industry stalls also. I think that is very, very important that we support, the industry supports the conferences and we support the industry. In 15 minutes, we collect back here for the next session. Thank you so much.
Good evening, everyone. Welcome to this enlightening session on gut microbiome in IBD. This is a crucial topic that delves into the relationship between gut microbiota and IBD and offering insights that could pave the innovative therapies and better patient outcomes. I am honored to invite our distinguished guests, chairpersons for this session, Dr. B.S. Ramakrishna, Dr. Charlie, Dr. C.J. Oy, Dr. Nikita Kandiala, and Dr. Deepak, Dr. Uma Devi. Now I would like to request the chairperson to introduce our esteemed speaker, Dr. Kiran Peddi.
I don't think we need to introduce again. We've been introduced a couple of times this morning. So can I have the slides, please? So due to the time constraints, we decide to curtail this session to half an hour rather than 45 minutes. So I welcome all the panelists for this. So the microbiome is a very new topic, and all of us are learning, basically. Especially the gastroenterology, we don't have enough technical knowledge to know how exactly we do the testing, what kind of methodology to be followed, when do we do, and other things. So we'll be touching upon introduction and definitions, and the testing for microbiome, good and bad bacteria, indication for testing, and a little bit on microbiome therapeutics, and then global perspectives. So all the human organisms, living organisms, are classified into three phyla. So the highest order is domain, then it comes down to species as we narrow down. So gut microbiome plays an immensely diverse role, not only in terms of disease modification, modulation, it also involves in supply of nutrients and energy, development of immune system, and also plays a crucial role in host defense. So wide diverse functions of gut microbiota is depicted here. Development and training of immune system, biosynthesis of vitamins and amino acids, metabolism of therapeutics. So each of us would act differently to, when you're given a same drug to two different people, both of us or both the people will react in a different way. That is probably one of the factors contributing to that is different microbiota, and we are acting like a human being carrying the bunch of microbacteria. So the metabolism of drugs would differ based on the microbiota as well. So a few questions to panelists. So Professor Ramakrishna was involved in Indian microbiome project in a big way. Sir, we often get into a lot of confusion with terminology used in microbiome world. So can you explain us or take us through these terminology?
Yeah, I think you have all the definitions here.
Yeah, but from your side, these are given to you by most of the panelists anyway.
So essentially what I would say is that the gastrointestinal microbiome, the study got revolutionized when molecular methods of study came in. Before that, we were doing basically culture-based microbiology. And that missed out a lot of the microbial organisms in the gut which were anaerobic. And from the soil microbiologists, and particularly from France, is really when it got translated to gastroenterology. The microbiome basically is all the genetic composition of all the bacteria, and there are there are a huge number of genes there. The actual bacteria which are present are called microbiota. And as Dr. Kiran has said, starting with phylum and then going down to family, genus, and species, we're all familiar with genus and species. Metagenomics is you just take the entire DNA or RNA of the of whatever there is there in that community, and then you look at it. There are many ways of studying it. Transcriptomics is whatever RNA is produced by this. The proteomics is the proteins produced by it, which are the ones which act biologically. And metabolomics is all the small molecules like the short chain fatty acids and the other drug metabolites, et cetera, produced by the microbiome.
Thank you, sir. So, Dr. Deepak, can you take us through a few of the definitions like richness, relative abundance, alpha diversity, and beta diversity? These terminologies are kind of basic, becoming basic in microbiome world nowadays. So all of us need to be familiar with this terminology nowadays.
Thank you, Charlie. Richness simply means like broadly the number of various stacks of, again, especially if you're looking at bacteria in the samples. Relative abundance is like when you're sort of comparing within taxa against each other. So sort of if one's sort of more abundant than the other. So alpha diversity sort of talks about if you're looking at one sample and describing the diversity of the species within this. And then beta diversity and alpha diversity, there are different indices like Shannon index, commonly reported, this Cho index, and multiple other ones. Beta diversity is sort of the, if you're looking at sort of comparing between samples or between ecosystems, which is important. I'm sure that'll come up in the discussion that even for the same patient, there can be a sample-to-sample variation. There's that really nice study in one of the Nature journals where they sampled the same individual over time. And obviously, differences between ecosystems based on other extraneous factors like diet.
So that essentially compares one sample to other sample, whether it's the same individual or different individuals.
Correct.
Okay, so as Dr. Deepak explained, these are some of the other definitions. We'll move on to next. Professor Uma Devi, madam, can you take us through the normal composition and distribution of various bacteria in GI tract? I can just, these slides were given by you, so I will just put up the slides as well. You can talk through those.
As you all know, there is a lot of gut microbiome constitutes 70% of the whole human microbiome. And there is variation in the GI tract from proximal to distal. There is increase in the diversity and increase in the abundance. And there is an increase in the luminal pH. You have to compare the luminal status of the GI tract also. There is increase in the luminal pH. At the same time, there is decrease in the oxygen gradient in the lumen. So 90% of the gut microbiota are facultative anaerobes. Most commonly in the colon, they are anaerobes. And our human microbiome project, along with the MetaHit project, they have divided basically these into broad four phylums. The firmicutes, they constitute the most, followed by bacteroids, then Actinobacteriaceae and Protobacteria.
So, madam, that means when you're collecting the stool sample, so it's not a true representative of what the human microbiome is present in the GI tract.
In fact, the GI tract microbiome is again divided into the mucosal microbiome, luminal microbiome, stool microbiome. So at all the three levels, there is a difference in the microbiome within the colon itself.
Correct. So the mucosal attachments we can't be assessing.
Different, and stool is different, whereas that is attached to the in the lumen separately is also different.
Sure. Thank you, madam. So what happens in symbiotic state and dysbiotic state? Can you take us through again?
human provides shelter and the nutrients, and you have already mentioned in your introductory slide, the microbiota, they synthesize from the human accessible nutrients, they synthesize the short chain fatty acids. They play an important role in the amino acid metabolism and in the bile acid metabolism, thereby in the mainly in the hormones itself. So ultimately, they act in symbiotic relationship with the host, and whatever happens in the lumen and in the whatever the patient takes, like antibiotics and all, there will be immediate change in the microbial function, structure, composition, and the way, then the metabolites, small molecules secreted by the microbiome also.
Sure, thank you, madam. So we'll move that.
And this is another important slide. Eubiosis everyone knows, so I'll tell only the dysbiosis.
Yeah.
Whenever there is a dysbiosis, there is a decrease in the mucus layer, decrease in the, there is a growth of opportunity pathogens, and there is an imbalance in the T cells, and the apical priming cells are unprimed, and there is impaired IgG secretion also. The milieu itself is totally lost, and the protective barrier and mucosal integrity is impaired when there is a dysbiosis. Ultimately leads to all the problems.
All the disease status. Thank you, madam. So the traditional cultivation of bacteria, when you ask for stool culture, which is traditional test was all of us do, number one, it just a fraction of bacterial composition will be cultivated by growth of the, by culture mechanisms. But that's not a true representative of the whole microbiome which is present in the stool sample. And the current traditional culture techniques will not be able to isolate or identify rest of the bacteria. So for that, we have more technology or techniques coming on a way. We'll come to this in a few minutes. So Dr. Nikita is a principal scientist who deals with microbiome all the day. So can you tell us about varying methods of studying these complex? What is the difference between traditional culture and culture independent methods? What I mentioned just now, like 16S sequencing, shotgun. So all of us are gastroenterologists. We don't know much about the technology or technical terms. Can you just explain, simplify us?
Yeah, so first I'll talk on the culture and the culture-independent methods, where largely we have been, as my fellow panelists were discussing on the culture-based methods, why anaerobic conditions and why we are not able to make the gut microbiota repopulate and study them. It's a very harsh conditions down there in gut, and it's hard to revive them. And when it comes to culture-independent methods, we are largely now looking into the sequencing, which has been closely to 2 decades that it's been emerging, and recently it's been more accessible in terms of cost and various aspects to it. Even the analysis of it, we're understanding how we can analyze this DNA sequencing data. So earlier, even in the sequencing emerging, we were studying the human genetics largely. And now we are, in a decade's time, we are understanding how we can also understand the microbial genetics, which contributes to various aspects of the gut microbiota and the gut health in general, the gastrointestinal health. So coming to the methodology here, you've mentioned about the 16S sequencing and the shotgun sequencing. So to make it simple, 16S is a targeted sequencing. So, and it largely in the sequencing methods that we use, we look at bacteria. Even though microbiome consists of the fungi, archaea, and the viruses, but we look at bacteria because we have that data accumulated. We understand how bacteria impacts, and bacteria is largely variable based on the drugs we take, the food we take, the lifestyle. And it's very relevant to study bacteria by accumulating of that data. So we look at the bacteria, and in 16S, we look at the bacteria, what type of bacteria. So it's a targeted sequencing. And based on the regions you are targeting, you'll be able to identify what type of bacteria you identify. Right. So when it comes to shotgun genomics or the metagenomic sequencing, we sequence the whole bacterial or the microbial genome. that is available in the stool. And here we are also getting the information on not just the bacteria, but also the viruses and the parasites, the fungi that is present in the stool sample, and how you are able to look at the metabolite aspects as well using the shotgun metagenomics.
Thank you. So I'll simplify for my colleagues who don't understand much about this terminology like myself. So I think in my crude language, culturing bacteria is like, so for example, if you show a photograph of James Bond, you know that you can recognize it's a James Bond. But if you show a picture of James Bond face is covered with something else, but he's holding a gun like James Bond holds, that's indirect evidence to say that, yeah, this is behaving like James Bond, so it could be the picture of a James Bond. So that's an indirect way of identifying bacteria by genetic testing. So is that something, am I very absurd, or can I say that the similar indirect evidence to say that how bacteria is isolated? Sir Ramakrishna, sir.
No, the thing is that the fecal bacteria are anaerobic. They live in a very anaerobic environment. So one of my colleagues used to say that a whiff of oxygen will kill them.
Right.
So that's why you cannot culture them. When I was doing my DM and doing work with this thing, we used to go to all lengths to culture anaerobic bacteria. We had these large anaerobic chambers. But with the molecular ones, the molecular, you can actually recognize the patterns. The 16S ribosomal RNA is what is called the molecular clock. So it has multiple regions. Some regions are conserved. It are conserved right from the beginning so that from family onwards it's conserved. There are some regions which are variable, and then there's some regions which are hypervariable. So the hypervariable allows you to distinguish between strains and between species. And that's what we target when we do
16S is the most consistent.
Yes, that's a 16S ribosomal RNA. It's about 1,500 base pairs.
Yeah.
So it's easy to isolate and it's easier to sequence.
Thank you, sir. Metabolics, just in a word, in a sentence, Nikita.
So any small molecules that are released by these bacteria and any studies that we do to study these metabolites is metabolomics. So we study the small molecules and its interaction to the gut lining or the receptors that it interacts with. So, yeah.
So for PGs again, if a metabolome, a product is produced, you identify that, quantify that, and say that this could be produced by X bacteria, then you
you
kind of
correlate it to the pathways, how the bacteria survive.
Sure, thank you. So you also wanted to talk a little bit on this. Can you quickly take us through this? You're running a little short on time, but
Yeah, it's the same thing what I have just mentioned about how we study, and also Dr. Ramakrishna also said about how we look at the highly variable regions and try to derive these bacteria using the ribosomal RNA. And the metagenomics is looking at the whole sequencing of the genome that is present in the stool sample. And when it comes to single cell sequencing, you look at single cells that are derived, and largely we are not using the single cell sequencing yet into understanding how we can use that in the microbial genomics. But 16S and the shotgun metagenomics are in play, and that's how you define the communities and the phylogeny and the species.
So in short, 16S sequencing gives only bacteria profile, and then short genomic sequencing gives a whole profile, including bacteria, virus, phages, and everything else.
Yes.
So we'll move that. So the same thing again. So what are the standard practices involved in this technology? Once you collect the stool sample, and what are the kind of steps involved in kind of analyzing these data, and what can go wrong?
So this slide. So the sample collection process in our testing service, we use the preservation buffer that immediately after collecting, it just stabilizes the sample, so there is no overgrowth. So that is something you have to look into when you are doing the analysis, or you're freezing it immediately. If you're looking at the DNA, and this preservative is to preserve the DNA, not the other species in there. So, and it makes the biological component inactive, and there is no more growth in there. So, and as you're talking on the storage of the sample, so if we are using the preservative buffer, we don't need to think about the storage. It can be stored at the room temperature.
How long we can, once you collect the stool sample, how long it can be kept outside before that comes to the lab?
So it can be stable at the room temperature for over 4 to 6 weeks.
4 to 6 weeks.
Yeah, it is very stable.
And that's standard across all the labs, whichever buffer you're using? Or
Largely, yes, yeah.
okay, so we'll move on. So how to choose your testing lab as a partner? What are the criteria we need to, because a lot of labs are floating around. So are there any quick parameters you can tell us how to choose your lab?
Yeah, it's very important as microbiome field is emerging, and you have to look into the research credibility and the testing capacity. When I say that, it's largely about, because in the testing and when they're providing the data, whether it is the disease risk information, or whether they are providing the microbial diversity, or whether they are talking on the food to the probiotic recommendations. It depends not only on the collection process or the lab processes, but also it depends on the data analysis and the data acquisition. So it depends on the data sets that you have, your comparisons, and the machine learning algorithm that you're using, and the accuracy, the precision rates of.
So if I can interrupt you, so if the lab comes to me and says that I provide lab testing, tell me 2 questions I need to ask that lab to test the genuinity of that lab.
So you ask them if they have the credible research, what they are talking about in terms of the claims that they are making for the valid evidence, and also is there a clinical relevance that you can use for your clinic or your interventions with the patients.
But the actual testing mechanisms is just the same for everyone, basically.
Largely, yes, but the analysis varies. So
Right,
that is
sure.
very important to understand.
Good, thank you. So, Prof. What exactly happens in IBD in terms of microbial change? What are the good and bad bacteria which
I think in the lecture by Dr. Ramakrishnan, he's shown that actually there are obviously good and bad bacteria. So I think in IBD, we like to think there is a paucity of the good bacteria. So besides that, of course, there is also change in diversity. And in IBD patients, they find that the microbiome tends to be unstable. So in terms of the good bacteria, why are they so important? So of course, the good bacteria could be the Bifido, the Bacteroides, the Firmicutes, and some Prevotellus. But the reality is the good and services that they provide are more important, meaning the short-chain fatty acids, or the making sure that there's not too much hydrogen sulfide that's produced, or the bile acids, how it is degraded from primary to secondary. The secondary bile acids are more beneficial, or the production of the good things, some metabolites, the small molecules. So those are the ones that are important. So bigger question, of course, then the changes. So really, to summarize, is like basically bacteria which are good, basically those with anti-inflammatory capacity. I think the next slide will show what I said. Yeah, and these are the ones. The diversity is important. The instability is. Those are the 2 points, and of course, the propensity of having a lot of bad bacteria. That's a problem.
Sure.
So we've gone through kind of a little bit of I call it good and services of the bacteria. And more important is what I forgot to talk about is I sent you the slide was about whether are they the effects, are they cause or effect. So I think there are now a lot of studies that are more persuasive to suggest that from twin studies of like inoculation of IBD microbiome in safe germ-free mice and all that, probably it's the cause more than effect. Yeah.
Sure, thank you. So we'll move that. And again, there's a wide variety of metabolome profiles which can be produced by, seen in IBD patients. So again, continuing the same topic, the changes in microbiome linked to inflammatory bowel disease, composition, function can be variable. So Charlie, so what are the indications to test for microbiome in IBD? So I see a patient with IBD, when do I actually, as a clinician, when do I ask for microbiome testing in my patients? What are the kind of clinical implications or applications?
Yeah, thanks, Kiran. The answer, I'm afraid, is never. I've literally never in 20 years requested a microbiome test. And I think it's going to be a wee while before I'm persuaded to do so.
Right.
Now, it's not that uncommon for patients to come in having had their microbiome tested privately.
Yep.
When I see a report from that, the first thing I look to do is to see if that company also did a calprotectin, which they often do, so that's useful. Quite often they do a QFIT, so if it's a patient with first presentation, that's also useful. And then it's nice to read through the report and show the patient that you're interested, and we'll then have a general chat about diet and lifestyle and anything. So I'm afraid that I don't think we have anywhere near sufficient evidence to support the use of microbiome testing in routine clinical practice at the moment. So,
So
that's my current opinion.
None of these would apply, basically.
So
Role in relative.
most healthy siblings will never develop IBD. And if there's any one test that I would do, it would be a fecal calprotectin test. And if they wanted the advice, then we would see the previous session on diet and environment, which was a very nice conversation. What about a relapse in a given patient? Well, this is super interesting, right? So in the PREDICT study I told you about before lunch, we have 2,500 metagenomes currently being analyzed at the Sanger Institute in Cambridge. That is going to tell us, I hope, whether or not there is any signature in the microbiome that is associated with and may predict disease flare. And we will then be able to control for the background inflammatory state through calprotectin and then look to see what happens over time. Will that translate into a diagnostic test in the clinic? I don't know. It might. If we find something, for sure we'll need to prospectively validate it to see if it works. It would be amazing to do similar things in South Asian population. If we could see similar signatures in an Indian microbiome as in a Scottish microbiome, despite radically different diets as we talked, and the environmental factors we talked before, that I think would be very compelling, but I don't know, it might be difficult. About 12 months ago, Curtis Huttenhauer, who's one of the world leading experts on microbiome in any field at all, let alone in IBD, published in Nature Medicine showing that they had found a microbiome signature that predicted 5-amino salicylic acid response. It was very compelling. They'd done beautiful studies in humans and in mouse to validate this. Sure. 3 months ago, Rins Veersma, who's been doing wonderful work on the microbiome in the Netherlands, did a massive replication experiment, entirely negative, published as a short letter in Gut because it was a negative study. But so I'm relatively cautious here at the moment, but I'm hugely optimistic in the long term.
Sure. Thank you, Charlie. So if you were to do study microbiome, IBD patients do have fluctuating flares and remissions. When would be the best time to study, if at all study, for either for research purpose or clinical purpose?
Probably in lots of people at longitudinal samples. So from research purposes, the most helpful thing is going to be to look at fixed time points and then in response to events. So in the UK, we're doing this IBD response study where we're studying the microbiome before and after initiation of all advanced therapies, 1,500 people to look at response versus non-response. And then we're doing this IBD open study starting next year when we're going to do a really deep dive, state-of-the-art inception cohort, 1,000 patients with IBD, and we're going to measure this every 3 months for the first 2 years. So those kind of studies with shotgun metagenomics, I think, will help us.
Thank you.
Probably the inflammation has a massive impact on the signal that you see, but the bioinformatics and artificial intelligence are really helping us unpick a lot of the noise in the data, but we need large sample sizes and very well phenotyped patients.
Thank you. So we'll miss that. You already mentioned the take-home study, and so microbiome therapeutics. When do you? It's an open question to all the panelists. What is the role of prebiotics, probiotics, symbiotics, and postbiotics in patients with microbiome therapeutics in IBD? So any comment, one comment from each of the panels?
I'll give you a very brief answer. It's very similar to my last answer. It's basically never. I don't mind patients taking probiotics, but I don't actively start them. I advise them that they might save money if they spend it on something else. I advise them to improve their microbiome through diet, and FMT is still very much in the research domain, and let's see.
Okay. Prebiotics, probiotics, Deepak, anywhere? Of late, there's a big meta-analysis on baseless coagulants in IBS patients. Anything of that sort you come across in IBD?
I think I have a very similar conversation to Charlie that, if you have the money, spend on probiotics. Most of the stuff is, snake oil. and they are studying probiotics, particular combinations in a trial, let's say in pouch patients at the moment, chronic pouchitis. But again, that's not something you buy off the shelf. It's like synthesized. I mean, otherwise, I would say Rebiota is there for C. diff. I mean, the setting of IBD also you can do that, but I wouldn't do FMT for an IBD flare. I think that's purely in the research space. The only other comment I was going to make for microbiome therapeutics is that there's also some data emerging on the microbiome with the fungus. We were also one of the sites that found one of these particular agents, the Debromyces hansenii. There's actually a study out of Cedars-Sinai, LA, where they're studying antifungals and how that might impact IBD. But again,
Sure.
all purely in the research space.
Okay, we'll ask the panelists next questions actually because of the time constraint. So you answered part of this, Deepak, already. So the Rebiota is a commercially available FMT preparation, and that's available in US now. So they'll skip that. So Dr. V, is microbiome testing available widely in Singapore, and companies doing?
Well, it is available in Singapore. It's part of the National University startup. We don't advocate it routinely as physicians or clinicians, but the patients find their way there, and they go and get their microbiome tested, and then they bring it to us, and then we have to try to unravel the results. So the idea is, if they find there is something that's missing, that is anti-inflammatory, perhaps is it useful to replenish that? So we know a little bit, but we don't know enough, and certainly we don't know a lot.
Thank you. So Charlie, is it available in NHS now, the microbiome testing? Certainly it was not there when I was there.
No.
No. So it's both for probably Dr. Ramakrishna and Dr. Uma Devi, madam. Any companies offering microbiome testing in India? Both of you can answer. I mean, either of you. In this Indian scenario.
Yes, dysbiosis test is available. It is they will send the kit to your home. We can send the stool sample and they give the report. But it is very. They give only 16 species or something. They charge around 23,000.
Okay.
Yes, so there are things available between 10,000 to 30,000.
3 more minutes, yeah.
Not sure that it's very useful.
Right. Okay, sure. So FMT in India, madam, so what is the current status? Dr. Ajit Sood is here? No, he's not here. So
FMT is FMT done in 2014 for first ulcerative colitis patient by Dr. Seth group, and he himself he did the follow-up of 5 years. He published this recently, with 7 states from India and 3 countries with a success rate of 60%. Okay. And the important thing is they prepared the stool at home. There are no adverse effects, but there are several unpublished single case reports all over the India from AIIMS, Pune, and Dr. Ajit Sood has a very significant experience in FMT also.
Sure. Okay, so in
but
US,
they put this regime of induction and maintenance and rescue FMT, and what they found was important thing to note is they don't find any significant adverse effects over a 109 FMT procedures. Okay. That is one ray of hope.
So now that we have, panelists from across the globe, just might have taken the answer. So Charlie, you practice FMT in UK, or what is the status now?
So we're doing it for refractory C. diff infection. Yeah. It's got a very clear role in there. There you've got an acute permutation in the microbiome that needs fixing. This seems to be a very effective strategy for it. For IBD patients, so there was a clinical trial effort going on in the UK at the moment, previously. I don't think there's anything going on at the moment. So I'm not sure I can really comment. It'd be nice to see this taken forwards, but let's wait for more data.
Sure. Deepak, US, how often you come across FMT being practiced? Is it only for recurrent C. diff or any other indications approved for?
just for recurrent C. diff? Because I think again the trial data perhaps appears stronger on the UC side more so than for Crohn's for sure. I think this also some of these trials have varied based on the donor characteristics. So I think that's what more research is needed on what those donor characteristics are, and if you can actually replicate some of that and modulate without actually doing like a wholesale FMT like
Sure.
you do for C. diff.
So thank you. I think we'll have to close this session because of lack of time. So the conclusion is the microbiome is a very hot topic nowadays, and especially in IBD. Huge potential for research, especially younger generation who want to take up some research fellowships or research positions. Widely available, but selection criteria is very important. Pre and probiotics are promising. Bacillus coagulans is recently proven to be very effective in IBS, but efficacy in IBD need to be studied. FMT in India is in infancy and needs a lot of guidelines and regulations before being commercially available. So with that, we'll close the session. Thanks all the panelists for an excellent contribution. Thank you very much.
It was a excellent panel discussion on microbiomes in IBD, and a very comprehensive one and insightful one. So now I request a panelist, a chairperson, to give memento to presenter and vice versa. Dr. Nikita. Dr. Umadevi. Dr. Deepak.
Okay, so that brings us to the second last session of the day. This session is on monitoring, and I take this opportunity to call the chairpersons onto the dais, onto the chairperson's dais, Dr. Vidyasagar Rabbani, Dr. Pradev, Dr. Sridhar Nutaki, Dr. Ejaz Habib, Dr. Vamshidhar Reddy, and Dr. R. Vidyasagar. You can start.
Good evening, everybody. In this session, already we covered one topic, that is therapeutic drug monitoring. So there are two more topics we have to cover. The first topic is monitoring a patient in remission. This is covered by Dr. Shiva Prasad. Dr. Shiva is popularly known as Shiva from Vizag. He is a senior gastroenterologist, and his areas of interest is in IBS, IBD, GERD, and liver cirrhosis. He holds a professional membership in the following societies, that is IHG, INSL, and Society of Gastroenterology Endoscopy. Dr. Shiva, please.
Thank you. First, I'd like to congratulate Kiran and the team for an excellent and very informative session that we've had all through the day. The topic that I'll be speaking on is on monitoring of patients and IBD in remission. And as you can well realize, many of these have been touched upon in previous talks and will also be touched upon otherwise. And I'm just kind of putting it together to see what we do in clinical practice when we monitor patients. So over the course of time, previously we just had clinical remission only, we just go by symptoms, and later biomarker remission, endoscopic remission, and possibly histological, and now even for Crohn's disease, transmural remission is also now being considered as one of the targets of therapy. The STRIDE consensus, as you well know, defines these defines these the targets that we have to reach. We have short-term targets, which are essentially symptomatic response, and then we have the intermediate targets where the CRP and calprotectin and others the normalization is achieved. And over the long term, we also have look at trying to achieve endoscopic healing and normalized quality of life, absence of disability. And in STRIDE itself, they said consider, but not exactly formal, in Crohn's disease for transmural healing, and ulcerative colitis, you look at histological healing, which I'll be addressing also. So in the time of active disease and flare, you have obviously certain protocols to follow, but once the patient is in clinical remission, the recommendations are for every 6 to 12 months or 3 months in the CALM protocol. These recommendations are entirely, I think, they're variable. They will be based upon the clinical situation and the patient's compliance and availability for follow-up. So in both UC and CD, you're looking at intervals between 3 to 6 months for patients who are in stable remission. Briefly, I will just like to touch upon some points which are different between UC and CD in practical terms. If you look at the correlation of clinical symptoms and even digital rectal findings on a digital rectal examination with remission, you probably will find it better correlating in patients with ulcerative colitis and in Crohn's disease only if there is perineal involvement. Otherwise, the correlation of symptoms and remission is not as well established in Crohn's as it would be in UC. Serum CRP is not usually useful in UC, where it would be useful in Crohn's. A fecal calprotectin correlates better with relapse in UC. And mucosal healing is usually enough to say there is complete remission in UC, but usually you just can't look at mucosal healing. For Crohn's, you would be looking at, as you know, it's a transmural disease. We're looking at even imaging and other parameters to assess complete remission. So in the benefit of tight monitoring and targets is also more seen in CD, where the primary goal is to prevent complications. Patients with UC who have mild symptoms and very minimal activity can probably get on without having escalation of therapy. But you're looking at tight monitoring and achieving some positive benefit in targets, it is there in CD. So first, of course, obviously is the clinical monitoring, and we have indices like the Harvey-Bradshaw Index and the partial Mayo score. But you should realize that these are just ultimately a full-fledged clinical consultation in your clinic. What is the well-being? What is the pain, loose stools, abdominal mass, complications? These are the components of the Harvey-Bradshaw Index, and they would be forming part of your normal clinic consultation and examination. Similarly, for the Mayo score, stool frequency, the presence of rectal bleeding, and the term that I love the most, physician's global assessment. It just means how do you think the patient is looking and feeling? That's it. That, I think, is the most important parameter for clinical monitoring. These scores are required when your patients are part of a study or you're reporting to a third party. So even the other term that you would see in patients monitoring is patient-related outcomes. That is, applies to a situation where the patient, the clinician is not able to make the assessment, but you're inviting the patient to make their own assessment on basis of the change in symptoms and other. These are just, again, where the patient is reporting his symptoms, and then you're trying to quantify and standardize them. So ultimately, it again comes down to a thorough clinical examination, history, and assessment. Calprotectin, as you know, has really changed the way we have monitored IBD, especially in the last 5 years. Briefly about calprotectin, it's inexpensive, remains stable at room temperature in stool for at least 3 days. I think this is good to remember. And even after 7 days, there's only about a 30% loss of activity. And it correlates with the presence of neutrophils in the lumen, and we use it to obviously distinguish non-inflammatory and inflammatory disease, and it obviously does not establish a diagnosis of IBD, only establishes inflammation. Overall, in patients with isolated small bowel Crohn's disease, you would expect the calprotectin to be lower than what it would be expected in terms of disease activity. We have to remember there are many other situations where calprotectin is raised. Even in colorectal malignancies, due to local inflammatory response, you can have an elevation of calprotectin, and other inflammatory diseases like necrotizing enterocolitis, GVH. Drugs also, even NSAIDs and enteropathy is also associated with the raised calprotectin. So, obviously viral infections, and there are reports of even PPIs, steroids, and others which may induce the gene expression for calprotectin and raise it, if not too high, at least into the gray zone. And GI bleeding is also associated with moderate elevated CP levels. These are things to keep in mind. So when assessing, once you have a patient with IBD, and if the patient is being monitored with the quantitative fecal calprotectin, there are ranges in which you have to make decisions. So the easy ranges are less than 50, which rules out IBD, and more than 250, which will really require you to make some proactive measurement, intervention to decide whether this is an IBD flare. The question comes between 150 and 250. And though some guidelines say that less than 150 you can consider as IBD in remission, and 150 to 250 is a gray zone, I would think that you can have two gray zones, a light gray zone and a dark gray zone. 50 to 150 I would recommend we still keep as a light gray zone. Maybe you would require a repetition of the calprotectin in another few months, but it would not mean that you can totally exclude the need for any change in management. The 150 to 250 would probably be the dark gray zone, and there is a risk of flare, and there you would either repeat or you would go in for, based on symptoms and other factors, you might go in for endoscopy and imaging. In UK, as calprotectin was adopted in the practice, you can see as with over time, as the use of calprotectin went up, the need for sigmoidoscopies, endoscopies has come down. So this is a clear correlation that as calprotectin is adopted into practice, you will be relying less and less on endoscopies to make clinical decisions. The question comes is, can you use calprotectin as a target by itself? As of now, the STRIDE recommendations do not use calprotectin as a target by itself, whatever be the level. It's only as a guide to say that the patient needs further endoscopy or imaging. But in the CALM study, there was a group, patients where treatment was guided by CDAI, CARP, and FC for fecal calprotectin. And they showed that by just using these activity indices, CRP and FC, you could achieve superior endoscopic and deep remission and a lower rate of CD-related hospitalizations. So it is likely that biomarker calprotectin level alone can become a target by itself, but as of today, again, that is something that you have to make a clinical decision for. There is a trial of UC in ulcerative colitis where just using FC as a greater than 300 became a treatment trigger, change treatment based on calprotectin. And a CD trial also using fecal calprotectin to decide anti-TNF intensification. So with time, as our experience gets better, we are certainly going to use calprotectin more and more as a primary target itself, rather than just as a trigger for further investigation. CRP, nothing much to say. We know that it is the normalization of CRP is an important target, and the presence of an elevated CRP would still mean that further disease needs to be looked for. The question comes with endoscopic healing. It would seem to be simple that yes, just achieving mucosal healing is associated with improving outcomes, and I think that would be fairly straightforward. If the patient has achieved endoscopic healing, he is obviously in a better position than those who have not, and it is associated with better outcomes, hospitalizations, RAPs, etc. The problem again is we don't have a uniform definition of optimal endoscopic target. What is the target that you would use to say that this patient has used endoscopic healing? This is not uniform across studies. So some studies have just said the resolution of ulcers or the resolution of ulcers and friability, but it does not allow for the partial, just patients having residual mild inflammation, but ulcers and friability have gone. How do you categorize these patients? That again remains a slightly gray zone. So it is required that today we should have a more uniform endoscopic score to become a target in both of Crohn's disease and UCI. And recently, the International Organization for IBD has given a recommendation that a UCI score of 0 should be your definition of endoscopic remission, which seems fairly logical. The question comes again with histological healing. Again, it would be oxymoron not to say that, okay, somebody who's achieved histological healing is going to do better than somebody who has not. But the question again remains, what is the real benefit in terms of long-term remission, a reduced risk of surgery, and CRC? And scoring systems have been developed for assessment, but are almost only used in UC, but only in the context of trials. There's again no consensus. You do have inter-observer variability as far as pathologists are concerned. And the number needed to treat to achieve improved outcomes is likely to be very high if you're looking at mucosal healing as histological healing as a target. So that we have to keep in mind. It sounds good to say that histological healing is a good goal to have, but in practical terms, it should not be applied as of now. And we also know that current available therapies have limited effectiveness if you want to achieve the ideal target of histological healing. Even if everything else is perfect, you will not be able to achieve that in a large number of patients who are otherwise in remission. So histological healing is still on the shelf. It's not yet as part of our day-to-day clinical monitoring. There is a whole session on intestinal ultrasound, and as I mentioned, transmural healing, transmural remission for Crohn's is being looked at, and probably the simplest way to assess transmural remission is on intestinal ultrasound. Though I'm not a practitioner, I'm really impressed by the single fact that a single measurement of bowel wall thickness, less than 3 or more than 3, is able to classify patients in Crohn's disease as in remission or not. I think that's a very, very attractive measure, which for people, and every IBD clinic should have somebody who's doing intestinal ultrasound, and just rely on, if the single parameter shows that it is as good as showing transmural remission, I think it's a great step forward. So in our monitoring algorithm, again, repeat what I just said, they have depending on, once a treatment patient is in remission, you do proactive monitoring, you see how use the clinical symptoms and other parameters, see whether the targets are met, and if they are if they appear the symptom targets are not met, but the biomarker and endoscopic targets are met, you may look for other causes of IBD, other causes other than IBD, but if they are not met, you can change therapy. And if they are, again, if everything is fine, you continue the current therapy and continue proactive monitoring. So this is what we would do in practice. There is a downside to target-based treatment also. There is in some systems like NHS, or where they're delivering the patient care as a whole, there is going to be an overall increase in doctor-patient visits, laboratory testings, endoscopies, everything could become burdensome, and this could affect patient uptake and treat to target strategies especially where community gastroenterology service is being provided. The other problem also with targets is what happens if you have a patient who's in complete clinical remission. I had a patient who's a young lady with Crohn's. She is very stable on azathioprine and adalimumab. Came in after 6 months or maybe even a year. She was just on self-treatment, perfectly normal, everything fine, all parameters fine. But the CRP was slightly elevated. I said, get a calprotectin done. The calprotectin came pretty high, 700 or something. Now, what do I tell her? She is actually going to shift to Hyderabad to take up a job, but now do I say, and she's perfectly fine, not a single symptom. So I just kick the can down the road and say, okay, let's repeat these after 3 months. So though you know that this calprotectin is high, to motivate such a patient to say, no, now you need imaging, now you need to do further assessment, and now you need to escalate your therapy beyond even what you're getting, is not easy for a patient to take, especially when they're doing well. So this discrepancy, we still don't know how much and where to apply. But there has been talks of, Dr. Dev Desai had mentioned about azathioprine optimization. I was really glad to know that in Hinduja they're doing those TGN and 6-MMP parameters monitoring regularly. It is unfortunately not available widely even in reference labs, because I was told that the reagents that are used for 6-TGN monitor, 6-TGN and 6-MMP assessment, those reagents are under some kind of patent by a US company, which is not easily available. but obviously Hinduja is able to do it, and I think more and more centers should be able to do these two parameters, as Dr. Desai had shown how useful it is in patients on azathioprine. I will not go into this. So in the when those are not available, what are the surrogates we have for azathioprine optimization? Kiran had mentioned in the morning, MCV itself is a potential surrogate marker. If it is MCV by itself is elevated, 6-TGN is unlikely to be subtherapeutic, and a delta MCV of greater than 7 is associated with good clinical outcomes occurred in CD and UC, and independently of the TNF. And in my clinical practice, what I found, an observation that I would say I feel is that if the patient on azathioprine is maintaining a count of 3,000 to 5,000, that is a good rule of thumb that this dose is optimal and they need not be either escalated or reduced. Monitoring post-op CD, we have endoscopic evaluation at 6 months. A Rutgers score will tell you whether to trigger initiation of therapy or escalation of existing therapy. And fecal calprotectin also has a good accuracy at predicting an anastomotic response. So after any surgical resection for Crohn's, doing a fecal calprotectin and an endoscopic evaluation would tell you what they need. In the morning, there was a reference to whether major atherosclerotic cardiovascular events like stroke and CAD are associated with IBD. There have been population studies which show that the pro-inflammatory state of IBD is associated with a higher risk of stroke and a higher risk of cardiovascular disease. So it should be kept in mind, and appropriate monitoring should not be neglected for those who need it. Remote monitoring via POC, point of care testing, telehealth, and teleconsultations are easy to apply to your patient's practice. You can always invite them to just send their CRP and calprotectin reports and just have a quick video call as to whether they're doing well. That may save an entire clinic visit. Using apps and wearables are being tried. Apps are useful only if data is inputted by the patient. There are apps which the patient has to keep entering the data as to how many stools he's having, what symptoms he has and all that, and then the app will inform the doctor. This is not really practical because the patient is not motivated to input the data daily. But parameters like, just a minute. Parameters, just simple parameters like sleep and physical activity daily itself is also a good way of remote monitoring. Good sleep, no, then a patient is in remission. Physical activity normal, patient is in remission. Then you have other AI uses of, in this one, just the appearance of stool could tell the what is the Mayo score, and then passive touchless monitoring, etc. Sorry. So in conclusion, okay, can I get back that slide? Oops. Yeah, it's okay, that's fine. So in conclusion, I'd like to say that yes, you have to proactive monitoring is an important component of IBD care. Clinical assessment, proper clinical assessment with CRP and calprotectin testing takes care of a large proportion of what we need to monitor our IBD patients. Endoscopic and imaging assessment as of now still required to make any therapeutic changes, and remote and AI-assisted monitoring are likely to be helpful. Thank you.
Thank you, Dr. Shiva. Any questions?
Yes.
Siva, thank you. What fantastic overview of the subject. One small question I have. Persistently raised fecal calprotectin over a period of 2 weeks, repeatedly, continuously, and the patient is symptomatic. Do you just based on those the clinical symptoms, do you step up the therapy, or you want to plan for a colonoscopy to assess the disease activity and then go ahead?
Yeah, this is exactly the point of saying, as of now, can you use calprotectin as a target by itself to decide therapeutic changes? Not to guide you. Yes, they use it to guide you, but there is a little, I think it will come into the picture. So there will be a level of calprotectin at which you can say, yes, I will step up therapy. But it is not easy. I would say as of today, you still need to do an endoscopy or imaging, as the case may be, to establish that this patient needs an escalation of therapy. Because you have to realize that escalation of therapy can be quite significant. Now you can imagine this patient that I mentioned, she's already taking adalimumab and azathioprine, and now if I say, no, you need escalation of therapy, it is going to be life disruptive. She has to start a new drug, new therapy, monitoring, etc. So we cannot rely on calprotectin alone. Again, if there are clear clinical symptoms associated with a RAIDS calprotectin, then I would agree that, again, our needle will shift towards making a therapeutic decision even without a procedure. So if a patient has known ulcerative colitis, now is come back with bloody diarrhea, and the calprotectin and the symptoms on the calprotectin are persisting for weeks, and a patient doesn't want a colonoscopy, you can say, yes, I'm justified.
Why I'm asking is that fecal calprotectin rise maybe because of the ulcerative colitis relapse or
so many other factors, yes.
Because of the other superimposed C. difficile infection.
Yes, I mentioned all the possibilities.
That
so
can
you have
also
to
cause
you have
the
to
rise.
monitor and see whether it's persistent. That's.
I happened to see a patient. Apart from master health checkup, they got a CRP done. The CRP was high. So
How high?
It was about 20 or so. So they brought the patient to me. I said nothing is required, but they forced me to do a colonoscopy. When we did the ileoscopy, there was ulcer. Biopsy proved to be Crohn's. And then subsequently, so this patient was being treated. Subsequently, they got the test for his sister. She also had a CRP elevation and she had ulcerative colitis. Both some sort of a asymptomatic type of presentations. I would like to ask you, Shiva, I think recently I came across one statement, serum calprotectin in inflammatory bowel disease. Could you comment on that?
Yes,
Is feasible?
Serum calprotectin is itself an inflammatory marker, but then it is non-specific. In fact, serum calprotectin has been used in SBP patients, to make a categorization of prognosis, etc. So it is a non-specific inflammatory marker in the blood, and it will be elevated in any systemic inflammatory disease, not necessarily IBD. So in IBD setting, really not going to be helped much by serum calprotectin, because you want to know what's a gut mucosa like, not whether there is any systemic inflammation. But serum calprotectin is a known inflammatory marker and has been tested in other inflammatory systemic conditions. Yes, there is. HSCRP differentiates HSCRP reflects an inflammatory state that is slightly above normal but not associated with systemic inflammation. It becomes a risk factor for atherosclerotic disease, etc. You'll see the HSCRP report. If they say it's more than 10, you consider it as equivalent to elevated normal CRP and look accordingly for infections and other factors. So in that range where HSCRP is more than what is the target and less than 10 or something, that is a range in which that patient has a risk of atherosclerotic cardiovascular disease and other atherosclerosis rather than being a reflection of systemic inflammation.
Thank you, Dr. Shiva.
Yeah, thank you.
So we would like to invest. I would like to call the next speaker, Dr. Shaji Sebastian.
Thank you, Chairman. Thanks to Kiran and the Yashoda team for the invite to this fabulous meeting, and the energy this morning and the discussions is really humbling, and I'm sure this collaboration across the world will continue. So Kiran asked me to talk about whether profile trial, which you heard few times this morning, which we conducted, showed results which suggested that it is time to stop risk profiling Crohn's disease patients. That's a bit tough question to say that it should be stopped, because I'm sure you heard that it was a negative study from the biomarker. But that means that pretty much a lot of my collaborators who work on precision medicine will actually start thinking that precision medicine is slowly becoming obsolete. That clearly is not the case. So I'm going to ask the question in a different way to see whether the biomarkers, current or future, is going to add anything more than risk stratification, what we are able to do at this point of time. These are my disclosures. None of them are relevant to this talk, but I do have a couple of disclosures which are relevant to this talk, which are my cognitive conflicts of interest. For those of you who don't know this term, it's a concept where what I believe to be true, I always want it to be true, and areas which are more receptive to evidence, which are in support of those my belief, and less receptive to evidence that contradicts. So we all have, we heard this morning, we all have our own biases when we are managing a disease such as IBD. So my cognitive conflicts of interest relating to this talk is that I still believe having somebody be involved in the first RCTs of anti-TNF as a registrar, anti-TNF still remain the king of the hill in routine practice in IBD. And I don't think new is always better, and real-world evidence in diverse populations are needed. We heard talks relating to that this morning, what is relevant in the Indian context, and the guidelines from organizations, including my organization, ECHO, may not be all applicable to here. And finally, we heard about the treat to target and histological and transmural healing. We also have to be humble enough to say that perfection can be enemy of good. So having said that, we know that Crohn's disease is a progressive disease. Yes, this paper from Jack Cohn is way back in 2002, so perhaps the biologics were not there. But what that showed was that over a 10 to 20 year period, vast majority of patients end up having complicated disease. So what is really the point of risk profiling? That may be what we will ask as a question. Can we really predict the future looking forward from today when we diagnose a patient going forward to the next 20 years? Or as Jack Cohn showed, are we just describing the past? Before we answer that, we need to first of all define what we mean by a complicated outcome in IBD. A complicated outcome for one clinician may be different to another. Complicated outcome for a patient may be different from the clinician. But in general sense, in my view, these are the complicated outcomes in IBD. I've added ulcerative colitis on the right as well, but mainly we will focus on Crohn's disease. Clearly, a disease progression, particularly disease change in behavior, to me is a complicated outcome in IBD. Anything which causes disabling outcomes for patients, so here keeping the patient right at the center of our decision making is also a complicated outcome. Need for surgery or a repeat surgery, need for hospitalization for all sorts of reasons, least of all economic reasons, is a complicated outcome. From a patient perspective, although stoma should never be considered as failure of treatment, but for many patients, that is actually a complicated outcome, at least at the outset. And finally, need for parenteral nutrition. So if you go through some of those, this is what we know, what we have been practicing for the last 10, 15 years or so. When a patient comes to my clinic as seeing a new patient, I look at what are the factors which I can look at to predict what their disease behavior. This nice paper from Joanna Torres indicated younger age at diagnosis, current smokers, those with ileal disease, we heard that this morning, those who have severe endoscopic lesions, and those exposed to steroids in first year. We'll come back to that later, and the presence of EIM. So if you have these patients, you almost are going to be predicting future stricturing or penetrating disease. Similarly, the need for surgery or a repeat surgery, those who have isolated small bowel disease, those who have penetrating or stricturing disease right at the outset, those who develop perianal disease, and we will have some more discussions about that tomorrow. And finally, the extensive and deep ulcers in the colon. I'm not fully convinced that the serological markers or indeed genetic polymorphism, apart from the L1 phenotype, really predicts the need for surgery. Clearly, the risk factors associated with disease progression and surgery also increases the hospitalization rates. But if you take two specific characteristics, it is the penetrating and stricturing phenotype and perianal disease who are the ones who end up mostly in hospitals and use healthcare resources. Permanent stoma, many patients who have complex perianal fistula and perianal sepsis, even if they get temporary stoma, they very rarely are they ever reversed, and those who have colonic disease and multiple previous surgeries. So reversal of a temporary stoma in perianal fistula is very low, and that is something which we need to be humble enough to admit upfront when we are counseling patients. But one thing which I have particular interest is intestinal failure. We think about our patients over the next year in terms of remission and relapse rates, or maybe even 2 years, maybe even 3 years. But in the lifetime of a 20-year-old patient, we need to be projecting up to when they are in their 40s and 50s, well after we are all probably retired, whether they will end up in intestinal failure. So we do not have consistent data which is available to predict intestinal failure in CD. But intuitively, you will think about younger age and multiple surgeries. So once we know that these are the predictors of a complicated outcome as per our definition, does early treatment work? This slide has been shown by Charlie earlier from Shomron. This is individual patient level meta-analysis of all the licensing trials. And it is very clear that early treatment in Crohn's disease, but not in UC, results in higher remission following induction. So this is just after induction. But what happens at 1 year? This is analysis of patients who had early initiation of treatment in the CALM study, which you would have heard. 122 of them had early initiation with anti-TNF biologics. And it was very clear the reason why they had prevention of progression from that early stage of Crohn's disease, coming back to what I started about the risk of progression, was mucosal healing. And you can see from the Kaplan-Meier curve on the right that those who achieved endoscopic mucosal healing had clear improvement. Then what can give you high rates of healing? We know from this old study, which used both infliximab and azathioprine, you can achieve mucosal healing up to 43% of cases with combination therapy. We also know that top-down therapy was better than step-up, admittably only for brief period of treatment a while ago, but we still were not practicing. So this is why the biomarker-based stratification trial was thought of, to find out who else is at risk in the future. Can we use biomarkers to predict complicated disease? Or, as I mentioned, is our current clinical predictors good enough? And if so, why we haven't changed practice? So this was the biomarker which was developed in the UK, which was a CD8 positive T cell, those who have, which had a higher risk of relapse and lower risk of relapse based upon T cell exhaustion. And both the discovery cohort as well as the validation cohort, although in small numbers, seems to have clear distinction between these two subgroups in relation to risk of recurrent flares. But that was the only outcome analyzed, which was the risk of recurrent flares. And if you look at the graph, it seems to be a good biomarker. So we went ahead to test this biomarker as a prognostic biomarker to guide management in newly diagnosed Crohn's disease patients. And at the same time, also wanted to answer the question, what is the optimal treatment strategy for newly diagnosed patients? I won't go through the study outline in detail, but one thing I want to encourage you to think is think about doing multi-center, collaborative, investigator-initiated studies. Profile was done during the COVID pandemic period, recruited 400 patients from 30 sites across UK, over a 18-month period. So it can be done, and such studies needs to be done in India. But essentially, patients who are at diagnosis who had evidence of active disease based on the inclusion criteria were randomized to top-down or accelerated step-up treatment based upon the biomarker, and then primary endpoint at week 88, which was week 48, which was sustained steroid-free and surgery-free remission. This was the patient population. The one thing which I want you to take from this is on the right-hand side. Time from diagnosis to enrollment was mean of 28 days. And the median time to put the needle in to start the treatment was 11 days. I know this thing happened, treatment, diagnosis, once the patient reaches the hospital, diagnosis and treatment in India is rapid in most centers. So somewhat profile scenario can happen irrespective of what treatment is used in India. What it showed on the left was remarkable. I don't think you would have seen any study which has a delta of 63% when you compared two strategies. So there was 63% reduction in treatment effect with the top-down and step-up. But what was not different was there was no difference between the IBD high or low. That means the biomarker did not predict the risk of progression. So I think based upon that, that was the end of the road for biomarker. But it gave us lots of additional data. The time to first flare, which has got significant economic as well as resource implications, was lower in the top-down group. Time to second flare was lower in the top-down group, as well as significant difference in relation to endoscopic outcomes at week 48. Importantly, this impressive results in relation to top-down treatment and early top-down treatment was not associated with increase in adverse events. If any, the step-up group had more adverse events, both overall adverse events as well as serious adverse events. And if you look at the need for abdominal surgery, only one patient in the top-down group, and that too for gallstone ileus, underwent surgery, while all the 10 patients were all in the step-up group, mostly due to penetrating or stricturing disease. So there is clear conclusion from profile, which is early, that is very early treatment in Crohn's disease is imperative. Biomarker risk profiling, at least the one which we tested, is not really beneficial. There are a number of remaining questions post-profile. Some of these I think can and should be addressed in the Indian setting. How do we identify the low-risk patients, including those who have mild endoscopic disease? Will other biologics, we heard Rubai earlier talking about TOFA in UC, but in Crohn's disease, will other biologics or small molecules started early will have the same impact? Do we need to develop other biomarkers, or our clinical predictors, as I showed you earlier, is enough? In my opinion, the clinical predictors are giving us sufficient clue to start on top-down treatment earlier. We do need to know long-term impact of early top-down treatment, and obviously we will be following the profile cohort, but similar real-world cohorts from places like India is necessary. And importantly, whether profile results are applicable in diverse populations, because I am aware that there is this tuberculosis conundrum as an elephant in the room. But I am told that you can have tuberculosis test done fairly rapidly once you diagnose with Crohn's disease in India. So perhaps that may not be a reason not to consider top-down, but I do agree about the cost. But let's think about that one more time, about the cost. What is the cost of uncontrolled disease? What is the cost of multiple visits to doctors, multiple treatment changes, perhaps admissions? What are the costs of their time away from work and from their family? Should we really do a proper health economic analysis to convince policymakers and convince the funders that the cost what is projected for drug is somewhat counterbalanced by other indirect costs. In addition, I think we need to work with pharma more to make sure that there are more biosimilars available. And I was surprised to hear some of the biosimilars here cost more than the originator drug. That clearly is not in the UK. Biosimilar adalimumab is cheaper than mesalazine now. So with competition, perhaps the cost factor will come down as well. So I'll summarize and say we need to start thinking about this concept of time to needle in Crohn's disease with very early effective treatment, and that is not based on steroids or mesalazine, and I would argue perhaps not also based on monotherapy with thiopurines. So advanced therapies early in appropriate patients, and then try and see profile results, whether they can be put into daily practice in the Indian setting. I do think that there is already early diagnosis happening in India. There is early assessment in India. What you need to think about is early treatment to avoid unnecessary delays, and then study and properly follow up these patients to look at the impact of long-term impact as well as impact of withdrawal in this cohort of patients. So I'll stop there and happy to take any questions.
Thank you, sir. That was an enlightening and very crisp talk about the profile trial and its clinical utility. Now, any questions from the floor? We welcome any questions or comments from the floor.
I would just have a query about the design of the profile trial. At the time of enrollment, if you have decided that the patients need maintenance therapy after inducing remission with steroids, and the group which received infliximab and azathioprine received the maintenance therapy, why didn't you give the maintenance therapy with, say, azathioprine alone or infliximab alone in the control group? So if you say that the patients did not warrant maintenance therapy because of their clinical picture, duration of symptoms, etc., then why didn't you wait for the first relapse to then decide that the patient would now need some form of maintenance therapy, and I will decide whether infliximab, azathioprine is better than azathioprine alone? Because what I've seen is, what in the study, at the time of the first enrollment, you stop the steroid. As the steroids are tapered, you put the patients on infliximab plus azathioprine in the one group, and the other group is just observation. Wait and see, let them relapse, then I will step up to immunomodulator and then step up to infliximab. So you're building a bias in this control group by that delay. Is that, am I missing something here?
No, you're absolutely right. The patients were waiting for their second flare. But in that control group, in the group which was treated with a step-up algorithm, the median time to starting the second treatment was 23 days. So it didn't really make a difference in relation to starting azathioprine. I would agree with you, if you are starting someone on steroids with Crohn's disease, conventional wisdom will tell you that you start on thiopurines along with corticosteroids. While you come down, the other thing takes over. That would have made powering this study almost impossible. Okay. So we need to remember, this is a 4-arm study. You got the biomarker stratification as well. So that's why it was designed in that sense, but it did not differ in terms of outcomes.
Sir, one of the flaws of the study design was that they never mentioned about the delay in the diagnosis. They all enrolled newly diagnosed cases, but what was the duration from the first symptom to the diagnosis? I think they are quite about that.
No, you are absolutely right that there is, in the UK, there is clear delays. It's getting better perhaps, but there are clear delays in first presentation with symptoms to particularly when profile was done. We did not routinely use calprotectin-based screening in primary care. Okay, so there is potential that there is variability from time to onset of symptoms to this thing. That is one part of the pathway which we are really focused now in the UK, not outside of this trial setting. So it's a valid point to say it is possible that there is variations in the two groups with regard to time to onset of symptoms to inclusion. it's an important point to consider, but it's also important from a clinical point of view. As I showed on my last slide, the three things: early diagnosis, early decision making, and early treatment. And that's what we owe to our patients, because I do really think that if you repeat somewhat like SPARE study in those early treated patients, I would suspect there will be a group of patients whom we will be able to withdraw treatment. Okay, so you are clearing the disease and then withdraw treatment. So these are questions which are still live profile, but it has stimulated this concept that we treat early, almost like angioplasty in coronary artery disease, needle, door to needle time. So this should be diagnosis to needle time.
Thank you, Dr. Sebastian.
Thank you, thank you. Thank you for the attention.
Yeah. Thank you very much. Yes. I request the chairpersons to kindly come onto the dais, and Dr. Shiva Prasad, the speaker for this session, to receive the memento. That's great. I request Dr. Shaji to kindly hand over to the chairpersons. Thank you very much. With this, we come to the end of this session. I request Dr. Anil to come over and take over the next session. Thank you. Good evening, everyone. We are into the last session of the day. This is an interesting topic, interventional IBD. So the role of endoscopy is increasing in the last few years to treat complications of IBD. Endoscopy clearly offers advantage compared to surgery, as it is patient is recovery is faster with endoscopy. So to discuss on this, we are having panel discussion today. I invite Dr. Santosh Inaganti to proceed for the panel discussion. The panelists for this interventional IBD panel discussion are Dr. Rakesh Kumar Adi, Dr. Chalapati Rao, Dr. Srikant Tapasani, Dr. Pardapal, Dr. Pavan Addala, and Dr. Sharat Putta. Over to Dr. Santosh.
So అది వాళ్ళకి ఇవ్వండి. Point. This works. ఇది వర్కౌట్ అవుతుంది. You need this one. That's a marker. No, that's double click కదా. Thank you for patiently waiting for this evening session. So far we have learned a lot about IBD theory, and we would like to change slightly, focus on to the intervention. So
we have a series of small case histories, and our panel members who are all experienced endoscopists will enlighten us with their approaches. So we'll start off. I would like to introduce Chalapati Rao from Vizag. Partha is next door to us here in Hyderabad. Rakesh from Secunderabad, Yashoda. Sharath unfortunately could not make it. He had some last minute issues, but he contributed to the slides. And welcome Pawan, our surgical member in the team. With the endoscopic intervention, we must have a surgeon in the house, okay? So what are we going to touch upon? Reaching the lesion, diagnostic tools to get to the bowel problem, video capsule enteroscopy and its benefits. Colonic strictures we touch upon, but focus more on small bowel strictures. Lesions in the IBD patients on long-term surveillance. Perianal problem and its complications, and enteric fistula, and if there is a time, we will touch upon small bowel bleeds. So we'll start off with one young, first case with a young adult 25-year-old female patient who had altered bowel habits for a few months. She also had mild intermittent right iliac fossa pain, no abdominal distension. She's anemic, CRP is high, stool routine is normal. So we excluded the infection. She got long-term symptoms. She's straightforward, suspected IBD. So what next? So imaging or colonoscopy first. In the audience, I would like to take a poll on this is a suspected small bowel type of diarrhea and IBD, and what would be the choice of investigation? Imaging? Few hands for imaging. Colonoscopy? Rest all? Okay. There are advantages and disadvantages. Chalapati, can you just I would like to take your point on what are the advantages, disadvantages, taking into the age of the patient into consideration. Suppose if you have two age groups.
Right. So this is a very common scenario. I think I would go for colonoscopy first, at least because given the situation, first to exclude at least the terminal ileal disease, we need to do that. Of course, the issues of bowel preparation, if there is any kind of obstructive symptoms, obviously bowel preparation can be challenging. Imaging, again, it is good, but not all follow the strict protocol of CT enterography or MR enterography. Given a choice, given the expertise, probably I would prefer MR enterography, but over both, I would prefer colonoscopy first with ileoscopy.
Okay, so being terminal ileal limited disease is a common form of small bowel problems, so probably colonoscopy is the first one rather than the imaging. Imaging would add any proximal strictures or diseases. How many would do markers? Hands up, audience poll. Only one. Okay, so because they are not going to contribute to the confirmation or exclusion of the diagnosis and the prevalence is low, I don't think they have any role in the diagnostic armamentarium of IBD. So next is the burning question. Is histology must for mid-small bowel classical IBD? I stress the point, classical IBD on CT enterography.
I think we should still chase for a biopsy because still there can be some lot of mimickers, especially like carcinoids like neuroendocrines or some kind of adenocarcinomas or lymphomas. We need to exclude this at least. So we need to approach it with enteroscopy and then go for a biopsy.
Suppose patient is a 10-year-old boy.
No. Still, it would be prudent to do it. Probably going for a minimalistic approach like laparoscopic biopsy would be still useful, I think.
Oh.
Yeah, not to forget tuberculosis. Obviously.
Sometimes in our practice, we have found that some of the patients are, while taking biopsy, we are surprised that to find malignancy in them. Yeah. So Crohn's disease with superadded malignancy. So biopsy is a must, I think. Sir.
But that would be rarity, isn't it?
Yeah,
that's a very rare, long-standing, already established case. Okay. So moving on. So proximal small bowel inflammation in a similar kind of patient where colonoscopy and ileoscopy was normal. So what would be your next investigation of choice? And I would like to Dr. Chalapati to address pros and cons of each modality. We have now that our power spiral is in the back in the cupboard. So we have these options.
Yeah. So at least before going to that, we would consider a cross-sectional imaging, at least a CT enterography, and that will give us at least a rough idea about the location of the lesion, and that will guide us the route of enteroscopy. If it is too proximal in the jejunum, probably a push enteroscopy would still be good enough. Proximal 30 or 40 centimeter be distal to the DJ flexure or something like that. If there is a stricture, definitely no capsule endoscopy. If it's a proximal bowel involvement, I would go for a balloon enteroscopy. Proximal, at least still single balloon versus double balloon, both are good enough. But if it is a deeper enteroscopy is needed, like proximal ileal or mid ileal, probably I would try from behind, that is retrograde, try to approach. If given a choice, I would now consider a double balloon over single balloon.
So as Dr. Chalapati said, this is a push enteroscopy. Lesion is at 70, 80 centimeters from the jejunum, so we can still manage, and you don't need enteroscope also. In most of the adults, a gentle colonoscopic push enteroscopy is also worthwhile. And video capsule enteroscopy is less used in the West and also here. So it's useless for investigation of abdominal pain. The pickup rate is only 5%, so don't ever do capsule endoscopy for unexplained chronic abdominal pain. Capsule retention is noted to be 1 to 5% in cases where the CT is normal and no previous surgeries. In postoperative cases and previously treated strictures, it can be up to 20%. Imaging-based diagnosis in classical IBD will give a lot of information, provided you exclude NSAID abuse. Although there is a slight differentiation in the capsule appearance of the NSAID and typical Crohn's ones. So in a good capsule study, you can see, this is the normal for postgraduates. So you can see the villus pattern and other things are normal. There is a small after ulcer. There is a peripheral mild erythema and induration. So that is starting early IBD. That can be a non-specific phenomena. It can be seen in aspirin takers and other NSAIDs. And you can see this classical appearance of a small bowel stricture. It is long-standing, as evidenced by the pulse and diverticulum developing over here. So nothing is getting, so intestinal peristaltic force is happening over here. And capsule is trying to get through this stricture. And this is the proximal lesion. And you can see the timing. The stricture is reached at 47 minutes, and at 2 hours still this is here. So what would happen? So as you would expect, the capsule gets stuck. Okay? So a capsule is stuck here, and you see there is a capsule in the pelvic ileum and the CT confirmed. Do we need CT, Chalapati, for investigating this patient? How will it guide us?
I think CT should be done before a capsule rather than
No,
after
no.
capsule.
Before it was done,
Yeah.
there was no significant stricture or dilatation.
Right.
So following the obstructed capsule, do we need CT at all?
So if already a prior CT was done, it may not be needed. But if that is a critical stricture and that needs treatment and that is symptomatic, directly after an abdominal X-ray, probably after 2 weeks, if it is not getting, if it's not coming out, probably attempt to removal should be considered.
So that's fair. Yeah. So we have symptomatic and asymptomatic patients, and the capsule may show that there could be a fibrotic stricture or could be an inflammatory stricture. So what would be the approach in retrieving the capsule after failed medical therapy?
Yeah, so failed medical therapy means at least you give a trial of steroids. Probably if it is an inflammatory stricture, that might get some healing, and that might allow passage of capsule. That is reported in literature. If that is the only stricture or that is the dominant stricture causing symptoms, probably the approach would be directly go in with surgery and remove the excision of the stricture, anastomosis of end to end. If always it's not possible, especially in multifocal diseases. In those who are not having very much of obstructive symptoms, going in with enteroscopy guided removal would be a good choice still. Yeah.
Asymptomatic, non-willing patient, how long would you wait, Rakesh?
No, I think, sir, although Chalapati mentioned 2 weeks, here the problem is the anxiety on the part of the patient and the treating doctor. The patient will start bugging you that, you have done something that has got stuck there. So, in fact, recently last week we had a similar patient, young lady, CT normal, was having chronic abdominal pain. We did a capsule, it got stuck. They were very apprehensive. We were asking them to wait for us some time, but, the husband was insisting that probably it needs to be taken out. So, I would probably do a CT. Unlike Chalapati, I might do it because it will give me an idea where exactly my capsule is stuck. We did a plain CT, we got to know it's in the distal ileum. So we were able to plan a retrograde approach first. So that sometimes aids us in trying to reach the capsule faster. And once we entered, we found multiple strictures. So we had to dilate and finally retrieve it. So I may not wait for 2 weeks probably.
Yeah. So Pawan may disagree that saying that a capsule got stuck and there is a chronic stricture. what are you going to achieve by retrieving endoscopically? So what type of surgery would you like to do?
So we'll go ahead with the diagnostic laparoscopy first and try to identify where exactly the capsule is stuck. So once we identify that, we usually make a small laparotomy and bring the bowel. And what we want to see is like whether it is a short stricture or a long stricture, and multiple strictures are there, whether they are proximal or distal to the capsule. So that is what matters for us, because apparently in this particular patient, she is like vaguely symptomatic. She has like early SIO kind of symptoms. So whether to go aggressively and do a resection anastomosis, or do a simple stricturoplasty, or do enterotomy at a different place and remove it safely and then suture it and then go for medical treatment so that the inflammation comes down, and then hoping that the strictures will release.
And also it depends on the number of strictures, isn't it? And whether they are on the treatment.
Yes.
Okay. Moving on, case 2, young adult male, altered bowel habits for a few months and he is anemic. Recurrent postprandial lower abdominal pain was there. There was a weight loss, significant weight loss. Colonoscopy showed aphthous ulcers in the terminal ileum. So this is the classical aphthous ulcer as we have seen in the earlier capsule image. So capsule image and endoscopy image matches. You can see that. And CT enterography showed mid-ileal stricture. So I'm overlapping 2 cases here. So the top one is a young adult who has a multifocal disease. There is a pinch over there, and there is a thickening in the proximal ileum, and there is a pelvic ileal stricture. And this is a boy who is 9-year-old and who got a long, tight stricture, only single lesion in the mid-ileum. So how would you investigate this case further? Splitting the 2. This is for Partha. So these are the young male and a child with a mid-ileal disease. What should be the role of next investigation to reach there?
So if there's a mid-ileal stricture that is seen on the cross-sectional imaging, and the patient has come for the first time, we need to establish a diagnosis, most probably do a retrograde enteroscopy either by a single balloon or double balloon, and establish the diagnosis. And if most of the cases, that will give the histological diagnosis of Crohn's. And if it is not a critical stricture, then we may continue with medical therapy. And still, if you are not able to go to the stricture, and if it is not reachable, which is sometimes the case in distal jejunal or proximal ileal stricture, which are very deep, in those cases, diagnostic lab along with the intra-op enteroscopy may help.
Would you consider a PET scan for that young boy? Mainly to think about lymphoma?
If there is clinical suspicion, then otherwise, if there is radiological sign is showing some this aneurysmal dilatation, all those features which can support a diagnosis of lymphoma, then only, otherwise, no.
So the first patient had a, The first patient had a retrograde double balloon enteroscopy, and as you can see that there's a beautiful picture showing indurated, ulcerated, edematous mucosa causing inflammatory, classical inflammatory stricture, and same photographs are captured at 2 different levels, and that's how beautiful the double balloon enteroscopy can give you the diagnosis, simultaneously ruling out other things like lymphoma. So this is to Pawan. So the younger chap, we couldn't reach there, and he was too thin, and ileum was normal. So we had to do the lap, and then on the lap, what are we going to focus and how are we going to get histology here?
So what we naturally see in diagnostic laparoscopy is the overall thickening. We'll try to identify that segment, and then we'll look at the fat creeping onto the bowel wall.
This is what Pawan is talking about?
Yeah. So there is some amount of fat creeping there, and there is increased vascularity as well. So it looks very red and angry. So all these things we commonly see in Crohn's disease. Looking at the imaging, I don't think there is a complete compromise on the lumen. So it's still patent, though there is thickening of the bowel lobe. So maybe I'll just take a biopsy and come out. I won't do much.
You do just a wedge biopsy and suture it off, and
we can suture it with again, hoping that it will heal, because these things, even if we take a full thickness biopsy, it's very unlikely that they'll heal. They're very bad. It's a very bad disease to take a simple biopsy also.
Yeah. So nodal sampling also. Yes. And what is the role of contrast enhanced laparoscopy images? Will it differentiate IBD from other things?
I'm not aware of any such thing.
Partha, have you had any experience in that?
No. No. We are not doing it routinely at least. So it will only give the increased vascularity and maybe some tortuosity, increased tortuosity in the vessels. Nothing much. I don't think it will establish a diagnosis at least. It will give more information, indirect information.
Only thing additionally I could do is a intraoperative enteroscopy, which may show me the how tight is the stricture. Sometimes it is on the mucosal side and may still be a critical stricture.
It's a pretty long one, 12 centimeter, 12 to 14 centimeter long one.
That may help sometimes.
Sir, given the classical findings that you are mentioning and with the chance of biopsy causing trouble, so do you feel that your findings are enough to conclude the diagnosis and start the treatment for him? Or should we go back again and get a segmental biopsy from the other areas?
Usually we don't see this fat creeping in any other disease. So I can comfortably say it's pathognomic for Crohn's disease at least. But again, if you want to go for biologicals where there is a lot of morbidity associated with even with medical treatment, I think it's better to have a diagnosis, histological diagnosis, so that it's easy for us to counsel the patient.
We have done the biopsy and small sample biopsy and then lymph nodal biopsy to exclude the TB, and you have started on biologicals responding well. For the postgraduate, this is the equivalent of the honeycomb sign on the CT films. So moving on, next case, 60-year-old lady, recurrent abdominal pain, who had weight loss. She was anemic and CRP was high. She had altered bowel habits occasionally and recent onset distension of the abdomen. She is in her mid-60s and CT showed multiple skip lesions, not causing any obstruction in the small bowel, but she had a dilated cecum. So colonoscopy showed single ascending colon stricture. So this one, we found this stricture over here, and then scope could not go through. So we did a CRE balloon dilatation, and then this is on the follow-up on treatment, and she responded pretty well. And colonic strictures, single strictures tend to respond reasonably well for the balloon dilatations, and this used to be the only modality available in the past. And any other endoscopic methods for refractory strictures, Partha?
So we know that the main problem with endoscopic balloon dilatation is the recurrence, which can occur in up to 50% of cases, and up to 2/3 of the patient will require a redilatation or a surgery. So that is a problem. So recently we have seen that we can.
So I put your slide over there. So Partha is part of this stricturoplasty study. So you can explain.
So another method that recently been used is endoscopic stricturotomy, in which you make radial incisions around the stricture, and in between you can cut circumferentially the fibrotic tissue as well. And in this manner, it has been shown in retrospective studies that it is better than endoscopic balloon dilatation in terms of long-term efficacy as well as surgery-free survival.
What is the perforation risk here?
Perforation risk is lesser than endoscopic balloon dilatation. However, bleeding requiring transfusion can be there in up to 10% cases. The bleeding is the main concern rather than perforation. And in our experience, because we were initially little conscious about doing it, so initially what we did, we combined with endoscopic balloon dilatation as well. We cut the stricture, and if you are not very comfortable in going very deep, we did endoscopic balloon dilation followed by this, which is we named as the hybrid method. Or in some cases, we did in multiple sessions, like multiple balloon dilation, graded dilatation, we did graded endoscopic stricturotomies. Like in the lower panel, we did 3 times in 3 sessions. For 2
But each time, how many areas you would incise, 2 or 3? Or only 1?
Usually 4 areas.
4
areas.
areas.
Quadrants, maybe multiple also, because we don't go very deep, try to dissect very slowly, so that because once there is bleed, it is very difficult to control in the fibrotic area. Usually the only performed stricturotomy in the rectum and the IC valve area. In the right colon is very high risk because of the thin colon. So in the rectum and this one, and also for the pyloroduodenal, proximally in the pylorus is the good area. Esophagus should not, esophagus and the esophagus is the most dangerous area because perforation can cause mediastinitis. Duodenum is also very risky. So they have actually divided the zones into red zones. Esophagus and duodenum is the red zone, ileum, this ileocecal junction and rectum are the green zones, whereas small bowel and anal canal are the yellow zones because there may be substantial morbidity associated with that.
So fortunately, IBD doesn't involve upper GI tract that much, so we are okay with that. So then case 4, moving on, 50-year-old male, previous jejunal resection he had 10 years ago, and he had a duodenojejunal anastomosis, which is specific to India. The West, they don't do that. Active ileal disease and on biological therapy on and off. For 4 years he was on biologicals and off treatment for 2 years, and then he developed a new small bowel disease. He was getting recurrent infrequent abdominal pain. MR enterography showed distal ileal strictures with dilated segment and SIBO symptoms. So this is a good MRI picture showing 2 strictures together here in the segment, one there and one here with a sump in the center, same thing highlighted over there. So this gentleman was already on biologicals and he had one surgery in the past. He was reluctant to have surgery. So we did one attempt at dilatation of the proximal distal stricture with balloon dilatation successfully. He was asymptomatic for 6-7 months and we couldn't dilate the other one. But sometimes for the postgraduates, small bowel dilatation, since the wire, we need to see where the wire is going, always take the fluoro help so that the wire is not making a false passage and you are not perforating the bowel. Now he comes back with this one and is getting admitted frequently with this tight stricture. I think I must have converted the 2 strictures into one long stricture now, and he doesn't have any disease anywhere else. So,
did you take biopsy, sir?
Yeah. So small bowel strictures, Partha, as you know, can be inflammatory, they can be mixed, or purely fibrotic, and single versus multiple, and some will have bowel obstruction, others may not have bowel obstruction. What is your approach in dealing with these strictures?
So initially, whenever a patient comes, I go to the clinical history of the patients. The patient, if they are having a fistulizing disease or is anti-TNF experience like this, they have a high risk of recurrence in the future, as well as if they are having very high biomarkers, inflammatory markers like fecal calprotectin and CRP. Then I go for the imaging, cross-sectional imaging, like in this case it was done, and see the number of strictures. If the number of strictures are more than 4 and the length is more than 4 centimeters, or it is or there is pre-stenotic dilatation that is more than 5 centimeters. These are the cases.
You want to take the help of your upcoming?
That's okay, sir. So
this one?
Yeah. So in radiology, pre-stenotic dilatation, location, length, and number of strictures. If the location is already known, we are discussing about small bowel. Pre-stenotic dilatation, if it is more than 5 centimeters and more than 4 strictures. Although if it is technically feasible, you can go for more, but this is fine. There is a Bacardi risk score for ileal stricturing Crohn's disease, which is involving B3 disease, anti-TNF exposure. This case is not a B3 disease because there is no fistula. Anti-TNF exposure is there. We are not testing for the CARD2-not15 gene, but pre-stenotic dilatation, which does not seem like more than 5 centimeters in this case. Inflammatory marker most probably will be high only in this case. So if this score is more than 4 to 6, then directly surgery should be done. If it is 0 to 3, then medical therapy can be tried. For small bowel strictures, usually endoscopic balloon dilation is the preferred choice. Although there are 2 series, one from China and from another from US from the Boschen series, they have shown that endoscopic stricturotomy with double balloon enteroscope or a single balloon enteroscope with a hook knife or a IT knife. But this is only 2 studies. So and also they are comparing this balloon dilatation with stricturotomy in a trial called the distress trial. So until the trial results are out, only option is to do an endoscopic balloon dilatation, and this is only 2 strictures are there. So you can go for it, but this patient has few high risk factors like anti-TNF exposure and high inflammatory markers. So we have to take a call when to stop. If it is
so
recurring
who do
time.
quicker, you or Pawan, the stricturoplasty?
No, I mean, considering the disease, whatever he wants to do, let him do, sir. Because I will only enter when there is a complication. I would prefer that because we all know how it's going to be once we put a knife on the patient. So if we can decrease the morbidity as long as possible with minimal intervention, I think that should be the way forward in this disease at least. So my role will come when endoscopy will fails or when there is complications of endoscopy, then I'm okay to take that.
I think I should refer you before complications occur and anticipate which patients are not going to respond. Like if they're having high-risk features, we should recognize beforehand. And suppose the patient is having a deep ileal, deep stricture, like a deep distal jejunal and proximal ileal stricture. Reaching that stricture every time is very difficult always. So dilating every time will not be possible. If it's a proximal jejunal stricture or a distal ileal stricture, I would go for maybe more times.
So moving on, case 5, perianal Crohn's. So unlike the other parts of the small intestine, which responds fantastic with biological therapy and good responders, even in them, the perianal disease lags behind. Before each infusion, they have a flare-up of perianal symptoms, and if that is a very active component of their this Crohn's disease, then they end up with strictures and perianal persistent or recurrent fistulae. So what would be the surgical approach in such cases if they come with repeated perianal abscess or fistulae in between the infusions and also with the stenosis? This to Pawan.
So it's always going to be drainage whenever the patient is having a perianal infection, abscess formation. Because when we give biologicals, they tend to spread very easily and the patient tends to become very sick. So it's better to drainage whenever it's required before starting any biologicals. Second thing is fistula. We don't do a normal fistulectomy or fistulotomy in these patients because that will only worsen the disease. So we prefer something called set-on placement. We put a set-on and tighten it over time if there is no infection. But if there is an active infection, we try to put a draining set-on rather than a cutting set-on. So our decision of set-on placement, type of set-on also depends upon whether there is an active infection in that area or not.
And how long would you like to keep them for? Because patients are reluctant to have them because they have pain on moving and they can't sit and they can't travel. So how long would you like to keep them?
So again, choice of material when we put set-on is very important. We usually put vascular loops. They're very soft silicone wires kind of thing. So they're very soft. They're usually tolerable. As long as it is required, I think it should be placed.
Okay. And Partha, any role for endoscopic management? You have been involved in some new...
So here two things were there. One was a stricture and another one was a fistula.
Yeah.
So for stricture, you can do a balloon dilatation. Sometimes the patient can self-dilate also sometimes because that is necessary before you treat the fistula because stricture has to be treated first. And also Boshen's group have reported stricturotomy in the anal strictures as well, but you have to be very careful because the sphincters, there may be incontinence. And additionally, if there is because this anal fistula, they are usually very short and superficial fistulas. So sometimes you can blindly pass the guide wire from the external opening and grab it from the inside by the biopsy forceps and then railroad the vascular loop or the set-on over it and can endoscopically put that. This is for the simple superficial fistulas. And usually it is difficult for complex fistula because it is tortuous and it is usually not feasible. But we have reported in one case in which the external opening was large, more than 5 millimeters. So we could go with an ultra thin endoscope and could see the internal opening and push the guide wire under endoscopic guidance and then could put the set-on. So these two options are there.
Okay.
And specifically in patients who have earlier undergone a surgical set-on, in them already the tract will be there. You can directly put the set-on endoscopically only.
What are the chances of you creating a false tract?
Don't push very hard. If I'm not able to do it, then I leave it because the technical success we reported as 60% only. So not very high.
Moving on, case 6, 45-year-old male, 20-year history of ulcerative colitis, pancolitis. He also had protein 3 deficiency and was on long-term anticoagulants. He had intermittent PR bleeding, regular abdominal distension, and painful defecation. He survived COVID because he had stopped his anticoagulation, unfortunately, and had a COVID with complete mesenteric thrombosis and survived that episode on anticoagulation. His colonoscopy showed multiple pseudopolyps only in sigmoid, with the rest of the colon was in quiescent colitis with luminal obstruction on follow-up. Initial biopsies showed pseudopolyps. There was no dysplasia at that time. So, addressing this issue of long surveillance findings in colonoscopy, on colonoscopy in long-standing UC, Rakesh, what is the best way of doing surveillance colonoscopy? Is chromoendoscopy still used routinely, or NBI, we are very much experienced with NBI, saves time, saves the floor, no staining. So what is the current status?
I think, sir, if we all remember the 2015, the scenic consensus that was published, surveillance for the colorectal malignancies in the IBD patients. So when it came up in 2015, the chromoendoscopy was compared with the standard colonoscopy, and definitely they found it to be very useful entity when it comes to characterizing these lesions. But unfortunately, as you know, chromoendoscopy can make your endoscopy room quite messy, and it needs you to be, takes longer procedure time. So it's not always easy to get a chromoendoscopy done, and luckily in the last 10 years, we have started getting the high definition colonoscopy with the virtual chromoscope that is in the NBI. So I think that has really helped us. And if you look at the recent consensus also, they are mentioning that, the NBI is not inferior to chromoendoscopy when it comes to doing surveillance for these lesions.
And do all DOM lesions look same for the postgraduates? By the way, this is adenoma in a normal colon, and this is a polyp in the quiescent colitis patient. So one need to differentiate these two. Yeah. So question, how are all DOMs look same, or they are difficult to diagnose?
I think this is the ambiguity, that inter-observer difference. This has led to, relegation of these terms now, sir. I think the scenic 2015, they relegated these terms, and we try to use the conventional Paris classification that we use for our regular polyps. As you have shown in your previous slide, the one on the left was the normal polyp where the surrounding mucosa is not inflamed. Whereas the one on the right, you can see that the polyp has got a significant inflammation. So what they are saying now is that just use the same Paris classification. When you see a lesion, just classify whether it's polypoid or non-polypoid. If it is polypoid, is it pedunculated or sessile? And if it is not a non-polypoid lesion, just describe whether it is elevated, flat, or depressed. And of course, we have to mention whether there is any ulceration and a comment on the surrounding inflammation.
For the postgraduates, you have to always take the biopsies from the surrounding of the polyp to make sure that there is a generalized. So this is the same guy who had the intestinal obstruction because of the bunch of pseudopolyps, and we had to do the debulking EMR to buy some time because it was only 4 weeks since his complete mesenteric obstruction. We were a bit worried about this one area which was looking slightly different from these areas. So when do you consider EMR ESG in these DALM lesions? And how is it different to normal colon EMR ESDs? What are the practical issues, Rakesh?
I think, sir, if you are having a simple polypoid lesion, probably a simple polypectomy would serve the purpose. But if you are having a lesion that's more than 1 centimeter and less than 20 mm, probably a EMR, just elevate the lesion and just cut across. But if you are having a lesion that's more than 20 mm, and if it is sessile to flat, I think that's where the ESD comes into the picture. But the only challenge is that unlike the regular ESDs that we do here, we are seeing a case where there has been a lot of inflammation background. So definitely we are going to expect a lot of submucosal fibrosis that will definitely hinder our ESD procedure in a big way. So I think that's a big practical issue there, sir.
And also the incomplete excision. Yeah. So this same patient came after we wanted to wait for 8 weeks because there was no cancer. So this is the appearance of that rectosigmoid junction where there is a ill-defined DALM with no deep boundaries. It is not a well-demarcated lesion, and there is a slight exophytic areas also coming. So we were obviously worried, and then this is a PET scan on the same patient. So on the PET scan, you can see that it is lighting up nicely, and then it is very, very suggestive of underlying early malignancy. So question to Pawan, role of surgery in this DALM and dysplasia at other parts of the colon, and what would be your preferred surgery, and what is the recommendation, and which is ideal, subtotal or pouch, based on the age of the patient also?
In this particular patient, what we have seen is there is a DALM which is identified, and by literature, more than 50% of the DALMs have malignancy, carcinoma. So we treat it like any other malignancy. We want to do an extensive resection, like because we have to take care of the lymph nodes also in these patients. So considering 20-year history in this patient, the chance of him getting another malignancy at another site is very likely. He'll fall into that high-risk group where we have to do regular surveillance in these patients. So I'll give the option to the patient whether he wants to get a total proctocolectomy, with a ileorectal anastomosis if rectum is spared, or if rectum is not also involved, then we will go for a ileal pouch channel anastomosis. That will be ideal thing.
So those are the three types of pouches. For the postgraduates, the pouch will have higher output and stool frequency. That should be explained to them. So, and moving on quickly, young adult male presented with itching and jaundice. MRCP showed PSC features, as you can see it in this picture, with beaded bile ducts and slightly dilated IHBRD. So, Rakesh, is colonoscopy must in these cases? And how does the colitis differ in presentation?
Sir, before I could answer that, I just wanted to add one point to your previous case. I mean, as we are mentioning, and you do a lot of ESD, so unlike the regular ESD, these subsets are very different. So whenever you are doing it, you have to plan it in proper. If the biopsy picks up a dysplasia, I think we need to always check it with the second pathologist. If it is high grade to carcinoma in situ, which most of the time happens, I think we need to defer it to the surgical side. And if we end up doing a good ESD or EMR, I think we should always tattoo that area, so that when we come back for a second scope 6 months later, we should be in a position to know where it was done, so we can pick up the activity.
This DDW, actually, there was a nice study from Japan. They showed that after submucosal injection, if they measured with the submucosal cushion thickness with the endoscopic ultrasound, if it is more than 2 millimeter, that was the lesions that are feasible for ESD. And if it is a submucosal lift is less than, cushion is less than 2 millimeter, then those cases are ineligible for ESD. Maybe we can apply that.
And the other point probably is that even if you are contemplating in ESD, it has been shown in literature that the risk of fibrosis in the submucosa is as high as 60 to 90%. So it's always wise to simply convert your procedure to hybrid. I mean, start doing the ESD. If you encounter too much of fibrosis, no harm in trying to go into hybrid ESD. In that way, probably you can save the time and also probably prevent complications.
Patient will be more convinced about surgery in future. So coming back to this case, so for the benefit of postgraduates, a case of PSC, should we always look for colitis? And how does the colitis differ? And when do we do liver biopsy?
Yeah, I think if my numbers are right in the literature, probably any patient of PSC, the chances of him having UC is as high as 75%. That is 4 out of 4 PSC patients, 3 of them do have a concurrent UC running. But if you look at the natural history of their UC, it has been found in the literature that most of the time it is mild or asymptomatic, although the colonoscopy shows pancolitis and there is significant backlash highlightis, but still they are not that symptomatic. So for that reason, if we have a PSC patient, probably it's wise that we always do an index colonoscopy to stratify the colon.
And do they have the increased colon cancer risk?
Yeah, definitely, because what the literature says is that because they have pancolitis, yet they do not manifest, the chances of them subclinically progressing to CRC is quite high. That has been
so
mentioned.
For the benefit of postgraduates, they should be treated with Arsacol, which reduces the colon cancer risk, not the cholangiocarcinoma risk. So this is another case of PSC quickly. So this is a severe form with severe itching and abnormal LFTs. And in this, we may need to intervene. So what is your approach for management in this one? When do you consider EUS? When do you do ERCP?
I think, sir, if the plan is to look for the diagnosis, if it's an indeterminate biliary stricture that you're trying to confirm the diagnosis, I think a good MRCP should actually give us the answer with the serological markers, and an MRCP should conclude. And especially if you have a background UC, I think MRCP and serological markers should do it. But if it's not, then probably ERCP plus or minus pi might give us an answer.
So this is a case by missing panelist Sharath. Other day, so 66-year-old female with known PSC, CA 19-9 came as 2,562, suggesting there is something going on there. and he had done the ERCP and then took the biliary brushings, which are showing atypical cells suggestive of cholangiocarcinoma development in this particular case. So now that we have spyglass cholangioscopy, that could be another way of getting the tissue if it is in the intrahepatic portion of the duct, because the brushings yield very poorly. So finishing off in a couple of other cases, young male, first presentation with small bowel obstruction, underwent right hemicolectomy with ileal segment resection. He had weight loss and serous discharge from the drain site 3 weeks after the hemicolectomy. Before we could start him on biologicals, we were just waiting for him to recover. You can see that MR fistulogram was showing enterocutaneous fistula. At the same simultaneously, dye was also reaching to rectum without feeling any descending colon and all. So he has a enterocutaneous and colocolic fistula. So we went in and we did a colonoscopy, and you can see this is a rectosigmoid junction where that's the only abnormal area juxtaposed with probably that segment, and that is the appearance of perianastomotic fistulating site, and that is anastomosis still inflamed and edematous, allowing the scope to go through, but we could not see any big hole to close it. So Partha, who should be considered for endoscopic fistula closure? This case, last case, we decided not to do anything and start the biologicals, and is being monitored. But who should be considered for a fistula closure, and what options do we have?
So usually if the fistula is between a symptomatic or asymptomatic fistula, we have to see. If the patient is asymptomatic, sometimes the patient may respond to the medical therapy as well sometimes. And if the patient is symptomatic, like in the sometimes the patient may have a bowel to vesicle fistula or a vaginal fistula. In that patient, those patients are symptomatic. In those cases, you may attempt the closure of the internal opening by using usually a through the scope clip. Usually don't use the over the scope clip, because the septum is very thin and it may actually cause more harm than a benefit. So in my experience, I have only closed one fistula, which was between sigmoid and this bladder, and he was already on adalimumab, which he stopped in between. We restarted and then closed with the through the scope clip, and he was better. It was a very small fistula, so in those cases maybe. But
so Pawan, this patient presented first time with intestinal obstruction, required resection. Given that he was very sick and lost weight and he was malnourished and he underwent surgery, would you have considered diversion, ileostomy, loop ileostomy at that time to prevent this complication?
Definitely, sir. Because that loop ileostomy will give some time for us to, for the anastomosis to heal. And again, what bothers me every time is what will happen when I close the ileostomy itself. So that is one question I'm not able to answer.
But he was not, he's a bio-naive patient.
Yeah.
We haven't started any medical therapy, so
yes,
you probably...
We can optimize him medically, then maybe after some time, not like routine after 2 months or something, but we can take him at a later date, whenever he's medically optimized.
So this is Kiran's patient who had long-standing IBD, and he met with an accident and ruptured his colon. He underwent surgery, but in the recovery period, he developed suture line sinus to start with, and then fistula draining fecal matter. So Kiran went and endoclipped from internally, but then second picture shows that the thing has not healed, and he had continuous daily discharge. So he went ahead and did a simultaneous clipping and the glue injection into the fistula tract, and that seems to be slowed down, and it is started to show some signs of healing. And so these are the other options we have for fistula. Biological also.
The patient actually started on biologics first, and then it was not healing, it partially healed. So then I went in and put the clips from inside, and the tiny opening, we tried to glue it. Okay. But he continues to have a mild discharge, and despite taking 10 biologic injections now. Okay. So any other options in this patient? What else would you do? Surgeon obviously not happy to touch because he had stomy course post-operatively, so we can't have surgery. So interestingly, he had diversion ileostomy, and before the closure, as Pavan said, my surgeon wanted me to do colonoscopy. Colonoscopy was absolutely fine, normal colonoscopy. 4 weeks after we gave a consent, 4 weeks after reversal, he started developing this. So that's what unexpected series 5 events actually.
So even though it looks normal on a colonoscopy, sir, these patients, they are not going to heal well. So we always take it with a pinch of salt. We always have in the back of the mind that these cases are not going to heal well.
But
So
at
we
this
have
stage,
to be
I mean,
prepared
any other
for all
options
these
we
things.
have, because he's still having infliximab infusions, and endoscopically also been attempted. Anything else we can do? Any other inputs from audience? Sorry?
Stem cells. Stem cells are the
Yeah.
Stem cell local infiltration.
How much would cost stem cell?
That is very high.
Yeah.
Okay. One worry I always had was if you close on both sides, the middle part will track into another area, causing interloop or fistula. So small bowel stricture, role of stenting, there is some data coming. So the Chalapati, what is the pros and cons of these difficult to reach areas, and stent deployment also can be challenging, and then technical difficulties and late complications.
So basically it can't be a permanent option, right? And at some point it has to be removed, and preferably a fully covered SEMS. So as it was shown in one of the previous slides, usually it's a, if it's a short anastomotic stricture, you can always consider a lumen opposing metal stents. Or if it's a long stricture, fully covered SEMS, and short stricture, you can always consider a partially covered. But whatever you keep, actually, it gives good results, especially in refractory strictures. But the technical thing is you should always go inside, reach the deeper, into the small bowel. You have to keep on exchanging with stents. But it is shown that it is better than, probably better than balloon dilatation in long-term patency. But it is complicated by post-op patency and sometimes impaction also. Sometimes there can be migration also. But most importantly, post-operative pain is the worrisome symptom.
And then this is the data you kindly sent it, which shows 11 studies. Technical success rate was around 95%. And can you please take us through the slide, please?
Yeah, so this is a meta-analysis just published last year. So overall long-term efficacy is 56%. Technically, you can be successful in around 95%. Short-term, it is 100%. So around 25% still require surgery. But if you have left these stents for a longer term, then probably the success rate would be higher. But again, the issue of removability and all these things will come. Yeah.
What is the ideal time we should keep it if it is a short stricture?
I think at least for 7 to 2 weeks. I mean, like 1 to 2 weeks.
Okay, okay. The complication rate seems to be unacceptable, isn't it?
So can I have a comment, sir? Here?
Yeah, sure.
Sir, the main problem is with these stents are the high risk of migration up to 44% according to the meta-analysis. So migration rates are very high, and one randomized control trial between endoscopic balloon dilatation and this one has done, that is published 2 years back, this is known as the PRODILATE study, which showed that the stents have very high reintervention rate because of the pain, as well as second problem is the migration. So that's why it is only should be considered as in refractory strictures, not as a primary therapy.
Okay, thank you. So small, just for completion's sake, we included small bowel bleeds. They are fortunately rare in IBD patients because it's a chronic inflammation. There will be thrombosis and ectasia of the vessels. They are not going to be penetrative. And usually they bleed if they are on anticoagulation, or they are NSAID abusers, or sometimes CMV infection in the right side. So which modality would be more effective? This for all the panel members. Would you go for endoscopic management or IR intervention if you have a major small bowel bleed in a non-IBD patient? Very rare, but.
I think I will probably look at the clinical scenario, sir. If I have a patient who is exsanguinating, hemodynamically unstable, I might ask my IR guy to probably jump in first. But if I have a patient where he's bleeding for some time, he's very much stable, I might probably go with an endoscopic intervention, try to reach the area and probably curtail the bleed. That would be my approach.
I have encountered 2-3 cases. One was a small bowel Crohn's, which had a recurrent history of anemia. So very fortunately, during the time of enteroscopy, I could find the spurting vessel. So I think those are the cases which it is more useful, and the results were very good. Second, another patient with very severe ulcerative colitis has a visible vessel in which we clipped. Third one was a post-biopsy bleed. post-biopsy severe bleed in a case of Crohn's disease. So these are the cases I had an experience. But most of the cases, usually the bleeds are diffuse, so endoscopic management is not very effective.
Recurrent bleed from the same segment, sometimes leaving a clip would be ideal for the radiologist to target that feeder vessels in that segment. So, any closing remarks by the panel members? We thought of including EUS, but I did only one EUS in 15 years to drain the pelvic collection in an IBD patient. So, I asked my colleagues also, they didn't have many cases. So, but that's one modality where we can, if the collection is localized and is bio-naive, instead of doing a, you can have both options, ultrasound guided or this one, and then continue them on the medical therapy. Thank you all for your patience, audience, and thank you for the panelists. And we finished on time for the dinner.
Thank you, sir. You covered it very comprehensively. We conclude the session with this. I invite all the chairpersons on the dais. Dr. Pawan, Dr. Rakesh, Dr. Chalpati, Dr. Partha, please come on to the dais. Dr. Santosh will hand over mementos to all the chairpersons. Dr. Pawan, please remain. Dr. Partha, please hand over memento to Dr. Santosh. Thank you.
Good evening, ma'am. Good evening, everyone. As we all realized, we had an excellent academic feast since morning. Good evening, everyone. As we all realized, we had an excellent academic feast since morning. And so I hope all you have gained knowledge and knowledge in the today's academic sessions. And I request all of you to come tomorrow morning at 8:45 a.m. and enjoy the academic program. We'll request all of you, all of you to join us for dinner. Join.